بسم الله الرحمن الرحيم. من بين طليعة المجد والولاء وعلى حد البداية ولا حدود للانتهاء، وما بين الباء والنون بحرين، نشق طريقنا بها نحو السمو والرفعة، في ظل وعي ودراية وقيادة حكيمة تعطي الوطن مكاناً في آفاق الأمجاد دوماً ودائماً. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، سعادة الأستاذة لولو بنت صالح العوضي الأمين العام للمجلس الأعلى للمرأة، سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة، أصحاب المعالي والسعادة، السيدات والسادة، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. أسعدتم صباحاً وأهلاً وسهلاً بكم في مؤتمر البحرين للسكري والسمنة. تحت قبة واحدة شرفتم عيناً ونزلتم قلباً. ملتقى ومؤتمر علمي يؤكد مكانة مملكة البحرين في احتضان المؤتمرات الكبرى وريادتها في القطاع الطبي، وكل ذلك نتيجة للرعاية السامية التي يحظى بها هذا القطاع من لدن حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك مملكة البحرين المعظم حفظه الله ورعاه، والاهتمام والمساندة من صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء حفظه الله. يسودنا الفخر والاعتزاز بأن يحظى هذا المؤتمر برعاية كريمة من لدن صاحبة السمو الملكي الأميرة سبيكة بنت إبراهيم آل خليفة قرينة ملك مملكة البحرين المعظم رئيسة المجلس الأعلى للمرأة، الداعمة للمرأة البحرينية، ونجني ثمار هذا الدعم والرعاية بحصد العديد من الإنجازات للمرأة البحرينية التي أصبحت علامة فارقة ومثالاً يحتذى به. وخير ما نستهل به حفلنا هذا آيات عطرة من القرآن الكريم يقرأها على مسامعنا محمد حمد صالح من الخدمات الطبية الملكية.
أعوذ بالله من الشيطان الرجيم. وضرب لنا مثلا ونسي خلقه قال من يحيي العظام وهي رميم قل يحييها الذي أنشأها أول مرة وهو بكل خلق عليم. الذي جعل لكم من الشجر الأخضر نارا فإذا أنتم منه توقدون. أوليس الذي خلق السماوات والأرض بقادر على أن يخلق مثلهم بلى وهو الخلاق العليم. إنما أمره إذا أراد شيئا أن يقول له كن فيكون. فسبحان الذي بيده ملكوت كل شيء وإليه ترجعون. صدق الله العظيم.
صدق الله العظيم. حضورنا الكريم، نرحب الآن بمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة، رئيس المجلس الأعلى للصحة، رئيس مجلس إدارة جمعية السكري البحرينية، لإلقاء كلمة بهذه المناسبة.
بسم الله الرحمن الرحيم، والصلاة والسلام على أكرم المرسلين. الدكتورة جليل السيد وزير الصحة، الحضور الكرام، السلام عليكم ورحمة الله وبركاته. إنه لمن دواعي السرور أن نجتمع اليوم تحت قبة واحدة عنوانها العلم والمعرفة وجني ثمار المساعي الطيبة التي تقدمها لنا القيادة الحكيمة حفظها الله ورعاها بقيادة حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المعظم حفظه الله ورعاه، ورعاية جلالته الدائمة للقطاع الطبي الذي يعتبر واجهة حقيقية لإشراقة المملكة وتأكيد مكانتها المرموقة على المستوى العالمي في ظل الجهود المباركة للحكومة الموقرة برئاسة صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء حفظه الله، وقيادة سموه لفريق البحرين في شتى المحافل خصوصا القطاع الطبي. إننا نعتز ونفتخر أن يكون هذا التجمع الكبير في مؤتمر السكري والسمنة بأن يحظى برعاية كريمة ومباركة من صاحبة السمو الملكي الأميرة سبيتشة بنت إبراهيم آل خليفة قرينة ملك البلاد المعظم رئيسة المجلس الأعلى للمرأة حفظها الله ورعاها، ونقدم جل شكرنا وتقديرنا لسموها على دعمها الحثيث لهذا المؤتمر وسعيها الحثيث لارتقاء المرأة البحرينية التي ضربت أروع الأمثلة في الإخلاص والتفاني خصوصا في القطاع الطبي، حيث أننا نملك كوادر لها باع طويل وقدمت الغالي والنفيس في خدمة المملكة. الأخوة والأخوات الكرام، إن هذا المؤتمر له طابع خاص في العام الحالي، لا سيما أنه يتزامن مع احتفالات المملكة باليوبيل الفضي لتولي حضرة صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك البلاد المعظم حفظه الله ورعاه مقاليد الحكم، ويأتي تأكيدا للجهود المخلصة التي يبذلها المجلس الأعلى للمرأة للرقي بالخدمات المقدمة لأفراد المجتمع عامة والمرأة خاصة، ولدوره البارز في تفعيل الشراكة المجتمعية للارتقاء بالوطن وتحقيق التوافق والنجاح للمؤتمر في ظل التركيز بشكل خاص على صحة المرأة، حيث نثمن ونفتخر بالدعم والرعاية التي تقدمها سمو الأميرة قرينة الملك البلاد المعظم حفظه الله ورعاها للقطاع الطبي بشكل عام والمرأة البحرينية بشكل خاص. علاوة على ذلك، الجميع يعلم بأن شهر نوفمبر مخصص للتوعية حول داء السكري، ومن هذا المنطلق حرصنا أن يكون هذا العام تحت شعار السكري وجودة الحياة، ولنبحر جميعا نحو المزيد من الآفاق والتباحث نحو مستقبل أكثر إشراقا للقطاع الطبي بشكل عام والسكري والمرأة بشكل خاص، ليكون هذا المؤتمر ملتقى علمي يرتقي بالخدمات الصحية والتثقيف الصحي لجميع المهتمين في المملكة وخارجها. والسلام عليكم ورحمة الله وبركاته.
شكرا لمعالي الشيخ محمد بن عبد الله آل خليفة الذي ادخر وقته للعلم والتميز في شتى الميادين حتى أصبح من أعلام هذه الأرض الطيبة والداعم لمثل هذه التجمعات الطبية التي تساهم في رقي البحوث وتبادل الخبرات. والآن مع كلمة سعادة الدكتورة حنان بلخي، المدير الإقليمي لشرق المتوسط بمنظمة الصحة العالمية. ومن الجدير بالذكر أنها أول امرأة تشغل هذا المنصب منذ تأسيس منظمة الصحة العالمية قبل 75 عاماً. نشكر حرص الدكتورة على المشاركة برغم مشاغلها العديدة.
Your Excellency, Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, distinguished representatives from the Supreme Council for Women, esteemed guests. I thank Your Excellency for organizing this conference. Its subject is truly vital. The Eastern Mediterranean region has the highest rates of diabetes worldwide. More than 70 million people are affected, and if we do not act now, the number is set to double by 2045. Diabetes leads to cardiovascular disease, blindness, kidney failure, and lower limb amputation. It also increases health care costs and undermines efforts to achieve the Sustainable Development Goals. The economic burden of diabetes in our region is immense. In 2023, it reached nearly 500 billion in international dollars. The pandemic of diabetes is driven by demographic transition, unhealthy diets, tobacco use, and obesity. Women with diabetes, particularly during pregnancy, face particular challenges that impact their health and their children's health. But diabetes is manageable and treatable. Early diagnosis, effective management, and strengthening primary health care are all crucial to prevent complications and improve health outcomes. Unfortunately, many countries in our region are all still not achieving that. WHO is working with them to reduce diabetes risk and ensure equitable, affordable care in line with the Global Diabetes Compact and our regional framework for action. A critical part of that work is tackling diet-related challenges. The Eastern Mediterranean region has some of the highest rates of obesity in the world. We need to fight back by improving food systems, preventing micronutrient deficiencies, promoting child nutrition, creating healthier food environments, and ensuring access to sustainable diets. So I am really pleased that you are prioritizing this issue in Bahrain, and I hope and trust that your discussions will help to drive progress in promoting healthier lifestyles and preventing and controlling diabetes. And let me also take this opportunity to welcome the launch of the Arabic Health Promotion Book on diabetes and pregnancy. It promises to be a valuable resource for many communities across our region. I look forward to working with you to step up action on diabetes and obesity.
الحضور الكرام، تأسست جمعية السكري البحرينية في عام 1989 للميلاد، وانضمت للاتحاد الدولي للسكري International Diabetes Federation في عام 1991 للميلاد. وهذا الانتماء للجمعية حقق فضاء أرحب للتعاون ومشاركة التجارب مع الخبراء في إقليم الشرق الأوسط وشمال إفريقيا بل وفي العالم كله. ونتابع الآن كلمة مسجلة للمدير العام للاتحاد الدولي للسكري البروفيسور بيتر شوارتز، الذي تعذر حضوره للمؤتمر ولكنه أبى إلا أن يشاركنا في هذا الحدث الهام.
Assalamu alaikum. Dear colleagues and friends, dear ladies and gentlemen, dear chairman of the Bahrain Diabetes and Obesity Conference, it's a great honor for me to speak here in the opening of the conference. I'm Peter Schwarz, I'm Professor for Prevention and Care of Diabetes, and I'm the President of the International Diabetes Federation. I would like to very warmly welcome His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, who is the chairman of the Supreme Council of Health. Furthermore, I would like also to welcome all the representatives of the Supreme Council of Women for this meeting here. And again, a very, very warm welcome to anyone who is attending this conference. It is important to discuss, it's important to exchange ideas, because discussing and exchanging ideas is the first step ahead to do actions on improving quality of care for people living with diabetes. This year's theme of the conference is diabetes and well-being, and this is also this year's theme of the World Diabetes Day. And why is this so important? Because well-being in people living with diabetes was ignored in the past very often. We were focusing on glucose, on biomarkers, on management of therapy, but we forgot addressing the need of people with diabetes. For me, as president of the International Diabetes Federation, this is one of my main objectives, addressing the need of people living with diabetes. And well-being is significantly affected by diabetes. If you are asking the patients, 75% say they feel an impact on quality of life and well-being. 80% say they already experience burnout due to diabetes. And again, the burnout is affecting the self-management and diabetes care again. And more than 70% ask actively for support and help in terms of well-being, especially social support, including also us as healthcare professionals and the full diabetes care teams and advocates for diabetes. So it is very important to address this topic, and it's very important to read, exchange ideas, and to educate ourselves. And one of the big achievements in this field is the launch of the Arabic book on diabetes and pregnancy. This is a very, very important book, and that this book exists now in Arabic language is a very important achievement, because this book is exactly addressing what is needed. Understanding the need of people living with diabetes, in this case diabetes and pregnancy, and how to address these needs. So I wish you a very good conference, but mainly I wish you a very good discussion, exchange of ideas, and think about what you can do in your environment in little steps or even in big steps to improve well-being and quality of life of people living with diabetes. Thank you very much for your commitment, your passion, your enthusiasm in this field. Thank you very much, and I'm looking forward to common action together with you. Shukran.
حضورنا الكريم، دعونا نرحب بسعادة الدكتور الموقر محمد صنديد، المدير العام لإقليم شرق المتوسط وشمال أفريقيا للسكري، لإلقاء كلمته بهذه المناسبة.
بسم الله الرحمن الرحيم. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة، رئيس المجلس الأعلى للصحة ورئيس مجلس إدارة جمعية السكري البحرينية، سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة، الفاضلات والأفاضل من المجلس الأعلى للمرأة، رئيس وأعضاء الجمعية البحرينية للسكري، أصحاب السمو والمعالي والسعادة، السيدات والسادة، حضورنا الكرام. كان بودي أن ألقي الضوء على أهمية ودور الاتحاد الدولي للسكري في منطقة المينا، أي منطقتنا التي أرأسها، ولكن لضيق الوقت المخصص أكتفي بما قاله رئيس الاتحاد بروفيسور بيتر شفارتز، ولكني أرى لزاما علي أن أنوه بالدور الكبير الذي بذله الرئيس السابق الراحل المرحوم حسين أخطر، الذي كان له الفضل في احتضان المنطقة ومنها تعريب مواد الاتحاد، ومن بينها كتاب السكري والحمل. وهنا الشكر لجميع من ساهم بإعداده وكتابته. وأخيرا أتمنى لهذا المؤتمر النجاح ولهذا البلد الازدهار والأمان. شكرا.
كل الشكر والتقدير للدكتور محمد صنديد على هذه الكلمة القيمة وعلى دعمه المستمر للقضايا التي تهم المتعايشين مع السكري. ونتشرف أن يستضيف المؤتمر قامات كبيرة من الاتحاد الدولي للسكري من إقليم الشرق الأوسط وشمال أفريقيا، منهم سعادة الدكتورة جاكي معلوف نائب الاتحاد الدولي للسكري، والدكتورة نديمة شقم رئيسة الجمعية الأردنية للعناية بالسكري، والبروفيسور شبين مسعود ماز، والبروفيسور أحمد بلال من باكستان، والدكتورة إباء العزيري من دولة الكويت، والدكتور حسين الصفار من سلطنة عمان، وكوكبة من الخبراء والمختصين من مملكة البحرين يثرون بحضورهم المحتوى العلمي لهذا المؤتمر، فلهم منا كل التحايا والتقدير لجهودهم النبيلة في نشر المعرفة. حضورنا الكريم، لقد عملت اللجنة المنظمة للمؤتمر بالتعاون مع Education Plus منذ شهور طويلة للإعداد لهذا المؤتمر، والآن نصل إلى نقطة الانطلاق بسلسلة قيمة من المحاضرات وورش العمل والأوراق العلمية المتقدمة حول السكري والمرأة. أما الآن فندعوكم لمشاهدة فيديو قصير تم تصميمه خصيصاً ليعكس ما تحظى به الفتاة والمرأة من اهتمام على الصعيد الصحي في مملكة البحرين. ومما يلفت الانتباه في هذا الفيديو الدور الحيوي الذي تشغله النساء في تقديم كافة الخدمات الطبية، فمشاهدة ممتعة.
في يوم المرأة البحرينية وما تحمله هذه المناسبة الوطنية العطرة، فقد أنارت بمصابيح العلم طريق نهضتنا، وحصنت بإرادتها المستقلة سياج وحدتنا، فهي من قرأت وتعلمت وشاركت وصنعت مجد وطنها.
نتوجه للمرأة البحرينية بكثير من التقدير والإعجاب على ما تقدمه من إسهامات مؤثرة، ولما تجتهد بتقديمه من عطاء ممتد ومتجدد نرى شواهده الباهرة في كافة مناحي الحياة.
تولي القيادة الرشيدة في مملكة البحرين اهتماماً بالغاً بالمرأة وتمكينها في شتى المجالات، وخصوصاً في حصولها على أفضل خدمات الرعاية الصحية. أمل ابنة البحرين الحبيبة وبطلة قصة اليوم وكل يوم. تتلقى أمل الرعاية الصحية الشاملة، مما يشمل الفحوصات الدورية والتطعيمات في مراكز الرعاية الصحية الأولية. وها هي أمل تكبر وتحضر مع زوج المستقبل للحصول على فحوصات ما قبل الزواج في مركز الرعاية الصحية الأولية. وتمر الشهور وتعود أمل فرحة بالحمل لتتلقى أفضل الخدمات في المركز الصحي. أمل في مكان عملها وتشعر بأن صحتها ليست على ما يرام، فتلجأ للتقييم في المركز الصحي. تم تشخيص أمل بسكري الحمل، ومن ثم تم تحويلها لعيادات متخصصة في مجمع السلمانية الطبي، مما يعكس التكامل في تقديم الخدمات الصحية بين أقطاب القطاع الصحي في مملكة البحرين. وهنا تجد أمل كل ما تحتاجه من استشارات مع أخصائي التغذية، وتزويدها بالمعرفة اللازمة عبر عيادات مثقفي السكري لتعليمها طريقة حقن الأنسولين وتزويدها بجهاز قياس السكر. أمل مع زوجها في مستشفى من الخدمات الطبية الملكية يتابعون العناية الحثيثة التي يتلقاها وليدهم من في وحدة العناية بحديثي الولادة. إنها أمل، قصة اليوم وكل يوم، التي تسطر البحرين من خلالها مدى الاهتمام الذي توليها المملكة بالعناية بالفتاة والمرأة في جميع مراحل حياتها، عبر تقديم أفضل الخدمات الصحية التي تضاهي المعايير الدولية، إيمانا واعتزازا بأهمية صحة المرأة التي هي أمان للوطن وأمله للمستقبل المشرق.
أصحاب المعالي والسعادة، السيدات والسادة، حضورنا الكريم، إن عالمنا اليوم يضج بالمعلومات، ولكن قد تغيب المصادر الموثوقة للمعرفة الطبية. لذا ارتأينا في جمعية السكري البحرينية أن نعمل مع مجموعة من الخبراء في الإقليم على تعريب كتاب السكري والحمل الصادر من إقليم الشرق الأوسط وشمال أفريقيا تحت عنوان Diabetes and Pregnancy: A Journey into the Past, Present and Future of Care من اللغة الإنجليزية إلى لغة الضاد، مع الحرص على تبسيط المحتوى لتعم الفائدة على الجميع. وكان النتاج كتاباً مميزاً هو الأول من نوعه في الإقليم، ندعوكم لقراءته ونشر النسخ الإلكترونية منه لتعم الفائدة. وها هي لحظة مهمة في تاريخ جمعية السكري البحرينية نعيشها الآن سوياً بتدشين كتاب المرأة والسكري نحو صحة أفضل أثناء الحمل، وندعو الطفلة السكرية المهرة راشد سامي عيسى رحمة للتقدم بزر التدشين لمعالي الشيخ محمد بن عبد الله وسعادة الأستاذة لولوى لضغط زر التدشين. مبارك هذا التدشين، والآن ندعو سعادة الدكتورة مريم بنت إبراهيم الهاجري نائب رئيس مجلس إدارة جمعية السكرية البحرينية للحديث عن هذا الإنجاز البارز وأخذنا في رحلة الكتاب.
أصحاب المعالي والسعادة، السيدات والسادة، أسعد الله صباحكم بكل خير. يشرفنا اليوم وتزامنا مع الاحتفالات المملكة باليوبيل الفضي لتسلم جلالة الملك المعظم مقاليد الحكم، وتزامنا مع قرب الاحتفالات بيوم المرأة البحرينية، إنه لفخر واعتزاز لنا جميعا أن ندشن هذا الكتاب الأول من نوعه، ليس على مستوى مملكة البحرين إنما على مستوى الإقليم وعلى مستوى الاتحاد الدولي. هذا الكتاب ساسمحوا لي أن نمشي بخطوات للرحلة. فمن أين بدأت الحكاية؟ الحكاية بدأت في 2021 لما كان هناك تدشين للكتاب باللغة الإنجليزية، كان بفكرة بروفيسور شبين من باكستان، وهي رئيسة لجنة المرأة والحمل بالاتحاد والإقليم، ومعها مجموعة، وبتعاضد مع البروفيسور أحمد عميد بلال عميد كلية الطب بالفيصل آباد باكستان، والدكتورة نديمة، وهم اليوم حاضرين معنا، ومجموعة من الخبراء والمختصين والاستشاريين. فبدأوا بكتابة إرشادات عن السكر والحمل، ومن ثم الفكرة تبلورت إلى أن يطلق الكتاب. فمن هنا بدأت الحكاية بإصدار كتاب باللغة الإنجليزية. في هذا الحكايات نحن في مملكة البحرين تم تدشين نسخة إلكترونية من الكتاب باللغة الإنجليزية، كان في 2023. بعد ما دشنا هذا الكتاب جاءت الفكرة أن احنا ليش ما نقتبس من هذا الكتاب فصول باللغة العربية، ومن هنا بدأت خطوات إصدار الكتاب. وهذه الفكرة، ومثل ما تعرفون من خصائصنا احنا أهل البحرين أن احنا نحب التحدي ونعشق الإنجاز، فجاءت الفكرة في مارس 2023. بدأنا في اختيار الفصول والمؤلفين ومناقشة تصور الكتاب، الصيغة القانونية، وعقدنا اجتماعات أسرة التحرير، وتم تصميم الفني. فخلال سنة أنجزنا هذا الكتاب، والطباعة وتنفيذ الموقع الإلكتروني إن شاء الله بيكون متوفر للجميع. فهذا الشهر خلصنا من هذا الكتاب. طبعا الهدف من إصدار الكتاب هو نشر ثقافة صحية عالية حول كل ما يخص صحة المرأة والسكري أثناء الحمل، ومن الفئة المستهدفة للكل ممكن يستفيد من هذا الكتاب: المتعايشات مع السكري، اللي مصابات سكر الحمل، العوائل، المثقفين السكريين، العاملين في القطاع الصحي، المتدربين، الإعلام، طلبة وخاصة طلبة الطب، وصناع القرار. طبعا الكتاب يحتوي على عدة فصول، بالإضافة إلى البداية كلمة معالي الفريق طبيب الشيخ محمد بن عبد الله، وكل الشكر والتقدير لقائدنا الشيخ محمد، قائد مسيرة السكري في مملكة البحرين وقائد القطاع الصحي في مملكة البحرين، فله الشكر والتقدير وطال الله في عمرك شيخنا. في كلمة شكر وعرفان، طبعا هذه شكر وتقدير للمجلس الأعلى، وهذا قليل على المجلس الأعلى بقيادة السمو صاحبة السمو الملكي الأميرة سبيكة بنت إبراهيم على دعمها لكل إنجازات المرأة ودعمها في كل المحافل، فلها كل الشكر والتقدير. وهذه كان جائزة احنا حصلنا عليها كجمعية السكر. ومن هنا كذلك ان احنا فكرنا يكون عندنا كتاب باللغة العربية بيخص المرأة. الكتاب يحتوي ما نسينا من أعمدة جمعية السكر البحرينية، دكتور علي السندي، دكتورة سلوى المحروس، دكتورة كوثر التيتون، من مؤسسي الجمعية توفاهم الله، تغمد روحهم بال عرفان. ومعاه أنه مثل ما تفضل دكتور سنديد رئيس الاتحاد الدولي للسكري السنة متوفي، فرحمة الله عليهم. وكان هناك في إهداءات دكتور سنديد ورئيس الاتحاد، وشكر وتقدير لأحد أعمدة السكري في الإقليم دكتور مرسي عرب من جمهورية مصر العربية. طبعا الكتاب في عدد المؤلفين تقريبا 31، نسبة المشاركين بالبحرين 52%، احنا العدد الأكبر اللي أخذنا الفصول. نسبة المشاركات من النساء 71%، وعدد الفصول 35. اقتبسنا الفصول من الكتاب الأصلي باللغة الإنجليزية في قائمة المؤلفين. والكتاب تقريبا 40 اجتماع وساعة 77 ساعة بالتقريب، لكن في هناك أكثر اجتماعات، وفي هناك رسومات وإن شاء الله تطلعون عليها في المعرض الصحي. هناك جداول، هناك مصدر مبني على البراهين، تقريبا 1247 مصدر ريفرنس للكتاب، فهو كتاب قيم يستفيد منه الجميع. الفصول الكتاب تنوعت عن السكر، الحمل، وتاريخ السكر، الفحص، التغذية، العلاج، فهناك عدة فصول. حاولنا نختار الفصول اللي هي تهم المرأة تستفيد منها في التغذية. طبعا هاي الفصول مميزة، الكتاب مليء بالمواد العلمية ستثري المكتبة العربية وكل ما تحتاجه السيدة أثناء الحمل، وتنوع في المعلومات المطروحة يصب في تحقيق أهداف الكتاب والوصول لجميع الفئات المستهدفة، بما في ذلك مقدم الرعاية الصحية وصناع القرار. ختاما، كل الشكر والتقدير لصاحبة السمو الملكي الأميرة سبيكة بنت إبراهيم آل خليفة، قرينة جلالة الملك المعظم رئيسة المجلس الأعلى للمرأة، وجميع الأعضاء بالمجلس الأعلى للمرأة على دعمهم المتواصل للمرأة البحرينية. كل الشكر والتقدير لمعالي الشيخ محمد رئيس جمعية السكر البحرينية رئيس المجلس الأعلى للصحة، ولكل المؤلفين ولكل من ساهم بالعطاء لإصدار هذا الكتاب. وأتمنى وأسأل الله الصحة والسلامة للجميع، يحفظ أوطاننا بالأمن والأمان. والسلام عليكم ورحمة الله وبركاته.
شكرا جزيلا للدكتورة مريم الهاجري التي سخرت كل جهودها المخلصة عبر السنوات لمتابعة مشاريع وبرامج جمعية السكري البحرينية بكل حكمة وبكل محبة، فلها منا جميعا خالص التقدير والاحترام. السيدات والسادة، حضورنا الكريم، لأجل أن تكون على هذا الميعاد في كل عام، كانت الانطلاقة بسواعد تحمل على عاتقها الإبداع والسعي لإنجاح مثل هذه المحافل والتجمعات الطبية، فبورك هذا السعي من أجل الوطن. وندعو الآن معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة، وسعادة الأستاذة لولوى بنت صالح العوضي الأمين العام للمجلس الأعلى للمرأة، وسعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة، وسعادة الدكتورة مريم الهاجري لتكريم الداعمين وشركاء النجاح. أولاً، مع الداعمين للمؤتمر بنك البحرين الوطني، ثانياً الراعي الماسي شركة ليلي، ثالثاً الراعي البلاتيني شركة سيرفي فارما، رابعاً شركة صيدليات مدينة حمد الراعي الذهبي، خامساً شركة نوفو نوردسك، وشركة يونيفرسال للأدوات الطبية، شركة الخليج للبتروكيماويات جيبك، البنك العربي، ثانياً الشركاء الاستراتيجيون شركاء النجاح. أولاً وزارة الصحة، المستشفيات الحكومية، مراكز الرعاية الصحية الأولية، الخدمات الطبية الملكية، جمعية السكري البحرينية، الاتحاد الدولي للسكري International Diabetes Federation، دكتور جاكي معلوف، دكتور محمد صنديد. وكل الشكر والتقدير للجهة المنظمة شركة Education Plus. ويتشرف معالي الشيخ محمد بن عبد الله آل خليفة بتقديم هدية تذكارية إلى صاحبة السمو الملكي الأميرة سبيكة بنت إبراهيم آل خليفة قرينة ملك البلاد المعظم رئيسة المجلس الأعلى للمرأة حفظه الله، وتتسلمها بالنيابة سعادة الأستاذة لولو العوضي الأمين العام للمجلس الأعلى للمرأة. وتتفضل سعادة الدكتورة جليلة بنت السيد جواد حسن وزيرة الصحة بتقديم هدية تذكارية إلى معالي الشيخ محمد بن عبد الله آل خليفة. وقبل افتتاح المعرض المصاحب نتشرف أن يصعد كبار الضيوف والمحاضرين ورؤساء اللجان المنظمة وأعضاء مجلس إدارة جمعية السكرية البحرينية على المنصة لالتقاط صورة جماعية تذكارية على أن نلتقي معكم في مؤتمرات علمية قادمة. والسلام عليكم ورحمة الله وبركاته. and Dr. Iba Al-Azeri. Professor Shabin Naz Masood is from Pakistan. She is a graduate of Doe University of Health Science in Pakistan. She was chair of the Guideline Committee for Hyperglycemia in Pregnancy for the Society of Obstetrics and Gynecology in Pakistan and then for the IDF MENA region. She is an author and editor of the book on diabetes and pregnancy, past, present, and future of care. She has 30 years of academic, clinical research, and teaching experience. And the co-chair is Dr. Iba Al-Azeri, who is the Chief Medical Officer of Dasman Diabetes Center. She's a very well-established researcher and a reviewer for The Lancet, and she's always inspiring us in the work she does. Without further ado, please, chairpersons, introduce Dr. Nadima.
Thank you, Dr. Dalal. Thank you, audience and delegates. I have the privilege to introduce our first speaker, Dr. Nadima Shagan, and her topic is, Nadima is a specialist in endocrinology, diabetes, and internal medicine. Nadima is also president of Jordanian Society for the Care of Diabetes, a member of IDF, Joint Secretary of Diabetes in Asia Study Group, Vice President of Jordanian Society for Endocrinology, Diabetes and Metabolism, and Group Chair of Knowledge Exchange Committee of IDF MENA region and co-author of several publications. She is also one of the authors in the book on hyperglycemia and pregnancy and an author for the guidelines of hyperglycemia and pregnancy for IDF MENA region. So I request Dr. Nadima Shagan, and her topic is gestational diabetes, controversies in screening. Dr. Nadima.
Thank you, Professor Shabin, for this nice introduction. Assalamu alaikum. I would like to thank Professor Dalal Romaihi and Mariam for inviting me to have a chance in this conference, and thank the organizing committee. My talk today will be about controversy in screening gestational diabetes. So, in general, hyperglycemia in pregnancy, it is estimated to be around 16.7% of live birth women had some form of hyperglycemia. It means 1 in 6 ladies, they might conduct hyperglycemia during their pregnancy. It can be divided as diabetes in pregnancy, that hyperglycemia that met WHO criteria for the definition of diabetes and first time diagnosed during pregnancy. And gestational diabetes, which count for around 84% of hyperglycemia in pregnancy and last around 9% pre-existing diabetes, either type 1 or type 2, or moody diabetes, which is rarely occurs. What about gestational diabetes? Gestational diabetes, according to the WHO and FIGO, International Federation of Gynecology and Obstetrics, recommended the diagnosis of gestational according to the EDAPS criteria, which vilifies any time during pregnancy we can diagnose gestational diabetes. According to the International American Diabetic Association, the gestational diabetes can be diagnosed at the week 24 or up to 28 weeks of gestation. But there is an entity which called early gestational diabetes, was defined patient that vilify the diagnosis of gestational before the 24 weeks of gestation, but not vilify the criteria of pre-existing diabetes. The WHO stated that any time during pregnancy we can diagnose gestational diabetes, and it can be called early gestational. So what are the controversy about gestational diabetes? Is gestational diabetes is important? Whom to screen, when to screen, and how to screen, and which cutoff values for diagnosis? Well, by early detection and treatment, the outcome of affected pregnancy can improve, and reduction of adverse events and complications that occur in the mother, on the infant, and future risk for the mother and the offspring. What are the complications for the infant? Well, fetal and newborn risk, we have a significant sign of presence of hyperglycemia in utero, which is increased fat adiposity and decreased lean body mass, increased skin fold thickness, selective organomegaly, and accelerated growth. During labor, we have the risk of birth trauma, shoulder dystocia, brachial plexus injury, and operative delivery increase the risk of cesarean section. Regarding the maternal complication, hypertension, preeclampsia, preterm labor, postpartum hemorrhage, and operative increased risk, as I told, cesarean section, polyhydramnios, and hypertensive disorder. Fetal origin of the disease, if you have heard about it, is the fetal programming inside the utero, the intrauterine environment of the diabetic mother that causes changes to the fetus and manifested later in life, such as obesity, glucose intolerance, diabetes mellitus, and metabolic disease. This was described during the HABO study, the offspring of a woman in gestational diabetes age 10 to 14, after 10 to 14 years, they have high rate of obesity, higher glucose level, and insulin resistance. Long-term effect for women in gestational diabetes, recurrent rate of gestational diabetes. Women with gestational have the chance to develop 20 to 70% developing type 2 diabetes in the coming 10 years. Actually, 50% in the coming 5 years and 80% in the coming 10 years. And risk of future cardiovascular disease independent of the diagnosis of type 2 diabetes. So, we are dealing with a serious complication and future consequences. There was a study done by Professor Shabin Nas Masoud, our chair. She did a mass media campaign for screening hyperglycemia in pregnancy and postpartum follow-up. This study was published this month, and she had a total of 1,700 pregnant women of diverse ethnic background attended the antenatal visit. They went blood glucose screening based on the DEPSI criteria irrespective of the period of gestation. And she did a follow-up for them after delivery. The follow-up might be, it was that within 48 hours after the delivery, she did for them oral glucose tolerance test, and of the 2,500 women who completed the follow-up after delivery, 81% were normoglycemic, 9% had impaired fasting, 8% had impaired glucose tolerance, and 2% were diagnosed with diabetes. I had the honor with Professor Ahmed Bilal to complete the study, this study with Professor Shabin. Now we come to the other question. Who should be screened for hyperglycemia? Is it universal or risk-based screening? Well, pros and cons. If we select universal screening, we detect more cases, ensure that no women at risk are missed. Cons, it can lead to overdiagnosis, unnecessarily intervention, and health care burden. Risk-based screening, it's cost-effective, resource efficient, only screen women with high risk. Risk of missing a lot of women if we select risk-based screening. Let's see, which current guidelines recommended universal or risk-based screening? Well, WHO recommend universal screening, but some region, they go into risk-based screening. The International Federation of Gynecology and Obstetrics and the International Association of Diabetes and Pregnancy recommend universal screening to ensure that no women are missed. IDF, MENA recommend universal screening as part of border strategy to address the high prevalence of diabetes and obesity in the region. What about risk-based screening? ADA, American Diabetes Association, they recommend risk-based screening. But they said, you have to screen anybody with more than one risk factor with BMI more than 23%. So actually, most of our ladies, they vilify this criteria. NICE recommended screening, risk-based screening, but they said any lady who comes from ethnic backgrounds such as Southeast Asia, Middle Eastern countries, United Arab Emirates, Sudan, Jordan, Bahrain, they have to be screened as universal screening. So we vilify the criteria of universal screening even in the guidelines who recommend risk-based screening. Evidence showed that some people with universal screening reduced the adverse pregnancy outcome compared to target screening. Cross-sectional study was done in Pakistan showed that around 27% of women diagnosed with gestational have no risk factor. Another one done in Malaysia showed that around 24% of women with gestational didn't have any risk factor and they were misdiagnosed. American study done for gestational found that 1.4% of women when using risk-based screening but increased to around 3% in some population using universal screening. So this goes with universal screening. When to screen? Timing of screening is very important. Early screening, first trimester, majority of guidelines recommend universal screening for existing diabetes at the first trimester to ensure that there is no pre-existing diabetes. It's identify women with impaired fasting, pre-existing diabetes, and diagnosed. But there is cost effectiveness and challenge. Yet, it remains to data that early diagnosis and early intervention, there is lack of study evaluating the potential benefit of advantage of early diagnosis and early intervention. First trimester represents a crucial period for fetal programming. It is important to offer screening at the earliest opportunity, especially for those with high-risk population, such as obesity and type 2 diabetes, and this applies to our region, the MENA region. The possibility of intrauterine fetal programming, early pregnancy blood cell volume, weight at birth, and early screening also afford intervention prior to the development of organomegaly and any abnormality. So, gestational diabetes and early pregnancy studies regarding the benefit of early screening on pregnancy are conducting of some benefit, and we encourage early screening and early diagnosis. Studies that should describe benefit demonstrate improvement of pregnancy outcome. So this justify the diagnosis of gestational diabetes in early pregnancy. Second trimester, nobody disagree on the second trimester screening. Everybody agreed, all the guidelines. But about third trimester, IDF MENA region guidelines recommend third trimester screening if there is any sign of polyhydramnios or sign of hyperglycemia during ultrasound. What approach to use? Is it first step approach, second step approach, or just fasting plasma glucose or hemoglobin A1C? The HABO study, hyperglycemia and adverse pregnancy outcome, it is a 7-year study in more than 23 pregnant women at 15 centers, 9 countries. They did 75 oral glucose tolerance tests at 24 weeks of gestation, and they look at the result, and the results were demonstrating that early 75 OGTT is beneficial, and we can use the values of 0, 1 hour, and 2 hours. So in 2010, the IDAP proposed a new threshold for diagnosis gestational diabetes using the 75-gram oral glucose tolerance test. This was based on 1.7% odd ratio of having complication in the HABO study, and the 1.7 odd ratio correspondent to fasting plasma glucose of 92, 1 hour of 180, and 2 hours of 153 milligram per deciliter. So we recommend 75 oral glucose tolerance test. Any abnormal value, more than 1 abnormal value, make the diagnosis of gestational diabetes. Advantage of this study, it is simple to follow, easier to diagnose, identify more gestational diabetes. Disadvantage, require a woman to fast, and greater false positive test. What about the two-step approach? Two-step require 50 grams, regardless of the last meal, and you do the oral challenge test, plasma glucose less than 130 milligram, no gestational diabetes, more than 130, you do the 100 gram, and you have to have 2 abnormal values, which are fasting more than 95 milligram, 1 hour 80, 2 hours 150, and 3 hour 140. The disadvantage, you might lose patient because they have to come twice, one fasting and one non-fasting, and loss of follow-up, delay the diagnosis and initiating treatment. Alternative options, if we don't have any, if the patient cannot come in a fasting, cannot drink the glucose solution, what to do? Well, if the patient cannot come in fasting state, we can use DEPSI criteria. It is non-fasting oral glucose tolerance test, require patient to drink 75 gram anhydrous glucose, and blood sugar will be taken at 2 hours, and 140 milligram per deciliter is enough for the diagnosis. If she cannot come in cannot take the glucose solution, she can come in fasting state and fasting blood glucose in 2 separate occasions, can make the diagnosis above 92 milligram per deciliter. If there is no laboratory facilities, a glucometer can be used. Fasting blood glucose is very sensitive. The sensitivity can reach up to 100% and specificity 92%. Hemoglobin A1C is not recommended for any case of diagnosing gestational diabetes. We can use it for pre-existing diabetes, and they require hemoglobin A1C to be less than 6%. So we can use it as baseline if we discover that the woman is diabetic. There is a study done by Mohan this month, published, early hemoglobin A1C at the first screening test for gestational diabetes resulted in 3 different values. They said for hemoglobin A1C alone module, the threshold were 5.4% roll in, and 4.9 roll out in India. 6% roll in, and 5.2 roll out in Kenya. And 5.6 roll in, and 5.2 roll out in UK. This study was published recently. We cannot take the recommendation, but it's a very nice study which can give us a guidelines that hemoglobin A1C can be used for diagnosis. But I tell you, hemoglobin A1C alone cannot be used without fasting. And fasting alone in one occasion cannot be used. It have to be 2 different occasions. So in summary, the debate surrounding the gestational diabetes screening is multifactorial, balancing clinical efficacy, cost, and patient care. Global standardization and simplification guidelines is required, which is consistent and accessible, ultimately reducing the disparities and enhancing maternal and neonatal outcome for maternal and offspring health. at first antenatal visit, we recommend at IGF MENA region to do universal screening for all pregnant women. It's recommended, irrespective of risk factor, and if negative, to be repeated at 24 weeks of gestation. The recommended gold standard test is one step, 75 gram, 2-hour oral glucose tolerance test using the ADAPT criteria. And this is the chapter I have wrote with my daughter in the book Hyperglycemia and Pregnancy, which was Dr. Ahmed Bilal and Professor Jabin were the main author, the editorial board. This is the light the way for days to come, screening and diagnosis. And thank you.
Any questions? Any questions? Thank you so much, Professor Nadeem, for keeping on time. This is a fantastic start. And it gives me great pleasure to introduce Professor Dalal, who needs no introduction. I think the morning was really exemplary of what she has done across her life. She's a great colleague and a friend. Dr. Dalal was an outstanding star even as a medical student who graduated with honors, continued her journey to the States where she obtained her internal medicine and endocrinology from the States. Then she moved back to Bahrain, and since then she has been leading the scientific committee of the Bahrain Diabetes Society. She's an author of the book of the Diabetes and Pregnancy, and she also leads the internal medicine, residency program in Saudi Arabia, the program director. She has a lot in the region. She's also part of now of the WOF MENA, who has really added the Bahrain Society to become in the WOF MENA region. Professor Dalal, with no further ado, she will be talking to us about diabetes and pregnancy, the medical management. Stay tuned, and we expect lots of questions.
Thank you so much, Dr. Iba, for your kind introduction. So you've heard this morning, just a few minutes ago, from my colleague, Dr. Nadima, about screening of gestational diabetes. And what I would walk you through is the management plan in pharmacology. And what I will discuss today is a summary, a very brief summary of a big chapter from the book on diabetes and pregnancy. I wrote this along with Professor Ahmed Bilal, and I will walk you through a case and see how we can help women with diabetes achieve best targets. To understand that, we have to agree on the targets that we strive to achieve, and these are quite tight targets compared to outside of pregnancy. So what we try to achieve is a fasting glucose of 3.9 to 5.2, and if we're measuring 1 hour post-meal, 6.1 to 7.7, and 2 hours, 5.6 to 6.7. What we typically recommend, and we mentioned that in the book, is that for at least one day at the beginning, ask women to measure fasting after 1 hour and after 2 hours of meals, because we peak our glucose after meals in variable times. And whatever is worse, use that and maintain following that in subsequent testing. And with the advent of technology and the availability of continuous glucose monitors, CGMs, a lot of our pregnant women or women with diabetes who become pregnant are wearing sensors and these gadgets. So what are our targets? If you have somebody with type 1 diabetes, because of the risk of hypoglycemia, we request that the time and target, which in pregnancy is 3.5 to 7.8, should be around 70% of the time, allowing 5% of hyperglycemia and hypoglycemia and 25% for hyperglycemia. However, for women with type 2 diabetes who are pregnant or gestational diabetes, we can be stricter because of lower risk of hypoglycemia, striving for time and range of 90%. Of course, medications are not the first line of therapy for gestational diabetes. It's always medical nutrition management and working on physical activity, and you'll hear from my dear friend Dr. Sabika Lahdan later more about nutrition management. But what if it doesn't work? Let's take Sarah. Sarah is a 26-year-old lady with gestational diabetes. At 29 weeks of gestation, She gained 10 kgs in pregnancy, and Dr. Nadima did a 75-gram OGTT and identified that she meets criteria. So you advise her to do diet and exercise and write your numbers, and she comes a week later with the chart you have in front of you. And my patients don't bring me such charts. They bring me one reading here, one reading there, but let's see what we can identify here. So if we look at the fasting glucose, we said the target should be below 5.2, and it's good to look at percentages. How much percentage is she not controlled? 28% in fasting is elevated. If I look at the postprandial, after breakfast, it's the worst time for her, and that's the highest because we know physiologically with the hormone changes in pregnancy, after breakfast we have the most insulin resistance. She's not too bad after lunch, not too bad after dinner. But which one would you give her? Because most authors, guidelines, etc. will agree if 30% of the values are above target, go ahead and treat with medications. So what would you give her? Is it insulin or is it metformin? And a lot of this discussion comes in the clinic. And you might be correct if you do either, because as you see here, there are several guidelines recommending different approaches. If you look on the right side, in favor of oral anti-hyperglycemic first approach is the Society of Maternal Fetal Medicine in the US and the NICE guidelines. However, if you look on the left side, then in favor of insulin from the beginning is the American College of Obstetrics and Gynecology, the American Diabetes Association, Canadian Diabetes Association, Australian Diabetes and Pregnancy Society. And I was US trained, and there it was always insulin and never metformin. And when I came back to Bahrain and I saw my colleagues and I saw the studies and I saw the research and the guidelines, I started to give metformin. And what I like is the conditional recommendations you get from the International Federation of Gynecology and Obstetrics, because they are, in my opinion, wiser. You would see the patient in front of you, their profile, depending on the risk, depending on how much time we have, and you can go either way. So for example, on the left side, if you have the following conditions, it's always insulin first is preferred. For example, if you have diagnosed hyperglycemia below 20 weeks, so it's probably pre-existing. If hyperglycemia management is initiated later, so you don't have time to try and error and bring them back. And if you have a fasting glucose of more than 6.1, or the weight gain in pregnancy is more than 12, which does not really apply to Sarah that I discussed earlier. If these don't apply, then the oral hypoglycemic agents is a reasonable option, and the IDF has a similar approach. Now, why is that a question to consider? Because, of course, giving metformin is more convenient, it's easier. Your patients will ask you for a tablet, they don't want an injection. But we know insulin is the gold standard. It's the best proven medication, it's effective, and I have a huge room to titrate, and I can with certainty help patients achieve targets. So yeah, we want something, they want something, and there are always disadvantages. For example, on the left side you see for insulin, cost is an issue, access is an issue, maybe adherence is not the best, and hypoglycemia and weight gain is a risk. With metformin, the risk is potentially, theoretically, because it passes through the placenta to the fetus, are there long-term consequences to that? So you see Sarah, you remember the chart, and mostly she has hyperglycemia after breakfast. I would say you have two approaches. You could go with metformin and up the doses gradually, or you could go with mealtime insulin only for breakfast. Both approaches will be acceptable. Now, when we give anybody insulin, insulin is insulin. It works the same. We just have to remind ourselves that there are certain types that are approved for use in pregnancy and others that are not. And lately, we added Digludec to options that can be given to women in pregnancy. And depending on what area of the glucose profile that needs attention, we will select. If the problem is fasting hyperglycemia, basal insulin is what you would go for. If the problem is postprandial hypoglycemia, you would go with a quick-acting or a bolus insulin, and if it's both, you use both. And the book or chapters show you guides of how to select even the doses in units per kg, depending on the weeks of gestation that the woman is at. And remember that these are initial doses. We always have to have feedback later on, see the response, see if we have achieved targets or not. If not, we always titrate up. If the problem is still fasting hyperglycemia, we can increase the basal insulin around 10 to 20%. And if the problem is with mealtime hyperglycemia, then it's the bolus insulin. And you will find yourself and your patient like riding in a rocky sea. Now you have hyperglycemia, now you have hypoglycemia. And I remind you and I remind our patients that it's okay. And you might find an area that you are really well controlled and we have really good 2 weeks and off we go to the rocky sea again. And that's natural because of the advancement of pregnancy and the increase in hormones and the insulin resistance. So be gentle on yourself and be gentle on your patients and let them be gentle on themselves, that this is expected. Worsening hyperglycemia might come and we have to be mindful of their well-being, even their mental well-being, not to distress them. Metformin is the queen of the medications, or king, depending on what you think. And we always start with 500 milligram once or twice daily after meals, and then you can increase to maximum dose, typically 2,000. And although I told you that it passes through the placenta to the fetus, no evidence of teratogenicity is proven with metformin. The only concern is, are there long-term consequences of, for example, increasing adiposity? And ongoing studies that you see listed are looking into that. Previous guidelines in previous years did recommend other oral agents, including glyburide, but this is now gone because it has the disadvantages of hypoglycemia, and we know that metformin and insulin are safer options. Now, I want to just touch upon some certain special situations. For example, the use of glucocorticoids, which our colleagues in obstetrics will need to use sometimes to improve lung maturity, and we know that the side effect is hyperglycemia. So betamethasone or dexamethasone is given, and then maybe you will see a lasting effect even after stopping, maybe 48 hours later, maybe 5 days later, you will see a noticeable hyperglycemia. So what would you do? It depends on what was the woman on prior to the use of steroids and what was the degree of control. So what we suggest is if you have somebody who was well controlled and prior to steroids was only on nutrition management, continue nutrition management and add a supplemental sliding scale if needed. If this person was on basal insulin, go ahead and proactively add 20% extra dosage, and you might also add insulin sliding scale. If they are on basal bolus, go ahead and increase by 20% and maybe up to 30% and sometimes with a correction insulin increase. We also think in special situations of women with type 1 diabetes who become pregnant. And remember that hyperglycemia doesn't start from the beginning. Because of the changes in the hormonal profile, you might see that the total daily dose of insulin in the beginning is the same as it was before pregnancy, with a small dip maybe between 11 and 14 weeks. However, from 16 weeks, you have an increase of all the fetal growth hormones and stress hormones, and you will see that placental lactogen, and you will see an increased demand for insulin levels. And that's expected to keep going around 5% extra every week. So that's natural, that's expected. So it's nice to tell that to the patients so they're prepared. And if you see a sudden dip in the need of insulin, be very careful because that might be an obstetric emergency. Say the lady used to be on 20 units and for basal and 5 units for meals, and now she's having hypoglycemia, and you say, okay, I will cut down your doses, but be careful because sometimes that means those hormones that used to cause a problem are gone because of placental insufficiency, and this is an obstetric emergency. So be careful that the doses will increase, and if you find no need to increase, maybe there is a problem. What about women with type 2 diabetes? Well, the journey starts way before even thinking of pregnancy in an ideal world, and that's the role of educating women of reproductive age. Once they get married, now let's think, when do you want to get pregnant? And you'll use effective contraception before pregnancy. You will help them get to an A1C, hopefully below 6 if you can, without hypoglycemia, or at least below 6.5. And change all their regimen. Deal with them as if they're pregnant now, like metformin, insulin, insulin, insulin. and look at all their medications, review their ACE inhibitors, their statin, check their immunization status, and begin them on folic acid. You see through my presentations, paintings and drawings pop up, and these are part of the book because we are writing for the public and also for healthcare professionals in the original book, and we didn't want it to be boring and heavy and scientific, so we're blending the science and art together, and I invite you later on to just pass by the gallery and see the art exhibit as well. So my take-home messages for you is that pharmacotherapy is indicated for women with hyperglycemia in pregnancy if you find that mark of 30%. So having a number is nice in my mind. It makes my life easier because I see and I calculate and I know, okay, we start. And metformin is a reasonable first choice for mild, mainly postprandial hyperglycemia, and insulin is still the gold standard. It's the safest option, it's effective, and it's titratable so we can achieve targets. Because of the shortage of time, I will not go through questions for this session. We want to stay on time. Dr. Mariam El-Hajeri is very strict with timing, and we want to keep this conference sharp on time. And this is just a picture of the chapter showing the number of references me and Professor Ahmed Bilal and the group had to go through to write this chapter were 201 references in total. So I thank you for your attention, and I remind you that glucose control is achievable when you follow simple rules. Thank you so much.
Thank you, Professor Dalal, for keeping on time. Any questions for Dr. Dalal? Okay, we'll keep it after for the panel discussion.
Thank you, Dalal. Very nice talk indeed. So I have the privilege to introduce Dr. Sabika Al-Ehdan, and she's a PhD holder in human nutrition and diabetics, and she's an assistant professor of nutrition and diabetes at Biology Department of College of Science at University of Bahrain. She is one of the few distinguished and well-known in Bahrain in the field of nutrition. Her research lies in the investigating the effectiveness of different types of diet on glycemic control of pregnant women with GDM and the association of nutrient intake and dietary patterns with chronic disease. Currently, she conducts research to study impact of COVID-19 pandemic on dietary habits of adults and pregnant women. So, Sabika, you are welcome, and the topic of her presentation is Sustaining Wellness in Hyperglycemia in Pregnancy, the Role of Nutrition. Dr. Sabika.
Thank you very much, Professor Shabina, for this nice introduction. Good afternoon. First, I would like to express my deep thanks for organizing committee to giving me the opportunity to deliver presentation on the role of nutrition to sustain wellness in hyperglycemia in pregnancy. The outline of my presentation is the role of medical and nutrition therapy in managing hyperglycemia in pregnant women, a role of energy, macronutrients, and micronutrients, a role of a different dietary intervention in managing hyperglycemia, and finally, take-home message. Medical nutrition therapy is a therapeutic approach that involves the use of dietary and nutrition intervention to manage a medical condition and improve the health outcome. This type of therapy should be conducted by a registered dietitian and is tailored to meet the individualized needs of the patient. The studies show that 70 to 85% of pregnant women diagnosed with the GDM, they can obtain and maintain a normal glycemia with medical nutrition only. So medical nutrition therapy is considered a cornerstone of treatment of hyperglycemia during pregnancy. Also, there is a nutrition care plan that consists of 4 key steps. The first one, nutrition assessment. We need to evaluate the anthropometric, dietary, clinical, and biochemical status of the patient. And the second step in nutrition diagnosis, we need to identify all the signs and the symptoms that related to the nutritional problem. A third step is a nutrition intervention and implementation of the dietary intervention, mainly to implement individualized meal planning by distributing carbohydrates and the focus on a healthy eating. Also, the nutrition intervention include counseling and education on how they consume carbohydrate over the day through using a carbohydrate counting approach, and increase or encourage physical activity. And the fourth step in the nutrition care process is the nutrition monitoring and evaluating. We need to evaluate blood glucose daily, like 4 times per the day, especially fasting and post-branding, as well as we need to monitor body weight gain to achieve a recommended weight gain during pregnancy. Also, this medical and nutrition therapy should be individualized. We need to take into consideration the mother nutritional need, health status, maternal dietary choices, and the lifestyle factor such as work, leisure, and exercise. Also, this medical and nutrition therapy should be adjusted continuously based on the self-glucose monitoring, appetite, and the weight gain pattern of the mother. If insulin therapy was added, we need also to distribute carbohydrate intake over meals and snack to facilitate insulin adjustment and to manage the blood glucose over the day. The main goals of medical and nutrition therapy in managing hyperglycemia are providing the sufficient calorie that enhance the growth of the fetus as well as for a mother, promoting optimal fetal growth, avoid ketosis and ketonuria, avoiding the mother excessive weight gain. Medical and nutrition therapy has a good effect or a good impact in both maternal as well as the newborn. For maternal, medical and nutrition therapy is able to prevent excessive weight gain, normalize the blood glucose, enhance insulin sensitivity and reduce insulin resistance, as well as improve thyroid function. For the newborn, medical and nutrition therapy allow for reducing oxidative stress and inflammation of the placenta and protect newborns from later disease. Also reduce the risk of macrosomia, stillbirth, reduce DNA damage, and promote the neural development and the brain health. The energy and the micronutrients requirement for a pregnant woman with hyperglycemia. First, I will start with the energy requirement. There is no sufficient evidence to suggest that the energy requirement for a woman with hyperglycemia should be different from a normal glycemic woman. So, the American Diabetes Association recommended a minimum intake of 1,800 kilocalories per day for mother, and the appropriate increase in the energy intake during the second and the third trimester of a pregnancy. To maintain a normal weight gain and the physiological need, we need to add 340 kilocalories per day during the second semester and extra 450 kilocalories per day during the third semester. While the International Federation of Gynecology and Obstetrics recommend the GDM patients should control their daily energy intake between 30 and 35 kilocalories per kg according to their body weight, and the total energy intake should be range from 1,500 to 2,000 kilocalories per day. A particular attention should be given for women who are already obese or already achieve the recommended weight gain. So a calorie restriction of 30 to 33% may be advisable. The recommended weight gain during a pregnancy in women with hyperglycemia is the same in the normal glucose tolerance pregnancy. A recommendation for gestational weight gain were made in 1990 by Institute of Medicine based on a pre-pregnancy body mass index. A woman with a lower body weight, they need to gain from 12.5 to 18 kg during a pregnancy, while obese women, just they need to gain from 5 to 9 kg overall a pregnancy, while a normal weight gain from 11.5 to 16 kilocalorie, and the overweight can gain from 7 to 11.5 kg. For the carbohydrate requirement, there is a debate. Some of the institute recommended a lower intake of the carbohydrate, while other focusing on a type and the distribution of the carbohydrate. So carbohydrate restriction remains the most common approach for medical and nutrition therapy in hyperglycemia during pregnancy. The Institute of Medicine recommends the carbohydrate intake to be range from 46 to 65% of the total energy intake, and the minimum intake of the carbohydrate should be not less than 175 grams to ensure appropriate fetal growth and brain development and function of the baby. The American College of Obstetrician and Gynecologist, Endocrine Society, and the ADA recommended restricting the carbohydrate intake in all GDM women to 35 and 45 of total energy intake, while the FIGO advised monitoring the carbohydrate intake, the quality of the carbohydrate that consumed by distributing all the carbohydrate over the day to maintain a normal glycemia. Also, carbohydrates should be mainly consist of starchy food that's high in fiber, low in glycemic index, like fruit, vegetables, legumes, and whole grain. More and more studies have shown that a low glycemic diet can effectively improve blood sugar control, reducing insulin use, and reduce the risk of macrosomia. A randomized trial showed that a low glycemic diet also had a significant positive effect on the pregnancy weight gain and the maternal glucose intolerance. As seen here, there are 12 clinical trials that conducted over the world. Those in red indicate low carbohydrate intake, while those in the black indicate moderate intake of carbohydrate, whereas marked by the green and the blue color indicate a higher carbohydrate intake. The lowest carbohydrate intake was in Australia in a study that conducted in 2009. Carbohydrate intake was around 36% of the total energy intake, while the highest one in Poland, the highest energy intake was 60% of the total energy. Restricting carbohydrate is beneficial for managing hyperglycemia, but when we replacing carbohydrate with fat in obese women with pre-pregnancy insulin resistance may elevate lipolysis, increase fatty acid and glycerol, which that enhance insulin resistance and increase adiposity among fat, while a higher intake of the nutrient-dense complex carbohydrate may result in improved all metabolic outcome like fasting glucose, insulin resistance, and also reduce the accumulation of adipose in an infant. Also, the American Diabetes Association and the Institute of Medicine recommend to consume 28 grams of fiber every day, 14 grams for every 1,000 kilocalorie. The higher intake of fiber can normalize the blood glucose, also has a good effect on a lipid profile, reduce inflammation. And to meet a recommendation by consuming 28 grams of fiber, we can meet by eating 600 grams of fruit and vegetable daily with a minimum of 300 grams vegetables. Here, a meta-analysis study show that dietary fiber and a whole grain can able to manage the blood glucose. Also, carbohydrate or all caloric intake should be distributed in 3 main meals and 2-3 small meals like a snack is recommended to avoid excessive food intake. At the same time, avoid large quantities of carbohydrate and reduce the post-Brandon blood glucose. And you can see here in the blue curve is that a normal meal pattern for a normal pregnancy, just 3 meals, while red curves illustrate that meal patterns for a diabetic patient, they should consume 3 large meals and 3 small snacks. The best approach to distribute carbohydrate among the 3 main meals and the snack is carbohydrate counting. So carbohydrate counting is a meal planning approach for managing blood glucose level for a patient with diabetes. It has the greatest impact on keeping the post-Brandon blood glucose level in target range. Also, we have one randomized controlled trial that conducted in Jordan among pregnant women who diagnosed with GDM. The finding of this study revealed that a patient who follow carbohydrate content had a lower fasting blood sugar and a lower post-Brandon blood glucose when we compare it with the control group. The protein is crucial for bone development as well as for a nitrogen balance. The ADA recommends that a woman with a GDM should consume at least 71 grams of protein daily during pregnancy, range from 10 to 20 of daily energy intake. The studies have shown that replacing the energy from carbohydrate by increasing the total protein may be significantly associated with a higher risk of GDM. Replacing the animal protein with the plant protein may reduce the risk of GDM. The fat requirement should be from 20 to 35% of the total energy intake. We should limit the saturated fatty acid, but more focus on a long-chain fatty acid, what we call the omega-3 fatty acid, because they have a positive effect on insulin action as well as in the glucose tolerance. In this section, I will discuss the micronutrients that are related to the glucose metabolism and enhance the insulin action. A study suggested that micronutrient supplementation during pregnancy is beneficial for a patient with a GDM. They focus on supplementation of magnesium, zinc, selenium, calcium, vitamin D, and vitamin E, either alone or in combination. They found it is significantly improved glycemic control in women with a GDM compared with a woman those receiving placebo. A vitamin and the mineral supplementation was found to reduce inflammation, oxidative stress, and increase total antioxidant capacity. Magnesium can reduce the mitochondrial electron transport. Zinc essential to reduce also a reactive oxygen species. Vitamin D affect insulin secretion, and vitamin E improve glucose disposal through upregulation of magnesium concentration. For vitamin B12 and folate, some studies found where there is imbalance of vitamin B12 and folate, there is a high risk for having glucose. This related to the damage in mitochondrial DNA. Also, vitamin D or supplementation with the vitamin D during the first and the second trimester may reduce the risk of intolerance to glucose and gestational diabetes. A high dose of vitamin D improve insulin resistance in a woman with GDM. Regarding iodine, there is a debate between the studies. Some of the study they found both of insufficient and excessive iodine intake has an impact on a pregnancy, may impair adaptive mechanism, and contribute to the occurrence of GDM. A recent Belgium study measured the concentration of iodine in the placenta and found that a higher concentration of iodine in the placenta reduced the risk of GDM in the mother. For a dietary intervention that manage hyperglycemia, there are many dietary interventions. They range from low glycemic to the higher glycemic, low carbohydrate to the higher carbohydrate, a DASH diet to the control diet. One systemic review studying 19 trials and comparing the effect of 10 different types of dietary advice found all of these dietary interventions give a similar result in normalize the blood glucose and improve maternal and the newborn health. So there is no conclusive evidence to show superiority of one approach or diet over the other. But the best two, one, a DASH diet and a Mediterranean diet, they are good because they are rich in the fruit, vegetables, a whole grain that's rich in a dietary fiber, which that manage the glucose level. There are two studies have reported the beneficial effect of using a DASH diet on fasting blood glucose, insulin level, insulin resistance, also cesarean rate, and the breath weight among the patient with GDM. For a Mediterranean diet, this is a traditional eating pattern for countries who are bordering the Mediterranean Sea. This is a diet rich in whole grain, fruit, vegetables. They focus on monounsaturated fatty acid as olive and the nut, adequate amount or moderate amount of white meat like a fish and chicken, dairy product, and a limited amount of meats. Okay, so Mediterranean diet are effectiveness and prevent GDM. A take-home message, medical nutrition therapy is a core for managing hyperglycemia. Many different approaches to nutrition therapy, they are work and equally effective. Monitoring gestational weight gain, self-monitoring, and tracking fetal growth are important to modify and adjust the nutrition care plan. And finally, optimizing the maternal health during pregnancy is essential for ensuring the well-being of mothers, their children, promoting healthy families and community. And thank you very much.
Very much, Dr. Sabika. Questions? No time for questions? Okay. So,
we would like to call the speakers to give them the awards. Please, if we have Dr. Nadim.
صورتني انا وعم بحكي. ايه يلا غير شكل ديانا هي هيك.
All right, we'll carry on with our program with Lily-sponsored talk. This is from our next speaker, Mustafa Abu Ubayya, is a medical advisor for Gulf region at Eli Lilly and Company. He's a pharmacist by training with 14 years of diversified experience across pharmacy practice, academia, and pharmaceutical industry. Mustafa worked across all Gulf countries in different capacities within medical affairs since 2019, managing therapy areas including rheumatology, dermatology, and cardiometabolic health. We welcome him to the podium.
Assalamu alaikum. It's a pleasure and honor to be with you here today, and I'll be presenting to you today, hopefully, a useful topic on tirzepatide in type 2 diabetes. So just a reminder that this symposium is sponsored by Eli Lilly and Company, and I'm a full-time employee at the company. First, if you allow me to show a small video as a disclaimer video on what we're going to discuss today. Excuse me. Do you have the audio for this? Video is not working. شغال من بيت. Okay. For the interest of time, I will tell you what the video was going to say. So basically, this meeting will be dedicated only to on-label information on tirzepatide in type 2 diabetes and weight management. So any off-label discussions that is not related to those approved indications or populations, we can take it after the meeting as a medical department. So if you can kindly refrain from taking photos and posting them on social media throughout the meeting, that will be greatly appreciated. So as we said, Mounjaro as of today is locally approved for management of patients with type 2 diabetes who are uncontrolled on their medications, either as a monotherapy or in combination with other anti-hyperglycemic medications. It's also indicated in patients with overweight or obesity as a method of weight management or that includes weight loss and weight maintenance in patients with a BMI of 27 to 30 with at least one weight-related comorbidity of the listed here, or in patients with obesity of more than 30 BMI. So just a quick turn on diabetes as a disease state and prevalence. So as we are all aware, the prevalence of diabetes is very high, and it's highest across our region with almost 18% according to IDF in 2021. The problem is this prevalence is highly increasing, almost doubling in some of the regions within the next 20 years. Those high prevalences, they impose a substantial impact on the healthcare system and also on the economics of the society, with 0.4 to 1.2% of GDP representing the diabetes-related health expenditure from low-income countries to high-income countries, with almost 50% of that direct cost of diabetes related only to complications of the diabetes. One of the reasons driving this high prevalence is that patients with whatever we have of medications that are tackling diabetes management as of today, we are still seeing almost 50% of patients not achieving the recommended A1C target of less than 7%. There are also on 90% of patients not achieving their weight loss targets or weight targets of a regular BMI of less than 25 kg per meter square. This was also confirmed by CDC National Diabetes Report in 2020, which is highlighting the same number. 50% of patients are not achieving their A1C target of less than 7%. One of the main reasons that's leading to this uncontrolled diabetes is the what we call therapeutic inertia, or the failure to intensify treatment in a timely manner. As we can see here, this is literature review from the UK that is looking at studies conducted in the UK with addressing therapeutic inertia. What they have saw is that it takes almost 3 years to initiate in a stepwise approach for managing patients with diabetes, almost 3 years to initiate from an oral monotherapy to a dual monotherapy, almost 7 years to initiate from or to intensify with a triple oral therapy, and to initiate an insulin or injectable therapy for intensification purpose, it takes almost another 7 years. And as you can see here, the point where we intensify the treatment is increasing as we move forward. So we started with intensifying at 8.5, 8.7, 9.1, and 9.7%. The problem with this delay or delaying of intensification is that it increases the risk for micro and macrovascular complications, it increases the risk of morbidity and mortality, and if the patients achieve their glycemic targets, the point is they don't stay on those targets for long. Unlike patients who were intensified early on, those patients were able to achieve better glycemic targets. They were able to maintain those targets for longer durations, and they were able to delay the onset of diabetes-related complications. This is another single-center study from the US that was published 2009, and they looked at a smaller cohort of patients who were newly diagnosed with type 2 diabetes. They were intensively treated with metformin and insulin for 3 months until they reached their glycemic goal of almost 6% A1C. Then they were followed up for 3 years later, and they were randomized to either continue on metformin and insulin for those 3 years or switch to a triple oral therapy regimen, which included metformin, glyburide, and pioglitazone. The interesting thing is that after 3 years, both groups were able to maintain their A1C target that they achieved 3 years earlier. And the other interesting thing is that regardless of the treatment they received or continued on, they were able to achieve the same target or maintain the same target. There was no statistical difference between the two treatment groups. So it's not the method you use to intensify treatment, it's the fact that you need to intensify. So it's a proof of concept of early intensification. The last piece of evidence here is from electronic medical records and Optum Health database in the US, and this was published in 2020 by Professor Rosenstock. So it looked at patients who were intensified on 2 treatments, a GLP-1 receptor agonist and insulin, and they looked at the interval at which those both treatments were initiated. So if they were initiated within 1 month apart, that would be the cohort A, the cohort to the far left. If they initiated both of them within 60 days to 30 days to 90 days, to 2 to 3 months, that's cohort B. 3 to 6 months, cohort C. 6 to 9 months, cohort D. And cohort E is patients who initiated both of them almost a year apart. So the outcome here, or the finding, is that the closer you intensify treatment or the earlier you intensify treatment, the better outcomes. So what we can see here is that we have the proportion of patients who achieved more than 1% A1C reduction within 6 or 12 months, and the percentage of patients who achieved 2% or more A1C reduction also within 6 or 12 months. And we see the better odds are in patients who were intensified early on. So just to sum it up, the clinical care gap still remains. We are not intensifying enough, and most patients are still not achieving either their glycemic or their weight targets, regardless of the solutions that we have as of today. So quickly jumping into tirzepatide and type 2 diabetes and its SURPASS clinical trial program. So tirzepatide is a long-acting GIP and GLP-1 receptor agonist. It's one molecule that can activate both receptors. So it's built on the native amino acid sequence of the native GIP hormone. It has some alteration in its amino acid sequences that allows for albumin binding, prolonging its half-life, which is almost 5 days, so it enables for weekly dosing of the medication. The plasma concentration is not altered either in patients with renal or hepatic impairment of any stage, so it can be used in full dose without any dose adjustment. The mechanism of action resembles that of other incretin-based therapies of GLP-1 receptor agonists, so on the central nervous system, reducing appetite and food intake, on the liver, reducing liver fat content, pancreas, improving beta cell glucose sensitivity, increasing and decreasing insulin and glucagon in a glucose-dependent manner, on the stomach with delaying the gastric emptying, and systemically on the white adipose tissue as well, with improving insulin sensitivity. The SURPASS clinical trial program has already 6 published manuscripts with 6 clinical trials, SURPASS 1 to SURPASS 6, that is covering the spectrum of care for patients with type 2 diabetes. It starts with monotherapy along with oral drug combination and eventually with insulin combinations as well. So as we can see here, there were different strategies that were implemented in those clinical trials, and with a huge number of patients that were involved in those clinical trials with different baseline characteristics. So the general study design is that tirzepatide was studied in 3 doses, 5 milligram, 10 milligram, and 15 milligram once weekly, versus either an injectable placebo or an active comparator. The primary objective or the primary endpoint was to assess superiority for tirzepatide in 3 doses in terms of A1C reduction from baseline at the time point, which is 40 or 52 weeks. Other key secondary also included weight reduction from baseline. So as we can see here, across the 6 published trials, we can see that tirzepatide, whether in 5, 10, or 15 milligram, was able to improve A1C reduction and to prove superiority versus all other comparators and placebo within 40 to 52 weeks, as we can see from the numbers in front of us, regardless of the use as a monotherapy or in combination with other medications. That reflected on more patients achieving their glycemic target of less than 7% versus other comparators and versus placebo as well within the 40 to 52 weeks. This was also reflected on the percentage of patients achieving normal glycemia, which is a little bit unorthodox to look at normal glycemia as an outcome from a type 2 diabetes study. So we had, with the highest dose of tirzepatide of 15 milligram, between 30 to 60% of patients achieving normal glycemia within 40 to 52 weeks. That's 1 to 2 patients in 3. Its effects on body weight loss, as of the studies that we have in front of us, it also showed superiority of tirzepatide when reducing body weight in patients with type 2 as compared to other comparators as well. And this was translated also in more patients achieving a weight loss target of 5%, 10%, or 15% of their initial body weight. So what we can see here is the percentage of patients achieving 10% or more of body weight loss, and that's up to 70% of patients in the highest dose of our trials. What we also can see here is the percentage of patients who are achieving 15% or more of body weight reduction across the clinical trial program. And as we can see here, a high of more than 40% achieving that target, which was not easily achieved with prior medication. We will deep dive on one of those studies, which is SURPASS-2 study that was published in 21. Again, this is comparing tirzepatide in all three doses, 5, 10, and 15 milligrams, to semaglutide 1 milligram weekly in patients with type 2 diabetes. As we can see here, the primary endpoint was looking as non-inferiority for 10 and 15 milligrams versus 1 milligram of semaglutide in HbA1c reduction from baseline. But as we go through the key secondary objectives, we're looking at non-inferiority of the 5 milligram dose, but also superiority of the 3 doses compared to semaglutide 1 milligram when it comes to A1C reduction, body weight reduction from baseline, percentage of patients achieving less than 7% A1C, and achieving less than 5.7%. The general study design, as you can see here, is tirzepatide for the 3 doses versus semaglutide. It was titrated as per label, and all of the patients were receiving metformin as a background therapy for 40 weeks. The inclusion criteria was for type 2 patients more than 18 years, which is the approved range or age for the patients. HbA1c between 7 to 10.5 and a BMI of more than 25. Of course, it was excluded for patients who had type 1 diabetes, patients with a history of pancreatitis, retinopathy, or an impaired renal function. As we can see here, the drop in HbA1c from 40 weeks, it was around 2.09% for tirzepatide 5 milligram, 2.37 for 10 milligram, and 2.46 for 15 milligram compared to 1.86, which is again statistically significant and superior to semaglutide 1 milligram. And as we can see on the overtime curve, we can see that the effects start as early as week 4 and week 8. We also see the same outcome with change in body weight from baseline at 40 weeks. And again, the same effect we see as early as week 8. And the amount of weight reduction is higher as we move forward with the doses. So with 7.8 kg reduction with a 5 milligram dose, 10.3 kgs with a 10 milligram dose, and 12.4 kgs with the 15 milligram dose, which is double the amount of weight loss observed with semaglutide 1 milligram in the same duration. This has also impacted the outcome when it comes to BMI reduction and waist circumference reduction, which we observed up to 10 centimeters of waist circumference reduction with the highest dose of tirzepatide. When it comes to safety, as you would expect of a GLP-1 GIP receptor agonist, is the majority of adverse events are GI related. They are mild to moderate in nature, and they are transient. That means that it mainly peaks within the dose escalation period, and then it subsides over time. As we can see, nausea, diarrhea, vomiting were the most commonly reported adverse events in the clinical trial program, and in this clinical trial, to be more precise. And the nature, as we talked about earlier, the incidence is basically within the dose escalation period, where we might expect the highest incidence of adverse events. However, this will subside over time when we manage the dose on a certain dose. Other adverse events of special interest that we would like to focus on are pancreatitis, cholelithiasis, medullary thyroid carcinoma, and diabetic retinopathy, which were very low in incidence across the clinical trials, and they were also comparable in incidence to active comparators, other active comparators, or placebo. When it comes to hypoglycemia, the risk of developing hypoglycemia with tirzepatide by itself or in combination with other medications that do not usually cause hypoglycemia is very low, as we can see in SURPASS 1, 2, and 3, which was a monotherapy trial in combination with metformin, and SURPASS 3 was in combination with metformin and SGLT2. So we see a low incidence of hypoglycemia. However, with SURPASS 4, which we had sulfonylurea as a background medication, and SURPASS 5, which we had basal insulin glargine as a background medication, we see a rise in the incidence of hypoglycemia due to the other medications. So my key takeaways out of this session would be that early intensive treatment can result in improved and I would say sustained glycemic control. Tirzepatide as an agonist that targets both GLP-1 and GIP receptors, it provides robust and clinically relevant weight reduction and A1C reduction compared to placebo, semaglutide 1 milligram, and basal insulin glargine. The most common adverse events were GI in nature. They were transient and they were mild to moderate in majority. And the treatment with tirzepatide doesn't increase the risk of hypoglycemia unless it was used in combination with an insulin or sulfonylurea. That would be all for me, and thank you very much for your attention and for your time, and I'll be happy to take any questions if you have. Thank you. Okay, just checking if anyone has any questions. Sorry, yes, sorry. Thank you. I'm sorry, I heard restrictions, but I didn't hear what the restriction is. Okay, so general restrictions on prescribing tirzepatide. Okay. Okay, that's more related to the country. Honestly, I'm not sure, but I understand there are some restrictions. I'm not quite sure because I'm not based here, so I don't know what the local regulation is. But I believe there might be restrictions on some of the specialties who might prescribe it as per the local law. But from product perspective, there is no restriction. Anyone can prescribe it. Any HCP can prescribe it as long as the patient is indicated for this medication. Yeah. I don't know if that answers your question, but maybe my colleague will help answer this question. So, thank you.
Actually, there are product restrictions in case of medullary carcinoma or family history of medullary carcinoma. In case the patient comes with familial multiple endocrine anomalies, so you should not use it in these people. And in case the patient is having recurrent hypoglycemia to begin with. So you better be careful in these people when you put them on this drug, is that their appetite may drop precipitously and they will get into severe hypoglycemic episodes. So I personally do not use it if there is family history of medullary carcinoma, thyroid, or multiple endocrine anomalies. I think the manufacturer mentions these in the restriction.
Thank you very much for raising this. So from a contraindication perspective on prescribing Mounjaro, so as per the locally approved label, which is reflecting the European Medicine Agency label, there are no contraindications on prescribing Mounjaro when it comes to patients with a history, family or personal history of MTC or MEN2. This was on the US label, and since we switched to the European label, it doesn't have this as a contraindication, and this is the one approved locally here in Bahrain and in all Gulf countries. So when it comes to contraindications on the currently approved label, the only contraindication is hypersensitivity to tirzepatide or any of the excipients that are used within it. I understand your point that we need to be cautious when treating some patients, And this is also on label, where we have patients who, for example, they were not studied in our clinical trial program. So, for example, patients with a history of retinopathy or a pancreatitis or a pre-existing GI disease. So we need to be cautious when treating those patients. However, it's not a contraindication. They can use the medication, but we need to be cautious while treating those patients.
I have a question for you, actually. Among the cases who developed pancreatitis, how many of them were severe, requiring hospitalization? And was there any mortality associated with these pancreatitis cases?
Thank you very much. So, as you can see here, this is the incidence of pancreatitis. It was very low in all of the cases. So we're looking at 2 cases in SURPASS-2 on the 10 milligram, 2 cases on 15, and 3 cases on semaglutide 1 milligram. In SURPASS-4, we see 3 cases with a 5, 2 with a 10, 1 with a 15, and 1 with insulin glargine. So this is the whole incidence of pancreatitis in the clinical trial program.
What's the total number of patients treated with all doses?
In SURPASS clinical trial program, we were looking at, I think it was 6,000 plus patients. So more than 6,000 patients were enrolled in this clinical trial program.
And how many of those developed severe pancreatitis requiring hospitalization?
I can come back to you on the exact number, but most of these cases were self-resolving. They were mild to moderate in nature. But I will get back to you if there's anything related to severe cases of pancreatitis specifically to be mentioned. Thank you. Any other questions? Okay. Thank you very much. Thank you again for your time. Thank you.
Hello, good afternoon, everybody. We are today for our second session of the Diabetic and Obesity Conference. I may present Dr. Al-Ozairi, Iba Al-Ozairi, who has completed her intercalated BMS in molecular pathology at Dundee University, UK, and graduated from Aberdeen University from the medical undergraduate studies and postgraduate in diabetes and endocrinology at Newcastle University. She was awarded the Fulbright Fellowship to Harvard Medical School, Boston, USA, to complete 2 years in clinical research. Dr. Al-Ozairi holds the American Board for Physician Nutritionist Specialist, and she is a fellow at the American College of Nutrition and completed Rapkin Fellowship in Medical Education at Harvard Medical School. She is a reviewer for Lancet Endocrinology, European Journal of Endocrinology, Diabetes Medicine, Obesity, Surgery, and Frontier in Endocrinology. Her topics is Advance in Medical Intervention of Obesity. Dr. Iba, you are welcome.
Thank you so much for the introduction. It's my great pleasure to be with all of you here. And I would like to thank the organizing committee for inviting me. Also, I would like to congratulate the Bahrain Diabetes Society for now joining and becoming the World Obesity Federation accredited center, a member of the centers in the World Obesity Federation. So today my talk is about the advances in medical intervention of obesity. I come from Desman, and probably if you know Desman, this is a center of excellence that publishes 100 papers per year. So we're very active when it comes to research area. These are the objectives for the day. So we're just going to see what are the new revolutions that we have in the medications and pharmacotherapy, and how did we look at it beyond what we thought of just weight loss medications. Okay, so the good news, it is not really necessary to achieve a normal body weight to achieve health benefits. What we're now redefining the clinical obesity definition. So what you will see that we have new definitions for the clinical obesity. And what is it? It's whatever impairs health. And today we have the weight management intensification. So with anything that we say, we have to really start with lifestyle intervention. So this is a must, and it has to be there for whatever we practice. Then we have our new medications. We used to have a gap between the medications and the surgery, where the endoscopic procedures were in between. But today we're happy that we were able to close the gap with our new pharmacotherapy treatments. But still, we're not able to achieve surgery yet, but we're very close yet there. So these are the surgeries, and until today, they're the most effective when it comes to weight loss, but we have closed the gap. And this is really important. So I'm part of the Lancet Commission on Clinical Obesity. These are the new guidelines that will be published in January 2025. I cannot tell you what is the new definition because we have embargo, but it is all about how we redefine clinical obesity. So this is really looking at, there is a limitations of BMI. We know that we used to do the Edmonton staging. Now we are going above and beyond with a new definitions of what is illness and health when we still have obesity. So I would ask you all to look forward to it. This was a commission of 57 groups around the world, and starting from across the whole world of where are the commissioners are in field of obesity, really to commission the new definition of obesity. And it has representation within also the Middle East, Asia, China, India, Europe, and the States as well. So what has been happening in the anti-obesity treatment? Well, we know that is not something new. So we have the first, anti-obesity treatment was there back in the 1933. So it's been ages when things has been, in the obesity treatment. But we have been so unlucky that over the years, if you see, we have a lot of withdrawn from the market due to side effects.
So until, prior to that, most of our medications were withdrawn due to side effects. But until the nutrient-based therapy, and that's where we have a major revolution in the discoveries of, anti-obesity medication. And when people say, is GLP-1 safe or not? The first GLP-1 really introduced and approved for diabetes was back in 2005. So they have been around for more than 20 years. And people would still say, is it safe? Is it not? We already have a data for 20 years. And then you see it took us almost 10 years to get it to move to the world of obesity. And then once we are in the world of obesity, then things has been really progressing of how we change the revolution about it. And in anything that we do in medicine, physiology is our backbone. So physiology can predict your pathophysiology, and physiology will lead you to pharmacology. And that's why when I used to teach medical students, I would say physiology is really important. And if we look today, as you want to look at what is the native GLP-1 and how we have progressed over the years to move it to our new GLP-1 therapies and the dual therapy. So the native GLP-1, you can see it, the 38 chains of a half-life of 1 to 2 minutes is deactivated by the DP4. When we had the first, liraglutide, all what we did, we added the carbon 16 to the fatty acids, and we just switched arginine to lysine, and that's how we got our, daily liraglutide. Then we moved to semaglutide, we added a longer fatty acid chain, and we replaced at, 28 for arginine, and that extended our half-life to 165 hours. But if you see, it has really very similar homology of your GLP-1 native. And if we look at what we have today of the dual agonist, you're going to see that it has both the GIP and the GLP-1. And then, sorry, it's just they couldn't. And then we see it's a very similar to homology to what we see in real life. And that's what we have really extended. So today, we really have a landmark in history of medicine. I would say the first landmark was the penicillin discovery, the insulin discovery, and today with our nutrient-based, GLP-1 and hormones, what we have is the recent discovery of the current era of the second generation medicine. So that's how we have moved in the history of the landmark. So how did we move into this, and how did it affect into our treatment and the pharmacotherapy? We have the dual GLP-1 and GIP, all well known about it. And what is really different here, that you see 97% of people would lose weight compared to previously where we say poor responders and a good responders. And then even with the higher dose, you still have, 66.9% lose weight. So this is really magnificence of what we had in the previously. So you can see, and what we aim today is not 5% weight loss. So if anyone tells me I have a treatment of 5% weight loss or 7% weight loss, we say we're no longer here speaking about weight loss. What we're speaking about is the health gain. So it's not about treatment for weight loss. We do not look at people with weight loss. What we look for and how we really mark people is what is their health gain. Even if we look at, semaglutide, which was once weekly, that is GLP-1, prior to the dual GLP-1 GIP, it's again a major discovery in our, world. So in semaglutide, 92% of people lost 5% weight loss, but again, you have 78% of people that have more than 10% weight loss. Again, a major discovery of what we can do in our world of obesity. And that's where we want to move ahead and how we can look into things. But what has really been an changing and a game changer is SELECT trial. I have never ever thought this trial will ever be completed, never thought this can be done. And this is where they have, recruited more than 17,000 people with no history of diabetes and, are at a high risk of cardiovascular disease and this has shown that you can reduce the MACE by 20%. So it's not only about, disease, of obesity, it is what we look for, disease-modifying agents. And now today we know if we can use semaglutide of 2.4, we can reduce 20%. And that is not only that, most of the people, even who had pre-diabetes, we can convert them to normal glycemia with more than 80%. And that is really game-changing. And that's what was really made as the breakthrough of the 2023 cover of the Obesity Journal. So that was the cover of the Obesity Journal. And if we look into it, and that's again on the cover, as the GLP-1 story continues, one thing is clear, these new therapies are really reshaping not only the obesity, but how we really understand it and how we go beyond it. And if we look, when we used to look at, our plate, we now look at obesity really meeting Earth's match. And that was a major breakthrough in 2023. If we look at within the SELECT trial, and we look at the disease-modifying agents, again we see it is above and beyond where it can be for the first time a treatment for select heart failure. So for those people who have preserved heart ejection fraction, HFpEF, then this is the first time ever we have seen we can offer these people a treatment, and it can also does a great improvement in exercise and many more. And this is a major breakthrough. Not only that, it's not about only improving that, but it's improve your feeling function. And even the Summit trial now that's using tirzepatide, you see it's reducing hospitalization. And now they're, really putting for FDA approval for the indication of HFpEF as well. So this is major through. And then when we go like above and beyond, and we see what is about the chronic kidney disease, we see that, on the FLOW trial, again, semaglutide in people with type 2 diabetes, we were able to, improve the outcomes and have 24% risk reduction. So these are safe medications that we use even in, low eGFR, and we can protect the kidneys above and beyond. So it's not about weight loss, it's all about health gain and how we can improve things within. And this is just the beginning. There is a long road and a very bright road among us, and this is just the beginning. Everything that's happening in our physiology, it's happening with the backbone of GLP-1 or GLP-1 and GIP. Then we're adding a lot of new molecules to it. So what you will have soon coming, and that's all in phase 3, is the triple Gs. And that is really outstanding results and really closing our gaps. We also have new smaller molecules, and we now have, that's undergoing a medication that you would need to take only every 3 months instead of even not once monthly, but every 3 months. And that is all in phase 3 at the moment, again going on the backbone of your GLP-1 and GIP. And the mean weight loss in these phase 2 trials of the new medications, whether it's survodutide or retiritide, were reaching up to 25%. So this is really closing our gap with, what we had in the previously. What about above and beyond? What is the effect on obstructive sleep apnea? And this was just published in the New England Journal of Medicine, showing in the SURMOUNT OSA that tirzepatide was able to reduce obstructive apnea and reduce the need for the CPAP machine. What about, MASH? So again, this is the first time ever that we had a phase 2 that was able to reduce fibrosis, and not only that, but it's going even above and beyond, and now it's going up in phase 3 trials. So we have very strong medications that are disease-modifying medications. But with anything that we do with weight loss, we have to think of how can we really preserve the lean mass. Because with any strong weight loss, we would know that we would lose a lot of lean mass. And now this is why a lot of the new medications that's coming in, they're activating in activin and myosin in the compounds. So we will also not only promote weight loss, but also promote muscle gain. So there is a lot that is going on, and we have done a lot of the studies in Kuwait to show that, more than 50% of the people with type 2 diabetes have already, low muscle mass. And comparing to the UK Biobank, we're aging at least 15 years. So an age of 45 is equivalent to 60 years old in the UK Biobank. So we're already starting with a lower muscle mass comparing to elderly. So the pipeline, similar to what I have shown you in the beginning. We are really getting there, and you're seeing that we are actually receiving with the CardiSema and the reticulometide, really closing the gap, going above what sleeve gastrectomy can offer us today, and really reaching 25 to 28%. So the future is really bright, and we're really into the advancements of how we can move forward with what we have today. When we come to it, I think today we have redefined it. And today we have to look at it at the CKM, and this is what has been taken now in the staging of, the American Heart Association. So we no longer take the obesity staging. This is what we go for, is, the staging of the CKM, looking at cardiovascular, kidney, and metabolic syndrome, and that's everything that you would take into account when you're looking at your patients. So that's not the end of it. There is a much more bright, life is coming through. Today, we're very lucky that we have free apps, and these apps can measure, your body fat percentage, your lean mass, and muscle mass, and that has been validated against our gold standard DEXA scan. Many of us are in the obesity world and advocate for obesity, but when it comes to the gold standards of DEXA, we all say we do not have access to it, and we just go by the normal, techniques of waist or waist to height ratio, which is the new model. And I would argue that is because we in the obesity world have not been active enough. Our rheumatologist colleagues would not treat anyone without their DEXA. But when it comes to obesity, we argue against DEXA is expensive. So it's time for us to rethink of how we have to really move and shift to the obesity world above and beyond what we used to practice. And this is the latest. It's currently, under trial. So this is gene therapy, and that's where they're looking at gene therapy now. It's already recruiting, and this you need to do it once a year. So you would need to do this once a year. You inject RNA virus into yourself. It does, low dose of viral sectors, and that's what it will lead to systematic biodistribution. The results look, kind of promising, but still ongoing, but it's already, ongoing, and there's 2 companies doing that for the injections of the, gene therapy into humans. So we still have many unanswered questions. We moved along, and we have done amazing work, but what do we really need? We know today we need a much more skills people required beyond writing a prescription. I think as a medical physicians, we're all good at writing medical prescription, but we have to think how we're going to train these people, and that's what I would advocate for all people in obesity, whether it's dietitians or surgeons or physicians, all of them to be at least scope certified. So we're all speaking the same language. And can we really develop policies that all people can have access to these medications? Because today, we know they are very expensive and they're luxury medications. How are we going to promote the access for the people? And what are the really downsides of these medications? Do we need to use them for life? Can we do intermittent use? Can we go to lower dose? So these are the things that would need research to come in. So it's not about, lifestyle or pharmacotherapy or endoscopic procedures or surgery. It is about how we utilize every single tool that we have in the box and can offer the best for our people today. So what do we want really? We want a society that is living longer but with better physical function. We want to prevent and treat of the excess adiposity, and that's what we really aim for. So watch out for the new Lancet Commission that will redefine obesity. It will be published in January 2025. I am one of the co-authors, and that is really redefining the clinical obesity and how we look into it. And with this, I would really like to thank the group back home. As I said, we publish 100 papers per year, and we have a huge group that is working in all areas. And without this, we cannot do a lot of the work. and also would like to thank my mentor, Professor Don Arayan and Professor Carl Leroux, for a lot of their input. And I would like to congratulate you all again, and thank you for inviting me. And we have a long road, but it's a very bright road that we're going to close the circle of what we're going to offer to our people. Thank you.
Thank you, Dr. Eva, for your excellent presentation. We'll leave the question till the end. No, okay. Dr. Eva is having some commitment. Please, if you have questions for Dr. Eva. Dr. Khawla, can you handle the speaker to Dr. Khawla?
A very quick question. Many of our patients can't afford them long term, so what are your strategies in clinical practice to minimize weight regain after you stop them?
Perfect. So I think for the moment, we're not going to in few years, in 3 years, semaglutide will be off patents. Liraglutide is already off patents. So these things are going to be very cheap. So already we have liraglutide being manufactured in India. But what we say today, what we need to advocate is for access for these patients. There are many strategies that you can use for these medications. So I don't think you need to use them as label. And we know that what you would need probably not to titrate as fast as what the label tells us, as long as we get the health benefits. Please remember, it's not the weight loss, it's the health benefits. If I have a MASH, and if it's, I can reduce the fatty liver and put it back to normal. If I have diabetes, can put it back to normal glycemia. This is what I achieve. It's not about the weight loss or for cosmetic reasons.
Doctora, thank you for a very nice talk. I would like to even emphasize one more thing, which is treating the obesity in childhood. The statistics indicate that our area is one of the worst areas in the world for obesity. And the rate among children is scary. So what are the efforts in the GCC to combat this epidemic? And what is the future medication-wise to prevent obesity in childhood?
So there are two things. When we come to treatment pharmacotherapy, semaglutide is already approved for use of children from 12 years old onwards. And tirzepatide is going to come soon approved because they're just going to finishing their teen study. So these would be medication that we can offer. But what we really aim is for prevention, and that is a huge thing that it does not involve the medical. It goes above and beyond, and each country has a strategies. But if we're going to medicalize obesity and think of it, the medical people would solve it, then we would never be able to solve it. It's a multidisciplinary that needs all the community. And it's above and beyond that what people think it's easy. But digital technology has been put in forward, and I think the future is very bright because we will be able soon to genetically predict who will have obesity in the future and who will be able to go under pharmacotherapy or under lifestyles or under surgery right from the beginning. We're not yet clever enough at the moment, but it's soon coming, and there has been personalized medical scores and genetic scoring that you can do for the future.
Thank you for a nice presentation. And as we know, we will not have you later on for a discussion from a gastroenterology point of view, surgeon point of view, and a medical point of view in general. But I guess one point I want to emphasize on, and maybe ask about it as well, is when it comes into advising my GI patient, I'm a gastroenterologist, and when I come to advise my patient about which injectable you're going to use, I personally prefer to use for them Mounjaro, or trapezuide, than versus Ozempic, because of the less side effect profile on that. And I see it in observation, and we see it in studies as well. But I don't know, why do you think that is the case, and especially that the dual is less on the GI symptoms or not? That's an emphasis and maybe a question on why it is less on that aspect. And do you see that? Do you advise for it as well?
The dual GLP-1 GIP has a less GI side effects, and that is the beauty of combining the GLP-1 GIP. The only downside is the price, of course. It's much more expensive. And that's what we say. We use it when I need to get to my disease modifying.
So if I am not able to reach it with the lower agent, then I would use it. But it's definitely, if I have the luxury of money, surely it's a more effective, medication. And, it will soon get out of fashion because of the newer medication that is coming on board, of the triple Gs, cardisema, and many more. So we have a magnificent tool today, but it's going to get even better. And the side effects would come less because of our physiology and how we're backboning everything to our backbone.
Thank you, Dr. Iba, for your excellent speech. We'll move for our second speaker, Dr. Hani Saati. He's a senior consultant general surgery. He's consultant surgical oncology, MIS HPB, upper GI, and bariatric surgery. Dr. Hani specializes in minimal invasive surgery in oncology and bariatric surgery. He's affiliated to 4 hospitals at Kingdom of Bahrain, King Hamad University Hospital, Bahrain Oncology Center, Bahrain Specialist Hospital, and As-Salam Specialist Hospital. Dr. Hani has a vast experience in the field of minimal invasive upper GI, HPB, and bariatric metabolic surgeries. He has completed fellowship training at the University of Toronto, Canada, and Southampton University Hospital, UK. Dr. Hani has a vast experience in interest in internist in retrospective bariatric metabolic surgery. Dr. Hani, please, your speech is advanced in surgical intervention for obesity.
Good afternoon. Mr. Chairman, ladies and gentlemen, thank you for giving me the opportunity to give this talk today. Actually, when I've been asked to give a talk about the recent advances in surgical intervention for obesity, I thought, well, my talk won't be much of biosciences. Rather, it would be more talking about a technology aspect in management and obesity, especially in bariatric surgery. So go back to world statistics. As we can see, the rate of obesity has been increased since 1975 to triple, and then 5 times in children and adolescents. And that accounts for a 40% in adults and 20% in children. As you know, and everyone knows, me and you know, that obesity has linked with the non-communicable diseases like heart, diabetes, cancer, and etc. So, and it accounts about 71% of mortality globally. So what about us here in Bahrain? Do we have increasing the trend in the obesity prevalences? Talking about the statistics shows since 1999 till a date, the statistics are growing up. Speaking about the overweight, which accounts about 70% of our population. Specifically, when talking about the high BMI, we are talking about 40 to 35%. As you can see, this goes together parallel with the increased number of type 2 diabetes, coronary heart disease, and stroke, and etc., and the cancer. So what the economic impact actually in Bahrain? In 2019, the economic impact of overweight and obesity estimated about 891 million. So the direct cost goes about 14.5% and indirect 85.5%. So we are expecting by 2060, we're going to have the expenditure of $11 billion. And that you can see the total economic cost, which is percentage of per GDP, from 2.3%, it will reach up to 3.26% in 2030, and increase that to 7% in 2060. So that means that we need to think economically and how we deal with this issue, the obesity. As incidences increases in Bahrain, so we need to adopt a perspective in management of obesity. So talking about the perspective, we notice that the projection increase in the adults and children is 1.7% yearly in adults and 1.4% increase obesity in children. So looking at having an insight, the rules of behavioral rule, behavior management, pharmacotherapy, and surgical management. So we need to have an insight how to deal with the obesity from those three aspects. So bariatric surgery versus pharmacotherapy. My colleague, Dr. Iba, thank for her, she covered the medical aspect. So my question, is it a market battle? So look at the obesity treatment market since 2019 and till expected 2031. As we can see, the market expected to the compound annual growth rate increased to 10%. And that means 37% the market has revenues from the obesity management, totally. So based on technology, we are talking minimal invasive surgery. So the technologies is expected to register the annual growth rate of 11%. Looking into bariatric surgery, not obesity in general, we can see the market is promising. So it shows that increase about 9% of the annual growth rate. That means that the revenue has increased to 32.8%. The global market revenues accounted, that is accounted in North America. What about the pharmacotherapy? Do they have a market? Yes, the market will be, you can see, growing at the compound annual growth rate of 80%. That increased to $482 billion. So the yearly over year, the growth from 2019 it was for 2019 about 8.8%. So with that, we are talking about a big market revenues and challenges. So who will put his hands on the big portion of the market? It's a battle actually between the bariatric technologies and pharmacotherapy. It's not only about medicine. I'm just trying to drive you from different aspects. So talking about the bariatric surgical industry. So our approach is the focus on surgical and device-based interventions. It means that we are relied on technologies, which primarily will treat the severely obese and which qualify for our the invasive procedures. Talking about Roux-en-Y, gastric bypass, sleeve gastrectomy, mini bypass, and innovations of something which call it bari clip, is without surgery, just put a clip and create a pouch like a sleeve. So in our innovations, looking for stapling technology, advanced bipolar technology, advanced ultrasonic technology, those the technology we use it to treat those patients. Especially also talking about robots nowadays and bari clip and artificial intelligence. So why it's important, the technologies of stapling, we are focusing about how we minimize the complications, decrease the bleeding rate and leak rate to less than 1%. So the evolution of the development of the stapler technology has developed from normal stapler in the past. I don't know if I have a point. Till we have the tri-stapler, smart tri-stapler technology. That means that they are stapling in three thicknesses. That minimizes the leaking rate, the bleeding rate. So the newest technology of the stapling we have with Himayah Mudha'afa, which is the reinforcement, the stapler, which we call it with reinforce, as you can see there in the picture, with a special lining, that prevents the bleeding. So, are we using automated stapling technology or hand? These are all companies, they compete each other to show who can put his leg in this market. So we are talking about market, not only medicine. Yes, it serves us to make the surgery more convenient, more easier, less complication, less hospital stay, but the background is the R&D, research and development, to put hands on the bigger market here. So talking about advanced bipolar technology. We are talking about how we are resecting and doing the surgeries. It's not in the old time we are doing this with hands and tying. We are relying on technologies like vessel sealing technology, which cuts and seal the vessels precisely. So here we're focusing how the heat distribution should not be more than 3 or 4 millimeter. So that means that you're talking about precision, doing the surgery, focus on vessels, not beyond to the neighborhood tissues. Also, we're talking about the efficacy. Is it effective? Is it more, how we can say, hemostatic? So these things we put in mind in the R&D in the surgical technology. And also we have something called ultrasonic dissectors. This is works with vibration, not electrodiathermy, not the heat. The vibration of the jaw of those devices creates the heat and dissect the vessels and create the hemostasis. Just let you see a video. We can turn on the video of the Barry clip. This is the new innovation and the surgical. It's non-cutting surgery. Creating a clip or like a band vertically on the stomach to create a sleeve. Like this is minimal invasive. So we are looking for something. Patients, they are looking for something less invasive, less cutting, no bleeding. So as you can see, this is the stomach. And as we hold the stomach, we create a space only behind the stomach. And that space, we insert the wire to drag the clip. And this clip, actually, we're going to leave it vertically as it's shown in the video. So bringing clip through without doing a lot of tissue damage or cutting anything, just put it on the stomach. What's going on? And clip. Simply as that. As you can see, this is the excluded part of the stomach, and this is the part of the stomach which looks like a sleeve, small stomach. And we're going to fix that there. So how about the robots? Of course, robotic surgery has entered the field of different specialties in surgery, and focusing on bariatric surgery, oncosurgeries. Talking about bariatric surgery, so the famous robots we're calling Da Vinci robots, you can see multiple arms. That gives you that removes the pain from the surgeon's shoulder, put it on the robot, and surgeons sits on the side and do the surgery without any pain, and has very precise movements. Very precise energy using the energy devices. For instance, this is a Da Vinci, and the other robot, we call it Hugo from Medtronic. We have it in Bahrain nowadays in the Royal Medical Services. What's the role of the AI? You know, the AI has entered the market as well, and the health market, we can say. And we can use it as preoperative planning, intraoperative. Assistants can tell you, the AI, where is the bleeding potentials. Sometimes the surgeon focuses on the surgery, not seeing the other part, but that monitor recording everything says where is the bleeding, which you can tell you where is the bleeding. Also, AI can tell you, is your stapler adequate for this tissue for stapling, or you need to go for something more deeper. Can tell you also the energy you're using on that tissue is adequate energy, or it is dangerous, you should go for less. This is really a second assistant for the surgeon. As well, the AI can give you the analysis of your surgery, how much you took time doing this dissection in this stage and that stage and that stage. So you have biofeedback, not biofeedback, it's AI feedback, how to do your surgery and perform better. At the end, bariatric surgical industry has advantage, rapid and substantial weight loss, because the patients want to see the results very early. It has a long-term resolution for obesity-related comorbidities like diabetes and hypertension, and no reliance on lifelong medication. So, now if the concept we think is different than a physician you think. You would like to change the patient's medicine to other medicine. I'm taking the insulin, I'm giving the patient semaglutide. You're taking the patient's pills, glucophage, but you give the patient, for example, liraglutide. The problem here, the patients are non-compliant. Patients want to be medication-free as well as disease-free. So I won't be biased for surgery. That surgery, yes, it has upfront costs, but for the overrun, it has what's the durability and the sustainability. And this is the challenge between the pharmaceutical treatment and surgical treatment, how we can be sustainable. And I think we're going to talk about it just in a few slides. So challenges the cost, invasiveness, and limited the patient meeting the BMI. In surgery, we have limited BMI we can rely on. However, the medical treatment, they are expanding, and expanding. As we can see how the market has expanded. Talking about pharmaceutical obesity industry, I'm not going to details, as already my colleague has spoken. You can see the evolution of the weight loss medication since 1999 till today. Start with Orlistat, then we reach to Saxenda, then we reach to Wegovy, and today we're talking about the Mounjaro. The advantage here is non-invasive. Yes, patients are looking for less invasive treatment. Okay, it's accessible with a fewer barrier for use. However, expanding the indication, the medical treatment is expanding to prevent the diabetes and cardiovascular disease. Their challenges, I would say, long-term use. For how long we can use that? I think one of my colleagues asked Dr. Iba, how long we can use, when you should stop. And the high cost, how long I have to pay for that? This is also one of the challenges the pharmaceutical company should think about. And the other thing is the side effect and limited effectiveness. We are talking about 60% the weight loss, excess weight loss. And you are talking the best, the GIP, GLP-1 medication, talking about up to 20%. Well, the key points here, are we overlapping the market? Due to improvement of effectiveness of the pharmaceutical solutions, increase the targeting, same population we target as bariatric surgeons in severe obesity. The efficacy debates, surgery generally leads to a greater weight loss. New medications are narrowing the gap, coming very close to surgery, comparable to improved metabolic health in the same patients. The cost is really dynamic. Now, the pharmaceuticals, the costs are ongoing, but less invasive, appearing to patients reluctant to undergo surgery. That's which is good. However, the bariatric technology, it has high upfront cost, but can be a cost-effective over the time, especially we are talking about fewer recurrences in the obesity. So what about the perspective from healthcare provider? Yes, if I am physician, internist, I will lean toward pharmaceutical treatment. If I am a surgeon, bariatric, I would advocate surgery. So what's the answer? The future trend. Pharmaceutical industry should expect capturing a larger market, and bariatric surgery technology also looking to be very competitive with the new innovative techniques, especially talking about the endoscopic devices. By the way, the endoscopic devices we consider as in our side, not the medical side. So both sectors are in competition. At the end, this is my answer to you all. The hidden competition. So we are talking about pharmacotherapy, industrial technology. We should not compete, we should work together. Robotic, bariclip, minimal invasive surgery, GLP-1, GIP receptor agonist, all together, we have run further than ever before. At the end, I'd like to تقديرا لإسهامات لاعبين المخضرمين أحمد رسم حمارة في الأولمبياد and the congratulations Olympic team Bahrain for this historical achievement. I mentioned that because, you know, sport and physical activity is a part of our obesity management mission. Thank you.
It's player calling dear Dr. Umar Sharif from Bahrain.
Yeah, thank you, Dr. Hani, for your excellent speech. We'll leave the discussion till the end of the sessions, or second session. We'll go for the introduction of the second speaker.
It's player calling dear Dr. Umar Sharif from Bahrain from Advanced Endoscopic Bariatric Intervention. He is the Chief of the Medical Staff and Consultant Gastroenterologist in King Hamad University Hospital. He holds the American Board of Gastroenterology and Hepatology. He is a senior clinical lecturer in the Royal College of Surgeons, Ireland Medical University of Bahrain. He is interested in biliary interventions, endoscopic solutions for weight loss management. He involved in multiple clinical studies and is participated in multiple publications. Please.
Thank you for inviting me to have this presentation in this nice conference, and welcome everybody. Is the presentation up? Excuse me. Excuse me, can you get the presentation up or not? Okay, thank you. So today I'm going to speak to you about, so we had two excellent speakers this morning, Dr. Hani from the surgical point of view and Dr. Iba from the medical point of view. And when we talk about intervention, I always tell my patients, what is the best way to lose weight? We always say diet and exercise. But then again, as doctors, we need to get in and intervene sometimes. And you've seen both spectrums in there and the advances that we have in there. And then comes in, and this is the talk I have with my patients every day when they talk to me about, doctor, I want to lose weight, is what can we do? And then we come here for endoscopic bariatric intervention. So today, we're going to speak about what kind of things we can do as a gastroenterologist. We're very happy to have Dr. Najah here, okay, my mentor and an idol. And we talk about GI interventions and stuff. And these are the things that we can do as gastroenterologists. Intragastric basket balloon therapy, we're going to speak about it a little bit. Gastric buttocks, you've heard about it. We might not do it that much, but we'll talk about it a little bit and discuss the literature in the time allowed. Indoluminant duodenal sleeves and is something that has come up, and there are some benefits, theoretically at least. And then endoscopic sleeve gastroplasty, I have a special interest in it, and then that's the major thing that we had some more data in it in the last few years. So, again, there's a lot about obesity. We having this conference because of the emphasis on what obesity can do. Obesity possesses obvious healthcare risk, and a modest weight loss of 5 to 10% may be sufficient in most cases for reduction and for health benefit of weight reduction. There's a lot of safe surgeries that can be done, and when you talk about surgery in the past, like sleeve, how much leak can happen. Now with the surgeons, if Hani can do a surgery in a very quick time with very low risk of any complications. There will be a desire for some patients to seek non-surgical solutions has always been there, and that's why the pharmaceuticals have come up, and that's where we come in as endoscopies and GI and what we can offer with that. So people sometimes come to me, doctor, I know surgery is might be the best thing for me. I don't use medications, doctor. شعري بيطيح. I don't want that to happen. People come with those arguments. I want something that can be done, can go home the same day, and with least intervention. And this is where endoscopy comes to play. And we'll bring you the data on that. So let's speak about intragastric balloon therapy, okay? It's been there for some time, and what happens is basically, we'll go over it quickly, but a balloon is placed in there, in the stomach. So the idea here is early satiety. A lot of things can be done with that. Lifestyle intervention is the first-line therapy always, but intragastric balloon is indicated if the BMI is more than 27 in Europe or more than 30 in USA. And for BMI of 27-35, intragastric balloon can be used in early intervention to reduce weight, and that sometimes can be used as a bridge before surgery. So for BMIs above 40 with 35 with comorbidity, surgery is a better option, but intragastric balloon can be an alternative. And as we said, for very high BMIs, intragastric balloon can be used as a bridge. So how can it be done? We'll talk about the way it's done and what are available in the market, but contraindications of previous gastric surgeries or coagulation disorders, and bleeding lesions, pregnancy, alcoholism, severe liver disease, and contraindication to endoscopy. Relative contraindication if they had previous abdominal surgeries or large hiatal hernias, but still can be done. IBDs, use of NSAIDs can also be an issue, okay? So there are multiple ways that can be done. There's the Orbera, it can be done with endoscopy. We go with the scope and then pass a catheter into the stomach, go with the scope, look at the catheter, inflate the balloon inside the stomach and leave it. Sometimes between 400 ml to 800 ml. Accordingly, we can place it in the stomach. It will induce satiety, but I tell patients, you'll be very miserable with the nausea, vomiting, and we hate doing it. I'm telling you that. So although I do give it to patients, there are some benefits with it. We use a lot of pharmacological therapies to help them out on reducing any of the side effects, but it can be very symptomatic in the first at least 72 hours of insertion. But this is one that can be placed endoscopically. There is the reshaped dual gastric balloon, and that is also, I'm talking about here the FDA approved one. So, and the thing that we have data on them, and they are in the market. That's the reshaped dual gastric balloon. We don't have it in Bahrain, actually. I think the agent came in to me and talked to me about placing it, but it's like 2 balloons at the same time. Can be done. So, have some benefit that you have 2 balloons instead of 1, maybe some more weight reduction, but also some more symptoms as well. The O balloon, we don't see it as much right now, okay? It's inserted under radiography. It's not FDA approved, but again, it is something that has been there in the market, and we are seeing more the ellipse right now. That is, we'll talk about in a minute, that can be placed without endoscopy. A Spatz balloon is one that placed endoscopically as well. The good thing with that is that we can actually, it can stay, and we can deflate or inflate more according to symptoms with endoscopy. The catheter that is there at the tip of it can basically be used later on, and we can inflate or reflate for that. That's the most one that was there, and that have not yet FDA approved. They did not get the FDA approval yet. It's placed actually in the clinic, okay? You can go in the clinic, do an x-ray, place it, the patient is awake, you put it into the stomach, inflate it, and the good thing with that is biodegradable. So you just place it, we fill it up with a standard amount, and you confirm with x-ray, and the patient goes home, and basically they come back later on. It just degrades by itself and comes out. So that's a good option that can be placed, and we'll talk about the data that we have. The average overall excess weight loss was around 33% or 10% total body weight loss in most in the combined studies. In retrospective study F 1,221, the mean total weight loss was 6.2. Okay, overall Brazilian experience of 40,000 patients showed around 18.4 plus minus of excess weight loss, and then 2.9% plus 18.4 of total weight loss. I think that might be an exaggeration, but that's basically what some literature are reporting with that. In the meta-analysis of Orbera, 1-year balloon, the total weight loss was 12.3, 13.6, and 11.27. And that's kind of comparative to some of the data I'm presenting for you for endoscopic sleeve gastroplasty and with even some of the other bariatric procedures that are there. Average estimated excess weight loss was 32.1, and average reduction of BMI was 5.7. So some good data. What's the long term? That's the question. How much of the long term can be done with that? There's some studies that come up with use of balloons plus pharmaceuticals, okay? Surgeries plus pharmaceuticals, endoscopic sleeves and some pharmaceuticals, and that is something that we'll talk about in a minute. Long-term studies showed 26% and 25% of excess weight loss at 3-6 months after removal. So good data that can be done. We did our local data in KHUH. We did 57 patients, and with average reduction of BMI was 3.67%. Average total body weight loss was like 10.48, and average excess weight loss was 27.21. Mean weight loss was 9.7, plus minus 8.7. So I have some patients that I always bring them up. He lost 25 kgs, looked like $1 million after that, went home, and then he was fine. We removed the balloon, he was fine, came to me 2 years later, gained the whole weight back again. I placed another balloon for him. He lost the 25 kgs again and came back again. Haven't seen him for the third time yet. Okay, but again, it can work. But again, rebound, how much is that? The side effect, the cost. All these things are there. So yes, there are some good data. There are some benefits from that, but we have to know that sustainability is an issue. There is some even data about improvement of metabolic parameters, okay, with endogastric balloon. The adverse events are that we see is majority will experience GI-related symptoms, and that is the main thing that I worry about and tell my patients about it. Serious side effects are there. Migration of balloon can happen, intestinal obstruction can happen, severe vomiting, GI bleed, esophageal-related, esophageal tear can happen, pneumonia can happen, obviously very low, but with a large amount of study, procedures that are done, there are actually even mortality that had been reported with that, okay? So this is with the balloon, and I'll wrap up my experience later on about it, but balloon is a good option, and we'll talk about my summary in the end. Gastric Botox, technically speaking, we go into the antrum and inject Botox in there, will cause some paralysis, and that can technically induce satiety and stuff. Randomized controlled trial, 24 patients showed reduction of gastric capacity, another randomized 30 patients, the studies are very low. Anyways, meta-analysis in 2017 showed no significant changes. We don't do it, we don't advocate for it. Maybe Dr. Najah can tell us about it. Came up at one of the times that, oh my God, it was something. People go to Lebanon and get this gastric Botox. Fantastic, they lose weight. It does not work, so we don't do it. Duodenal endoluminal sleeve, technically speaking, you can see something like that can happen. Place something in the lower esophagus into the duodenum. There's another one that you can go into the duodenum and ablate in there. Ongoing studies are there. There's a major study that are ongoing in Europe about going to the duodenum and ablating the mucosa. And the idea here is that induce similar metabolic effects that can happen with bypass. So technically speaking, you can induce some of these GLP and GIP rise that can happen. And I always tell my patients, where did the GLP and GIP rise come happen? Is from the bypass surgeries. You notice the increase in the size and these hormones, and that was noted. So you can do similar things with these kind of things. Promising things. There's ongoing study, we're waiting for it, in a study involving 46 patients, 24 weeks post duodenal mucosal resection. A1C reduction was noted. Okay, fasting blood sugar reduction is noted. Weight was modestly reduced, but was mostly metabolic effect of this. So the DMR is something, and I think that they did not publish their final data yet, and was Repice, Dr. Najah was involved in one of these in Milan, and they were involved in this kind of a study, and technically it can be a promising thing. So no surgery, just go there, ablate the duodenum mucosa, and maybe have some effect with reduction of HbA1c and fasting blood sugar. We don't do it in here. I'm not involved in the study in here about it yet, but something to consider. But the problem is, it's costly. You convince people to do it, and I don't know if people want to do it with that. Let me talk about my endoscopic sleeve gastroplasty. So ESG is an incision-less procedure, and this is what we're gonna do with that. Okay, so this is the way it's done. So technically speaking, the way it is done is it's done endoscopically. Similar to the sleeve, and we've seen with Dr. Hong, the back lip and stuff, is that we reduce the size of the stomach by doing this kind of a shape. It's like instead of cutting the shirt that is the side, you just like wrap it up from inside in this way. It's done over a scope. So the device is put in on the scope itself, and basically that's how it's done. So it's like a needle holder and something that grabs the mucosa with that. And basically what we do with it is we go through the stomach, and then as you can see in the video in here, you put it down and inject, pull this stomach there, put in a suture, take 1, 2, 3, 4 bites, and then eventually what will happen is you will reduce the size of the stomach as you've seen in the initial video. So the study had been first started the first published data were in Mayo Clinic in 2013. We've seen more and more coming into this part of the world 2016. And now we have a lot of data, and the EFSO did recently endorse it as a study, and we'll talk about the data that they have. So there is 70 to 80% stomach reduction with that, okay? And what you see with it is total body weight loss is around 14%, and excess body weight loss of like 49%, and some of these studies that have been done, the MERIT trial, and some more studies that we see, and I'll talk about it in a minute. So the good thing about it is that it's done endoscopically, no surgery is done, and there's good data with that. So how sustainable it is, we will see with time, but we have data up to basically 3 or 5 years. There is some sustainability of reduction of weight with that. So mechanism of weight loss appears to be purely restrictive. An element of delayed gastric emptying could happen. The hormonal effect that similar to what happened with sleeve gastrectomy or with bypass does not appear to be there because the stomach stays there. In theory, some delayed gastric emptying can happen with that. That's the MERIT trial that got the FDA approval in 2022. In a multi-center study, 209 individuals with class 1 or 2 obesity underwent ESG, lost more weight than controls. 13.6 total body weight loss versus 0.8. So this is for basically diet and exercise. And that's what FDA needs. 49.2 versus 3.2. 80% of patients underwent ESG had an improvement in 1 or more metabolic comorbidities, where 12% worsened, compared with control group in which 45% improved, whereas 50% worsened. At 104 weeks, 68% of the patients who underwent ESG maintained more than 25% of their excess weight loss. ESG-related serious adverse event occurred in 2% of the participants without mortality and need of intensive care after the surgery. And serious side effect, we're talking about perigastric leak, GI bleed, self-sustainable. Most of the perigastric in the studies require drainage endoscopically sometimes, and that's it. The side effects are GI related mainly in the first 1 or 2 days after the procedure. So overall, well tolerated with less morbidity. And this is a short-term outcome of endoscopic sleeve gastroplasty in 1,000 consecutive patients. So this is some data from a single center. You can see the side effects or readmissions after ESG were mainly for fever. Perigastric collection happened in 4 cases out of the 1,000. Severe abdominal pain, nausea, and 8. Blood loss, 7%. And then you could see there is 8 of the patients had revision of gastrectomy afterwards, and redo ESG was done in 5 cases. And you can see here on the left lower side, excess weight loss and total body weight loss, 10.53 months, 13.76 months, 15 in 12 months, and 14.8 in 18 months. And there's some change in comorbidity that could happen. This is a study by Damar al-Gahtani, and he's done it he's done a lot of cases, 3,000 cases in here, and he compared basically ESG and LSG. He has the advantage, he's a surgeon, he does it as well. And you can see this published data in GIE, that ESG versus LSG, you can see the comparative data in there. BMI was lower in the ESG side, but again, we'll talk about the indication with that is that it's mainly from 30 to 50 BMI is where you recommend these cases, and there's some data about 27 BMI and above. But here you see total weight loss, 14% versus 19% in the same group. Comorbidity remission, you can see comparative adverse events, 0.3% and 0.2%. So, and then you see here the revision of 80 were revised from endoscopic sleeve and underwent surgery, okay, and 28 had repeat ESG. So again, data, we can take it with a grain of salt, but you can see the comparison with the same surgeon, but here the surgeon can do either ways with them. This is the data we had in KHUH, so we did start doing it in KHUH, and I've done 87 cases in Bahrain in here. We had readmission for some symptom release in 2 cases, conversion to sleeve gastrectomy in 3 cases. But can see here, this is initial data that we have. Some of the important thing we have, on the right side there, the patient complaints. 22% had abdominal pain, 11% had some GERD symptoms afterwards, constipation 17%, nausea, vomiting, fatigue, and bloating. So these are the side effects that you can tell the patient that they will have. And I can tell you they are less side effects than the balloon. Okay, compared to what people have after surgery, but again, no surgery because it's all transoral. And the thing is here, length of stay. Because you could see 37% of the patients went home the same day, while 59% they stay for the 24 hours. And this is what I advise the patient to get in with that, is that you coming to the hospital, stay here, and leave in the morning. Just because to relax in here, ما تروح البيت ونطون اليهال على بطنك, okay? فيعني that's basically what I tell them. So they stay here 24 hours. And only 4% stayed more than 24 hours, and these are in minimal cases. And you can see here our data. Here you can see the median weight, 92 before, and then we have data up to 6 months. And inshallah, we'll have extension. Thanks for the team that's working on that here with me, the doctors in KHUH. 92 data perioperatively, 80, so reduction 12.5 median. BMI 35 median perioperatively, and then 30 in 6 months. And can see the total weight loss is 13.4, so comparative to what we have on the other data with that. So promising data, very good procedure that can be done with that. And this is the IFSO Bariatric Endoscopy Committee evidence-based review that basically they did recommend that ESG as a procedure that can be done for weight reduction as well. So that's a major thing, and this happened only September this year. So the IFSO did endorse ESG as one of the modalities that can be used for weight reduction. In summary, multiple endoscopic procedure that can be done. I would advise my patients to think of it. We have seen a big reduction with the use of all the pharmaceuticals on demand on all these procedures. But again, I tell them it's an option. Gastric balloon, good option if you want something short term. I want to reduce some weight and leave. But again, we have to understand the side effects and no sustainability. Gastric Botox, no. DMR, maybe something to think about. The metabolic and ESG has a big promise on that, and it's good that it's under. But the thing is, you have to talk about the cost. Okay, so the cost for it is high. That is something. So ESG is more expensive than bariatric surgery. Yeah, and just to, I don't know if I can bring in some money aspect to it, and a balloon can be done with something like 950 BD or something like that. And this, like gastric sleeve, some people do it in Bahrain for 1,400 BD to 2,500 BD or something like that. ESG will cost something around 3,000 just because of the cost of the device itself. And that's where the cost come in. Will it come down later on? Maybe. There's one study that actually did not show in here, compared ESG and Ozempic, and for cost effectivity. and actually did show ESG is more cost effective than use of Ozempic when you compare it for 3 and 5 year use of it. So for reduction. Sorry, it took a long time. I'm done with things, but again, very promising things, and thanks a lot for giving me the chance to talk. Thank you.
Thank you very much for a very elaborate talk.
Assalamu alaikum. It is now my great honor and pleasure to be introducing my brilliant teacher, Dr. Najah al-Zayani. Dr. Najah is a graduate of the AUB. She obtained her MD degree in 1977. She's an Alpha Omega Alpha Honor Medical Society 1975. She completed her residency in internal medicine in the States, and she's been American board certified since 1980. She did her GI fellowship at Baylor College, and she's of course American certified in gastroenterology. She served as an assistant professor at Baylor College of Medicine, and then she started Bahrain Specialist Hospital in 2002, and she's presently the co-chairman of this hospital. Please join me in welcoming Dr. Najah. Her topic today is metabolic liver disease, new insights in care.
Can you open it, please, from there? I cannot open it from here. Okay, I think I was able to manage. Thank you very much. I thank the organizing committee for giving me the chance to give this talk on the metabolic dysfunction-associated steatohepatitis. I have great interest in this topic because of the epidemic of this disease in our area. So I will summarize part of the work we do in our center, managing the metabolic liver disease. And my aim on this talk is to review the prevalence of this condition in Bahrain and in the Gulf, as well as globally. So the aim is to review the prevalence of this disease, define new terminology, because in 2023, this disease has acquired a new name, and I'll explain why. I will mention local experience we have developed at the Bahrain Specialist Hospital on validation of non-invasive testing as a method of screening for this disease. And I will also review new drugs in the management of fatty liver disease, both in metabolic associated liver disease as well as in MASH. This disease, to let you know, was renamed in 2023. So what we used to call NAFLD is now called MASLD, metabolic dysfunction associated steatohepatitis. And MASH replaced NASH, and MET, LAD, is metabolic liver disease with fat in addition to alcohol. And the reason these nomenclatures were changed is to avoid bias of calling it non-alcoholic, because when the patients listen to non-alcoholic, they immediately think that you're blaming them for being alcoholic. They don't appreciate that description. So people have decided to rename them and stress the metabolic part of this disease, because it's not only disease of the liver, it's actually severe metabolic dysfunction in the whole body. This disease affects between 25 to 35% of the global population. In our area, the estimate is between 30 to 33%, and as high as 68% among diabetics in Bahrain. The third of this population with fatty liver will progress into hepatocyte injury, inflammation, and fibrosis. So that's a very significant number. And hepatic decompensation and cirrhosis will develop over a mean time of 7.6 years after onset of this inflammation. 4% of these patients will end up with a diagnosis of cirrhosis eventually. Unfortunately, once they decompensate and they go into cirrhosis with severe NASH or MASH cirrhosis, the survival is only 2 years, so it carries a very high mortality. Hepatic steatosis is also an independent risk factor and a warner for development of hepatocellular carcinoma. Among the cases I have seen in my clinic, hepatocellular carcinoma was most associated with MASH cirrhosis in Bahrain than any other etiology. The percent of patients, 7% of patients with MASH will eventually develop hepatocellular carcinoma. The progression offers us a beautiful model of detecting early, treating early, and avoiding complications. So it's a slow process from fat to inflammation to eventual mortality associated with this metabolic disorder, including cardiac death, CKD, peripheral vascular disease, and this kills majority of patients. Eventually, however, 10 to 15% of people with fatty liver will go into end-stage liver disease, including cirrhosis, hepatocellular carcinoma, and decompensation. Overall, there are multiple pathways why inflammation sets in this disease. It's not one factor. It is accumulation of fat, which leads to activation of inflammation. Lots of cytokines are released in the circulation, going to damage the cardiac system, the kidney, the peripheral vascular structures. Lots of mechanisms have been involved in the development of NASH or MASH cirrhosis, including mitochondrial dysfunction, immune cell activation, and therefore inflammation setting in, attacking the normal liver cells. A lot of gut-derived endotoxin related to the microbiome in the gut activate this inflammation further, and there is a feedback or a vicious cycle of these inflammatory markers attacking other organs and releasing further inflammatory markers to attack the liver. So when we come to diagnose MASH cirrhosis, we go from an early stage where there is just fat with minimal or no fibrosis to stage 3 fibrosis, and then eventually to stage 4, where there is usually isolated cirrhotic nodules. Pathologists have had very excellent criteria of different stages of this disease. How to detect fatty liver? The clinician who encounters the patient in their clinic should suspect this disease by just one look, and I mean it, one look. Look at the abdominal girth of the patient. Look at the fat distribution of this patient. Measure the abdominal girth. It is a very cheap way of telling who is suspect of having this disease. So anybody in female group with waist diameter or abdominal girth more than 80 centimeters, or in males more than 85 centimeters, should be screened for this disease. If we rely on lab liver function tests, it's only elevated in 70% of patients. 30% will have absolutely normal liver function test. One of the easiest and cheapest way to screen for it is liver ultrasound. It will show you hyperechoic liver compared to the right kidney. So when you put the probe looking at the liver and the kidney, you'll see a marked difference in the echogenicity, the liver being bright and the kidney never gains fat, remains dark. So that's your first clue on bedside ultrasound. Lately, however, there are more accurate softwares on the ultrasound machines that allow you to actually quantitate the fat very easily by the same probe, and this is called ultrasound quantitation of fat index, or USQIA. It quantitates the percentage of fat, and anything above 5% is indicative of significant fatty accumulation. For many years, MR technology has been used to calculate fat fraction, and it is an accurate way of quantitating fat compared to a liver biopsy. However, MR is expensive. It takes time to do it. Not everybody can access an MRI, and not every radiologist knows how to interpret data from MRI. So in my center, I decided to compare the technology of ultrasound, which is easily accessible, bedside, can be easily reproducible by multiple operators, and compare it to the accuracy of MRI. And we were able to enlist over 60 patients who had significant fatty liver with fat fraction elevated above 30, and compared that to MRI. The ultrasound measurement was blinded to the person who read the MRI, and we plotted the correlation between ultrasound fat fraction measurement versus MRI, and we were able to reproduce the data very accurately. So ultrasound was much cheaper, did not expose the patient to the lengthy procedure of MRI. The cost is far less, and can reproduce the same data of measuring the amount of fat in the liver at the bedside. This is shown as a poster if you want to see the details of the study in this conference. On the other hand, when a patient develops significant inflammation and fibrosis, or progresses from MASH to fibrosis, liver biopsy remains the gold standard for measuring degree of fibrosis or cirrhosis. However, liver biopsy is an invasive, expensive procedure, and it is subject to sampling error, because when you biopsy the liver in one core, you don't know what's happening in the other lobe of the liver or other areas of the liver. It's also impractical and has some risk, though it is small, of 0.6%. Nevertheless, it's a risky procedure for some patients, especially those who have prolonged prothrombin time or have low platelets. When fibrosis in advanced stage happens, the ultrasound will miss it, so that echogenicity, which was high initially, will go to normal or isoechoic values. So this should not mislead you. You should look for other features of fibrosis, like scalloping of the margin of the liver, shrinkage in the size of the liver, the presence of dilated portal vein or increased portal pressure. But shear wave is a standard procedure now used to measure degree of fibrosis. The stiffer the liver is, or the more fibrosis, the faster the pulse of ultrasound goes through the liver. And that has been logarithmically worked out by ultrasound manufacturers to correlate with degree of fibrosis. So if you have a shear wave measurement at bedside of 1.5 meters or less, you don't have significant fibrosis. But once your score goes above 1.5, you start to develop fibrosis. And therefore, I aimed at a study of comparing liver biopsy with shear wave in order to validate this modality in MASH cirrhosis. Not many papers have been written on this in fatty liver. A lot of the work on shear wave validation was done in hepatitis C. So this is a unique chance to allow us to validate this measurement as a tool in evaluation of liver fibrosis. So in this study, what we did is we were able to collect 51 cases of people who had shear wave measurement, and within the same week, they underwent a liver biopsy, and we compared the correlation coefficient between liver biopsy staging versus the shear wave measurement. The pathologist was blinded to the shear wave, and the person who did the shear wave measurement by ultrasound was blinded to the pathology till all the data was plotted. The correlation coefficient was very high, close to 90%. So when we diagnosed a high stage of shear wave, the fibrosis is significant. At a level of 1.6, usually you'll see F1 cirrhosis. So anything above 1.5 indication of early fibrosis. At level of 2.7, it is F2 cirrhosis. At level of F3, you are at a shear wave value of 3.2 on average, and anything above 3.3 indicate final stage of cirrhosis. We hope to extend this data even further and take more measurements, but I'm very convinced that that shear wave measurement is an accurate method of diagnosing cirrhosis and early fibrosis. Later on in the talk, I will explain why it is important to recognize what stage of fibrosis we are in. As I said, mechanism for MASH is multi-hit theory. So it's insulin resistance leading to mobilization of fat, build-up of visceral fat, and this fat also enters the liver, starting a lot of oxidative stress in the liver, especially at the mitochondrial level. Secondary to that, inflammatory cells attack, and the inflammatory cells release a lot of cytokines, which cause damage within the liver, but also export it to other organs, including the heart, the peripheral vascular tree, and the muscles. You will see a lot of muscle wasting in these people because these cytokines are toxic to muscle cells. So this propagates the metabolic disorder because as they lose muscle, they gain more fat, and they develop a central obesity. Please look at diabetics here in Bahrain. You will find very thin lower extremities and a bulging belly. And I always can tell the person who is in severe damage to the liver by just taking a look at the patient. As I said, this inflammatory process includes the heart, the kidney, the muscle, as well as the visceral fat accumulation, which by itself releases a lot of cytokines, and it becomes a vicious cycle of events. Now, I know it is a sad story to deal with when the person has developed fibrosis, but let's look at what can we do once this fibrosis has set in. Can we change the outcome? Can we reverse this fibrosis or at least stabilize it and avoid liver cirrhosis? Numerous pathways, as I said, in MASH are being approached for therapy. So the most important discoveries in 2024 is the use of thyroid hormone receptors in the management of MASH cirrhosis, and the data that came from the incretin research showing that combined GIP, GLP agonists are very effective also in preventing further inflammation in the liver. The therapeutic endpoints, so how do you know this drug is working? Pathologists and hepatologists agreed that they will seek liver biopsy in their trials to see if these drugs are working. So they look for resolution of fatty liver on biopsy before and after 52 weeks of treatment, and they look for amount of fat deposition in the liver after and before drug therapy. Alternatively, I hope in the future we'll use non-invasive methods, which I mentioned are validated now to a great extent in saying whether this patient benefited from the drug or did not benefit from the drug. Imagine if patient has having to face a liver biopsy once a year to know what's happening. This is difficult, it is risky, and may not give you the full information. So I'll first review the effect of GLP, GIP agonist in management of MASH. As you know, MASH coexists with diabetes, with obesity, and cardiovascular diseases. We all know that these drugs have had a big impact on management of obesity and in reversal of cardiovascular risk. So do they work on the liver? Do they improve the fibrosis in the liver, or what happens? They are approved, as I said, for diabetes, for overweight. Nobody has approved them yet for development of MASH, but certainly studies are soon to be published how this drug affects the liver. They definitely reduce fatty liver. If you biopsy a liver after these drugs are given for at least a year, the fat content of the liver reduces as the weight is reduced. But is weight loss the only mechanism that causes a shrinkage in the fat content in the liver and the reversal of inflammation? This is not known yet. Maybe there are other metabolic effects of these drugs. How effective are these drugs? There is only one small study published in New England Journal of Medicine, and it looked at 190 patients after 3 different doses of both GLP, GIP agonist, based on a liver biopsy at week 0 and week 52 of therapy. So basically, they randomized these 192 cases into therapy with small dose of 5 milligram subcutaneously once a week, 10 milligram and 15 milligram versus a placebo. And at the end of 52 weeks, they looked at the amount of inflammation as well as fat in the liver. There was a significant reduction in inflammation and a marked reduction in fat content in those who received this combination of drug. And the major side effect was GI side effect, including nausea, occasional diarrhea. No major side effects were encountered in this study. This is, however, a very small study, and I hope in the future we'll have more data on the use of these drugs' effectiveness in reversal of fatty liver and fatty inflammation. Aspirin as an anti-inflammatory has been tried. This is a very small trial. It published on 80 patients who received tiny dose of aspirin, which we use in the cardiovascular conditions. And they looked at what happened to fat fraction by MRI in those who received aspirin versus those who received placebo. No other intervention taken. So all people with bariatric surgery or those who received incretins were excluded. Only aspirin was given. Interestingly enough, the amount of fat reduction by MR, measurement of fat fraction, decreased on those who received aspirin by 6.6% versus those who did not receive it, who increased their fat fraction by 3.6%. So the future is open for anti-inflammatories to try and reduce the risk of MASH cirrhosis. But the most remarkable and the most published study is resmetirom on treatment of MASH or NASH. This was published in February 2024 by Harrison and his group. And within a month, the FDA approved this drug as the only approved drug for treatment of MASH cirrhosis. It is a conditional approval, selecting only stage F2 and F3 of MASH, excluding anybody with full-blown cirrhosis or early fibrosis, and excluding anybody with fat without cirrhosis or fibrosis. So how does a thyroid-based therapy affect fibrosis in the liver? Just to let you know, the thyroid is a very active hormone in the liver. It is highly effective in reversing fat deposition in the liver if it is utilized the right way in the body. T4 is converted to active T3 in the liver. But in people with MASH, this conversion does not happen. T4 is actually converted to inactive component, which is not working to stop the fat deposition. And therefore, mitochondrial fat deposition goes on because the inactive component of T3 is made, or reverse T3 is made instead of T3. And therefore, there is toxic accumulation of lipotoxic amount of fat in the liver, leading to the cycle of inflammation and mitochondrial oxidation. So what we call intrahepatic hypothyroidism. The T4 in the periphery is normal, but it's not working in the liver. Therefore, people thought, what if I give the active component that stimulates the beta receptors in the liver? Can this reverse the fibrosis? And therefore, this randomized trial was undertaken, and I will show you the results. This is called the resmetirom study. It included 966 patients who were randomized to receive this drug at two different doses versus a placebo. A liver biopsy was obtained at time 0 and after 52 weeks of therapy of a single pill per day. And the results of this study, as I said, it's an orally administered drug, liver-directed thyroxine-like drug, and it acts on the beta receptor as a selective agonist of the thyroid beta receptor in the liver. The randomization was 321 patients on placebo, 322 on 80 milligrams per day, and 323 received 100 milligrams per day. The results were showing moderate effect. In other words, 29% of those who received 100 milligrams showed a downgrade of the fibrosis, a reduction in the fat, and improvement in the liver after 1 year based on a liver biopsy. The major adverse events encountered were diarrhea in about 20% of cases. This diarrhea subsided after the first weeks of therapy. No major side effects were encountered. Just to conclude, NASH is treatable now with resmetirom, and people are also adding GIP, GLP, and multimodality of therapy is the future. My conclusion, also, I have to tell you that there is no treatment for MASH cirrhosis once it is established. All we have to do is screen them for possibility of liver transplant and also take care of their metabolic needs. It affects 33% of our population and 68% of diabetics in Bahrain, and it is associated with HCC. It is associated with a very high cardiovascular risk and complication. Weight loss remains the most effective method of combating this disease, and now we have non-invasive methods of diagnosis. Effective drugs like incretins, combined GLP, GIP agonists are the future, in addition to drugs like resmetirom, which affects the beta receptors in the liver. Many drugs are under trial, and combination of drugs are the future. Obesity is a multi-organ disease. It's not a disease that affects the liver alone, but the liver offers us a window to look at the risk of the cardiovascular events. Prevention of obesity is the prime health target in the Gulf region. Education of the public on types of food they eat, lifestyle they lead is very important, and I think the health authorities should focus on this. Thank you very much.
Thank you very much, Dr. Najah, for this wonderful presentation. Professor, you want to introduce Dr. Khawat?
Dr. Khawla Ali from Bahrain is requested to come at the stage. She is going to present a topic with huge future implications. The microbiome, a hidden anchor for obesity care. She is a consultant endocrinologist and senior lecturer in medicine, American board certified in internal medicine and endocrinology, diabetes and metabolism, and also in obesity medicine. Please.
Do I do it myself or? Assalamu alaikum wa rahmatullah. Thank you for the introduction. Thank you for the organizing and the scientific committee for inviting me to speak today. It's very difficult to follow a figure like Dr. Najah, but I will try my best. This should be a brief presentation because really our knowledge is limited up to this point, and we will tackle the issue of the microbiome, a hidden anchor for obesity care. First, let's define things. When we talk about the microbiome, we're talking about the collection of the microbial genes that are located inside the human body. And those are not just limited to bacterial genes, but also fungal genes, parasitic genes, etc. When we refer to the term microbiota, we're referring to the collection of microbial organisms that live within our systems. And not just within the gut, as we classically think of the microbiome, but also outside of the gut. So within the respiratory tract system, within the genitourinary tract system, etc. But you'll see that the focus mostly of the microbiome is in the GI tract because that's where the biggest collection of microbiota is located. Very interestingly, when we look at the microbiome and the number of genes that are found inside the human body, there are about more than 1 million genes that have been identified. And that only compares to about 23,000 of the human DNA genome that's located inside of us. So in other words, 99% of human or of your genes are actually in the microbial cells and not in the human cells. So what I usually say is 99% of us were made of bacteria, whereas only 1% of us is human. And that collection of genes, the microbiome genes, really determines disease versus health status, and we'll see the impact of this microbiome on several disease states. When we talk about the gut microbiota, we're talking about bacteria specifically that is located along the entire GI tract, starting with the highest density, of course, in the colon and in the oral cavity. But the composition of those bacteria, of course, differs in these two locations. Oral cavity has predominantly the aerobic types of bacteria because of the increase in oxygen exposure, whereas the colon is predominantly anaerobic types of species. And then when you go down into the GI tract, into the duodenum and the stomach, that's where you find the lowest concentration of bacteria, primarily because of the acidic environment of the stomach. And then the prevalence, of course, goes up as you go into the small intestine, with the highest prevalence in the colon. Every part of the GI tract has a predominant species that predominates the entire microbiota composition. And it's important to note that in healthy individuals, the predominant type of the predominant species essentially is the Bacteroides species in the colon. That's the predominantly healthy type of microbiota, and that really determines a lot of health states in a lot of conditions where increase in Bacteroides versus something called Firmicutes species is correlated with increased health and vice versa. There are, of course, a lot of influencers or influencing factors on the gut microbiota that actually starts even before you're delivered. So there are a lot of maternal factors that impact your gut microbiota later on in life. Of course, we know the mode of delivery, C-section versus vaginal delivery, also affects, because that's the first stage at which you encounter the oral microbiota and get swallowed into the gastrointestinal tract, and thus you start to build your own microbiota species. Of course, your gestational age, whether you've encountered any infections, even from a young age, and of course, the early life antibiotic administration significantly impacts this microbiota even later on in life. Host genetics plays a important role, your immune system, in addition to feeding patterns, and not just feeding patterns during childhood, whether it's breastfeeding versus bottle feeding, but also feeding patterns and dietary behaviors later on in life, as we'll see in a second. The microbiota influences, and there's more data on this that we will explore in a second. It does influence significantly most of our organs or most of our disease states, and the focus today hopefully should be on obesity and insulin resistance and how the gut microbiota is linked to that disease state. Most of our understanding of the function of the microbiota and its link to the metabolic state is through the fermentation of the resistant types of fibers or dietary fibers into short-chain fatty acids. So you'll hear short-chain fatty acids, or the SCFAs, quite often when people talk about the microbiota, because that's where most of our understanding is on the role of the microbiome in metabolic functions, etc. And this very nice figure from nature summarizes the functions of the short-chain fatty acids. So essentially, we start out with dietary fibers or complex carbohydrates, and not just any fibers, but the resistant starchy types of fibers. Those are usually digested by the gut microbiota, usually the good type of microbiota, so predominantly the Bacteroides species, into these short-chain fatty acids. So the butyrate, propionate, acetate, etc. All of these influence the gut cells, including the endocrine cells and the immune cells. They influence the gut cells by producing the incretins, such as GLP-1, PYY, etc. So that's probably one of the mechanisms how short-chain fatty acids produced by the microbiome may influence obesity states, may influence even weight status post-bariatric surgery, as we'll explore in a second. They also have effects on the immune system. They stimulate the differentiation of T cells. They also have their effects at the liver level, and also, very surprisingly, even at the central nervous system level. So some of these compounds that are being produced as a result of short-chain fatty acids can increase neurogenesis. There's been studies to show that they improve cognitive development, they have some anti-aging effects, and they also reduce inflammatory signals in different varieties of neurocells. This is an example of certain disease states that are affected or that affect the microbiome composition. Now, of course, the big question with all of these disease states and all of these studies, are these correlation, is the relationship simply just a correlation, or is it a causation? So in other words, do we have a change in the microbiota, as we'll see in a second, as a result of these disease states, or is the change in microbiota, does it precede the disease states and contribute to the pathophysiology or the pathology of those disease states? So we start out with a gastrointestinal disease, and understandably, if you have a gastrointestinal disease that primarily affects your GI tract, there will be a change in microbiota, and that's what we see. So this is this was a study that was done in 14 healthy individuals versus 25 with IBD, distributed between UC and Crohn's disease, and what we do see is that the species significantly differ between healthy individuals versus those with ulcerative colitis and Crohn's disease. Even within the IBD cohort, there are significant changes or significant differences in the microbiome composition. But when we think about disease states, we're also thinking about outside of the GI tract. So even when you have systemic disease, something like symptomatic atherosclerosis, pre-established cardiovascular disease, when you look at the microbiota composition of those individuals versus healthy controls, you will see a significant difference in the composition of the bacteria in both species. Again, that begs the question, is it a change as a result of the disease, or are dietary changes causing these microbiota changes, and as a result they induce the disease state, or at least contribute somewhat to the disease states? So for example, in this study they found that atherosclerosis was associated with an increased particular pathogenic type of species called the Collinsella versus healthy control that were usually associated with these two species of bacteria. Moving on to obesity. We know that obesity or obese states are associated, number one, with decrease in the microbiota diversity. So as the diversity goes up, healthy states or a general health status generally goes up. And so in lean individuals, we do see more diversity, we do see more richness in the microbiota. And this is the key thing that has been established in clinical trials, or in studies at least, that we know that there is a ratio that's called the Firmicutes to Bacteroides ratio. So the Bacteroides are the good type of microbiota, the Firmicutes are thought of them are the less good ones, and so if that ratio goes up, that's usually associated with obesity states versus a lower ratio in patients who are lean. One of the major studies that was done on the microbiome and its effect on metabolic state actually came from this clinical trial, or this study that was published in Science in 2013. Very interesting study where they took genetically identical twins. However, morphologically, one of them was lean, the other one had obesity. And what they did is they extracted essentially the intestinal microbiota, and they did fecal transplants on germ-free, genetically identical mice. And so when you transplant the microbiota of the intestines from an obese participant or participant with obesity versus a participant who is lean, that significantly affects how the mice is going to do over their lifespan. So even though these genetically identical mice that are germ-free were fed the same exact diet, over time, those who had the gut transplant or the fecal transplant from the intestinal microbiota of the participant with obesity gained significant amount of weight with the same diet, with the same caloric intake, compared to those who received the lean fecal transplant. And there's, of course, this notion that one of the reasons that might be is because the good types of bacteria, or the good microbiome, it actually extracts less calories from the food that you intake versus the less good types of microbiome. And as a result, the amount of calories that you absorb from your diet significantly differs between those with good microbiota versus those with unhealthy microbiota. This is another study that looked at diet and how it influences the GI microbiome. If you look at herbivores, or people who are or mammals in general, that are purely plant-based, the type of bacteria that they harbor, or species they harbor, are significantly different from those who are carnivore. And now there's, of course, this whole notion and this whole trend of carnivore diets that's been widespread across different social media platforms, where people are advocating for such a diet, such as the carnivore diet. And you can see that the microbiome is very different in the two types of categories. Now, the omnivore, those who eat both plant-based and animal-based, also very interestingly, have a very different microbiome composition. And it's not just a simple additive effect of carnivore plus herbivore. Instead, they have their own separate microbiome. So it's a very complex process, the way our diet interacts with our microbiome. And of course, our understanding is just starting to emerge, and there's a lot to be navigated. Now, diet, you don't need to be on a specific diet for months or years to change their microbiota. This is a very nicely done study, a case control study, where they basically took a group of vegetarians, or people who are basically who are plant-based in their diet, and they randomized them to either receiving or continuing a plant-based diet versus switching them to an animal-based diet. And they looked at the diversity, or in other words, the change in the microbiota over the course of a few days when they changed their diet. Now, the change in diet is represented in green, starts at day 0 and ends at day 4, so only 4 days of change in diet composition. What they've seen is that, of course, the plant-based diet, people, nothing changed. They've started plant-based, they continue plant-based, versus those who started plant-based and then shifted to animal-based diet. There was a significant change in the diversity of the microbiota as early as day 2, and that change goes back to the way it was, or back to normal, or back to their original state even as early as day 6 or 8 post-intervention. When we talk to our patients, we talk about diets that are beneficial to the microbiota. So we talk primarily about 2 types of foods. We talk about probiotics and prebiotics. Probiotic foods are foods that contain beneficial bacteria within them, such as fermented foods, the kefir, etc., probiotic yogurt, versus prebiotic food, like the resistant starch types of foods, asparagus, bananas. Those are the things that stimulate a beneficial environment or a friendly environment for your own bacteria to grow. Now, I'm conscious that I only have 3 minutes, and I'm going to spend it a little bit on whether giving probiotic foods, and particularly supplements, does that actually help with obesity? Because that's a big subject. A lot of patients don't like to eat these fermented foods, etc., because they cause bloating, they cause gases, etc. Some of them are expensive and hard to get in some countries. And so the question is, are supplements beneficial, and will they help with obesity? Will they help reduce the weight? This is a very nicely done randomized controlled trials where they took a group of individuals, about 81 individuals, and randomized them for 3 months to receive either placebo, a single dose of a probiotic, or a double dose. And what they saw at the end of 3 months essentially is no statistically significant really changes in body weight, placebo comparing that to a single dose or a double dose probiotic. But then they moved on to an open trial for the remaining 3 months, and they switched everybody on single dose and double dose to a triple dose probiotic therapy. And what they've seen is some change in body weight with those receiving the triple dose, of course, at the end of the 6-month period compared to baseline. Now, 2 kgs is the total amount of change in weight loss, and is 2 kgs clinically significant? One can argue probably not. However, when you combine probiotics with a dietary or weight loss program that's rich in starches and prebiotic-rich foods, you do get actually more clinical benefits. And here probably the focus is on the disease status modification benefits, like Dr. Iqbal was mentioning, as opposed to just simply looking at the weight change or the BMI change. So what we do see is almost 100% reduction in leptin, indicating increase in leptin sensitivity, reduction in ALT and AST levels. There was a reduction in the firmicutes to bacteroides ratio, again favoring a good microbiome environment. And then there was some reduction in weight, about 1.5 kg, that was done over the period of time in about 50-something individuals in Egypt. Lastly, bariatric surgery, of course, also has its impact on the microbiome, and this may be one of the mechanisms how bariatric surgery helps with weight loss via the favorable changes that we observe in the microbiome. We do know that post-bariatric surgery, there is increase in diversity, which is indicative, of course, of a healthy microbiome environment. There is improvement in the Firmicutes, the improvement, should be the Bacteroides to Firmicutes ratio, again favoring a good microbiome environment associated again with these weight loss figures that we see. So just to conclude, many disease states have been linked to the microbiome. Obesity does induce changes, of course, in the microbiome. Dietary behaviors by themselves can also change the microbiome status, either favorably or unfavorably, and adapting dietary behaviors composed of a rich prebiotic and a probiotic types of foods are essential really for health and well-being and should be probably incorporated into any dietary or weight loss program. And of course, more research is needed into these areas. Most of the studies I presented or looked into are mostly case control studies or prospective cohort, very little randomized control trial, big evidence available on this topic. And that should be it.
Okay, it's my pleasure now to announce our last speaker in this session. We have Ms. Nagham Nuruddin. Ms. Nagham is a graduate of AUB. She's a clinical registered dietitian, NAHRA certified, working 14 years in hospital setting and active in community service, conferences and media. She's currently working in Ibn Nafis Hospital. She will be talking to us today about nutrition challenges in children with obesity.
Thank you so much for the organizing committee. Thank you so much for giving me the space to talk about challenges of obesity in children. And thank you, Professor Dalal Rumayhi, as well. Can we have it displayed, please? All right. So today's talk is going to be about nutritional challenges that we face clinically with children suffering from obesity. So a little bit of an introduction, we'll talk about numbers, and then finally the in-clinic challenges that we face as clinical dietitians. And of course, a little bit of science and background. Now, introduction, a little bit of childhood obesity. Of course, this is a disease and a health issue as per the European Association for the Study of Obesity, WHO, and the Endocrine Society. And we see the different terms, whether it's classifying obesity as a chronic disease in children and adolescents is a critical step for increasing individuals and societal awareness and for improving early diagnosis and interventions. As we can see, the same goes true for WHO. Childhood obesity is one of the most serious public health challenges in the 21st century. And of course, moving on to the Endocrine Society, which does mention that pediatric obesity remains an ongoing serious international health concern, affecting 17% of US children and adolescents. And of course, we saw the numbers also by Dr. Hani, and the problem is real, and we need to do more on that, definitely. Now, a little bit of numbers published by the World Obesity Atlas 2023. We see here that we do have global obesity trends for children, and we see the numbers here for boys aged 5 to 19 years of age. We see that the proportion for all girls as well in percentages. So the numbers are big, and we need to start doing some action, aggressive action, towards changing these numbers. As we see for the Eastern Mediterranean region, which is also we can see the numbers for boys and that of girls. Okay, and of course the depiction of the future numbers in 2025, 2030, and 2035. So there is an increase. Now, if we look at the numbers here, I would like just some, interaction with the audience. Which do you think, if you want, just by raising hands, which Arab country do you think has the highest prevalence rate of childhood obesity in girls? Is it A? Do you want to raise hands? B? Egypt? Okay. Yes, correct. Okay, so you do have the numbers correct for girls. And for boys, it's Qatar, and we'll see the numbers. So it's 22%, that's correct, and 29% prevalence for Qatar. And we see the different numbers as well. We see for Bahrain, it's 19% for girls, and for Oman, Jordan, and Lebanon, it's up to 22%. So let's talk a little bit about the challenges in clinic, the power of parents. I really want to emphasize on this because sometimes parents can be the fixators, but at the same time, they can be the destructors, okay? And sometimes it's only one word, yes. So sometimes we need to fix the parents, to be honest. It's not really the children. I see children more compliant, reminding their parents of their appointments, okay? And parents are the ones that tell me that. So I think here we need to fix parents before we fix children, by all means. Childhood obesity is complex. It's influenced by different parenting styles, family lifestyles, parent knowledge of what constitutes growth. And an example here, for example, would be mothers not breastfeeding, of course, long enough, giving the formulas at early stage. Even introducing solid foods at an early stage is also one of the factors. Parents, as I said, they can be the most supportive, but also the most destructive. And we've seen a lot of weight stigma from parents, unfortunately, not from doctors. And this is, of course, unacceptable, and we need to have private sessions with parents before the children come in, by all means. If there are more than one child in the family, usually parents would like to amplify the lifestyle change on only one individual, and this is not realistic, okay? And we explain that to the parents as well. This is a study that does talk about parent involvement in diet or physical activity interventions. So this has been applied on children from 3 to 12 years old, which included family-based approaches, parent-only interventions, parent-child interventions, and of course, school environment is also very, very essential. So in this study, we did see great changes with children just by parent involvement. Now, challenges, again, parents don't cook at home. For example, this is one of the great challenges that I face because they lack the cooking skills. So here comes the solution. So as clinical dietitians, so some parents come to my clinic failing all capabilities and completely surrendering to the idea that they need to start preparing food at home. They find it really overwhelming when I ask them to do so. Okay, so solutions here would be to take, cooking classes, watch YouTube videos. We all are observant learners. Okay, and it's okay, you can fail to succeed, and that's totally okay. Now, of course, some parents, they also complain that, preparing food is very expensive, and it's quite the contrary, because if you look at local vegetables and fruit found in Bahrain, it's way cheaper than than other commodities found, coming from abroad, for example. So we encourage buying local seasonal products. We talk about meal preparations. Freezing is pleasing, so do freeze. For example, I can give this example of falafel, for example. You can do it in the weekend. You can do it with your kids, okay? So you're involving your kids in this. And of course, this is actually a solution that we also suggest in clinic. Also, one of the challenges, insurance doesn't cover dietitian, reviews. And we know that the more that you come into the dietitian, the better the results that you can get. So some of them, they also do have, metabolic disorders, so they don't have enough blood work. So this is also a gap for us as clinical dietitians as well, not to see the full picture of the child, not able to assess properly. Of course, deficiency in vitamin D is one of the obstacles for weight loss. As we all know, iron deficiency, very common here in Bahrain as well. So even referrals from the referrals from physicians are lacking, unfortunately, as well. So maybe more screening should be done on that aspect, so more referrals can be done, so we can do more changes on that aspect. Also, one of the challenges that we face is that when children have, TVs in the room, so we do ask them to remove that because we already have a problem by itself, which is the screens on the phones, and we know that adults usually fail that by themselves. So how can we ask the child to stick to that if the parents don't do that initially? Okay. Also, we have problems with sleeping patterns with children, and sleeping is essential for controlling weight. We all know that very well. So we need to control that as well. So parents should be involved in this and place strict rules on sleeping hours. There's no physical activity. Sometimes the parent will tell me, okay, so we'll take him to the gym, and then the child gets overwhelmed, This is not enjoyable. Kids need to move, and they need to move consistently. So in order to do that, you have to give them an enjoyable approach to start off with. Nothing comes, by force. So what I usually suggest would be probably, enjoyable hobbies. We do ask the children what they like. Okay, so what's your hobby? This is the first question we pop. Okay, so the child starts talking. Maybe he or she would like to swim. Okay, because usually at the beginning with a big amount of weight, it's usually very difficult and very challenging for these children to move. So we need to ask them to do hobbies that they're able to move in enjoyably, and it doesn't pose any kind of, like restrictions on their movement whatsoever. So swimming is one of the safest, enjoyable for kids, and we're able to be consistent with that, definitely. Some kids would like boxing as well. Okay, so that comes maybe next after they've shed a little bit of weight. Okay, and of course many other hobbies that we can try to implement, and these are challenges for parents, but not for when we suggest the solutions, things become easier by all means. So we need to be consistent, and this is very, very essential. It's not once in a week. It's not all the studies have shown that children should move at least 1 hour daily. Thank you so much. I think I'm past the I'm earlier than the time, which is good. So I thank you very much, and that's a wrap.
Thank you very much, Ms. Nagham. Thank you for keeping the time, and I think we open the floor now for questions for our wonderful 6 speakers, or 5. Dr. Iba left. Do you have any questions? Dr. Khalid, can we have a microphone?
The question is for Dr. Nagham, I think. And you see here in Bahrain, by ministerial order, they reduce the amount of salt in the food, and in all like local bakeries. So you showed us a very scary numbers in terms of Kuwait and Egypt, and do you think there should be like ministerial order also to reduce the amount of sugar and processed food for kids?
Okay, so I think yes, by all means, there's a lot of availability. We have the talabat, for example, which makes it door-to-door very easy to get these foods to start off with. But maybe, yeah, getting the commodities to start off with, maybe a healthier option, less sugar. Maybe we should use, social media, so food bloggers that talk about things probably a bit healthier, so, that people will follow these people. So why don't we start with that? And then reduce the sugar and all of that. But I think like social media has a lot to play in this aspect as well.
It's more of أمر وزاري اللي هو تقليل الملح في الطعام في المخابز المحلية, and it was from WHO, and I think if we are facing this in the MENA region, then should be also restriction, just like for cigarettes, salt, sugar, as in the processed food and whatever, for the children, if we are facing such thing, I think.
Absolutely, and what I see also in schools, unfortunately, okay, we still see croissant, we still see a lot of donuts, and this is not acceptable in schools as well. Maybe we need to start from there.
This is the first step, and then we'll take it from there with the bigger, yeah, by all means. Thank you.
Dr. Nasreen.
Yeah, question for Dr. Omar. Looking at the endoscopic sleeve, was there any data showing the effect on outcome in terms of the glycemic control and diabetics, liver, fatty liver, fibrosis? We know with the bariatric surgery you could have reversal of fibrosis and fatty liver. So were there any data compared to the bariatric in that?
The MERIT trial that they got the FDA approval, which had around 209 with a follow-up for 108 months, 108 weeks, sorry. So it has to show some parameter on reduction on that. So I showed you some small studies on what happened with them on the balloon stuff. And then there are actually studies, even Al-Qahtani, his data that he presented, and the other data also from his center, 1,000 patients, they show reduction of parameters like HbA1c and stuff. So this is one of the things that they look at for, and there is proven data with that. The matter of the fact is that, you know, when there is a reduction of weight, there is a reduction of the parameters. Now, metabolically, specifically how it would do it, it's mainly by reduction of weight. Other than the duodenal mucosal resection stuff that had reduction of HbA1c without even reduction of weight. So, so that tells you that there is the metabolic part of it is more than the recession with that. So to answer the question, yes, there are some data on that as well.
Any data on fibrosis? Because right now the challenge with the GLP-1, you could reverse the fatty liver, but not really the fibrosis. You could probably just hold that fibrosis at that stage without the progression, but with the bariatric, we have seen reversal of fibrosis. Do we know with the endoscopic technique?
Well, again, it all depends on how much weight is going to be reduced with that. So we know that it is a good modality of weight reduction. I showed a comparison between it and surgery with that. So if you tell me what is better, of course, surgery is going to be better. But now that comes into it is like, I always tell that to patient. I think this is not, I'm going to هاي مو الكرمشة المعدة وليست قص المعدة بالمنظار. Because I don't want it to tell them that it is comparable to gastric sleeve or bariatric surgery. Yes, it does reduce the weight, not as much or robust as what is done with bariatric surgery. So if we want to aim for fibrosis, then yes, surgery might be a better option for that. But is it a good option? Good alternative? Yes, 100%. Number two is how much of that is compliant and how much people, they don't want to do surgery. So I offer this kind of endoscopic procedure for people who do not want to do surgery. Then yes. But again, theoretically speaking, yes, there will be a reduction on all the parameters, might be even including fibrosis. I did show you one study, small data, in balloon and reduction of fibrosis. So technically there should be.
More complex than we think. It's not a volume, a capacity where we can accommodate the food. It's not only the absorption, which we alter during our surgery. It's not only the appetite when we play with medication, with the GLP-1 or GIP antagonist. What we do actually, when we do endoscopic sleeve gastroplasty, We just decrease the size of stomach, isn't it?
Yes, and reduce.
However,
motility of the stomach.
the source of ghrelin, which is the fundus of the food desire, is still there. So the patient has the desire to eat, but cannot eat. This is what happens exactly with the sleeve gastrectomy. However, when we do sleeve gastrectomy, we are removing the fundus of the stomach, and we are removing the source of this desired hormone, the ghrelin, for the food. That works with patients. For 70% of those patients, they recur after 3-4 years because they change their behavior eating to carbohydrate or sweet drive. When we do bypass, we are addressing 3 components: the size, exclusion of the fundus, which release the ghrelin, and absorption. So when we do that, we can reach to more sustainable weight loss and reverse the fibrosis, what's happened. Exactly what hormones going on when we exclude the duodenum, we don't know yet. There are many hormonal complexes. They correct the HbA1c and reverse the process of fibrosis and fatty liver. But it's really, I think, the pharmacotherapy, which address the food desire, the reduction of the stomach size and absorption. These all complex things can help. I think we need a sort of maybe new medication can address the 3 components, can help in reducing the desire to eat, reducing the absorption of nutrient, transient, maybe for 1 to 2-3 meters, and the effect will go. It's really a complex thing. That's why when you do sleeve, the mucosal barrier, what happens?
It's bypassing the...
You're bypassing the duodenum. There are some hormonal changes.
Yes, of course, that's the thing.
Happening.
Exactly.
Yeah.
And the thing that we don't understand is like also is like when we have a good collection is the microbiome, with what happens to the microbiome. And this is very interesting stuff, the bypass and what all this does, the change in the acid in the stomach, use of the, with all this, and how it's going to affect the microbiome is going to be the thing, one big thing to work on. Very interesting talk with that.
Yeah.
All the speakers are requested to come on the stage, and I would just conclude it from a poetic version. मोहब्बत मुझे उन नौजवानों से है सितारों पे जो डालते हैं कुमंद. The translation of Arabic is this, that I love those people who go to the stars, and there are other worlds beyond the stars. So the innovative lectures by dear Umar, microbials, and all innovative surgeries. So we have to think out of the box. Thank you very much for very elaborate talks. Thank you.
And now we move to session number 3, cardiovascular health. And our first speaker is our dear friend and inspiration, Dr. Hassam Noor. He will talk about cardiovascular health and diabetes care. Are we meeting the challenge? He's a renowned and highly esteemed cardiologist in the fields of medicine and cardiology. He holds plethora of distinguished titles, each reflecting his unparalleled expertise and contributions to the medical community. Dr. Hussam has become a figure in healthcare industry in Bahrain, demonstrating unwavering commitment to excellence in patient care, medical research, and academic leadership. His multifaceted roles, including Chief of Medical Staff in Clinical Services, Director of National Aortic Repair Program, Director of the Cardiac Catheterization Laboratories, and is a consultant interventional cardiologist at Mohammed bin Khalifa Cardiac Center. His patients love him, we adore him. Welcome to the stage.
Assalamu alaikum. Good afternoon, everyone. It's great to be here. I see my mentors, Dr. Qasim, Dr. Najah. Good to see you. Dr. Dara, thank you for this kind introduction. I try to do my best, and that's what we're going to hope for. So I need to pull up my slides, and I'm sorry we're running a little bit late. How would I get into that? That's one thing I'm not good at. So when I saw the talk in cardiovascular disease and diabetes, and I said, what is Dalal doing to me? It's not an easy subject. It would be a conference by itself. And when I just arrived early this morning, and when I was thinking what to call it, I had to change and modify the title. I called it Cardiovascular Disease, the Perfect Storm. So it's a storm that affects, and ultimately, it would lead to a lot of associated morbidity and mortality. So why this is very, very important is because ultimately, the majority of your diabetic patients would die because of cardiovascular complications. So what I'm going to be talking in the next 20 minutes or even less is what is new. You've had great talks all day, and I'm not going to bore you with a lot of trials, but I'm going to highlight important stuff that could be relevant to your day-to-day practice and correct some of the myths associated with things that we do on routine things which we think it's correct, but in reality has no data or any evidence to support what we do. So this is the institution that I work for. Believe it or not, it's going to be 20 years since I came back this year. And so the first is we have to address the problem. In 1 out of 8 of the global population in the next 2 decades would have diabetes. And if you're good in math, that would equate to in 2040 from now, 2044 from now, you will have about 750 million people with diabetes, close to 1 billion. Just imagine how much would that have an impact on what we do, and how much would the community and countries and health economics would suffer from it. So of course, you know all of this is going to affect cardiovascular disease, kidney disease, arrhythmias, whatnot. I don't think there's any single organ or single cell or single nucleus in the body is not affected with having high sugar in your blood. Simplifying it. There's a very interesting study in which they look into, when they look in type 2, I'm basically primarily talking about type 2 diabetes. And I've also forgot to tell you, I have zero conflict of interest. Don't receive any honorarium. I just love to be here with you guys. And my other conflict of interest, I don't practice diabetology. I'm an interventional cardiologist, but this is part of what we do. And diabetes brings us business. So type 2 diabetes is associated, if you compare it, patients with no diabetes versus patients with type 2 diabetes. What's striking in here, if you look at the frequency of the comorbid conditions, the peripheral vascular disease is one of the top ones in the top, and then heart failure, and then stable angina. If you go back to our community, people with diabetes would always think, oh, I'm diabetic and I'm worried about heart attacks. Well, actually, if you look at coronary artery disease, is number 3 or number 4 on the prevalence of disease. Peripheral vascular disease is 1. Heart failure which I'm going to emphasize is number 2. So where is my talk is coming from, and this is where I'm going to update. This is a very, very beautiful document presented at the European Society of Cardiology, in which is about 100 pages document, very much evidence-based, and talks about the diabetes and cardiovascular disease. And if you want more details, and by the way, at the end, anyone who needs these slides, you can email me and I'll send it back to you. So number 1 is a very simplified question, is how do you diagnose diabetes? And I feel I'm very much embarrassed to stand before you and talk about how really do you diagnose diabetes. But the reason I'm bringing this up, I challenge you. Survey your community, survey your hospitals, survey your doctors at the local health centers, and ask them, survey them, and you will be surprised that till today that many people don't understand or don't really know the newer diagnosis of diabetes, one of which was myself. So for patients who present with cardiovascular disease, it's a class 1 indication that you use fasting blood sugar or the HbA1c given. So, and then of course, if people have cardiovascular disease and they have no diabetes, and diabetes ruled out, they go to a different category. In our experience, and I'm sure Khalid would say the same at Salmania, at least 50 to 60% of patients with coronary disease are diabetics, at least. So it's very, very important that we identify patients with diabetes, and how we identify them is we do these fasting blood sugar, HbA1c, and find out if they're diabetic or not, and then you go forward. I think what's more important is, which probably is more pertinent in the primary and secondary care setting, is how do you really risk stratify the other way around your diabetic patients? And be cognizant that, and you need to inform this to your patients, that if you are diabetic and you're a male above the age of 50, you lose 7.5 years of your life. And if you're a female above the age of 50 and you're diabetic, you lose 8.2 years of your life. And I think when you engage your patients, and we'll come into that, it makes a very intellectual and very impactful effect on them, in which that they have to be really careful with their diabetes and their cardiovascular risk. So tell them, listen, sorry, you have diabetes. If you're a male, you lose 7 years of your life. If you're a female, you lose 8 years of your life. And you have 2 to 4 times risk of cardiovascular disease, 2 times risk of heart failure, but 1 to 6 times risk of stroke, and increased 50% risk of cardiovascular death. Because once you engage them with data, you would have better outcomes. So traditionally, how do you risk stratify diabetic patients? And this is again from the European Society of Cardiology, where you have low risk at one spectrum, and you have very high risk, and then of course you have moderate risk, high risk, and very high risk. And I'm not going to go through the details, but I'm going to, for us in cardiac center or in cardiology space, it's pretty simple. All patients are very high risk. That's, for me, is very easy. I don't need to do the score B, I don't need to do target organ dysfunction, I don't need to do 10-year CBD risk assessment. Now, in the primary care setting, which is more difficult, because you're the one who's seeing, your door is open up front for everyone. So we have the selection bias to take the very high-risk patients or high-risk patients, but you will see everybody, you don't know. So then you need to find out, who am I dealing with? Am I dealing with a very low-risk cardiovascular disease or a very high risk which has been undiagnosed? And this is where something like this would help you, and I strongly, I'm going to come to that, ask you to actually risk stratify them, because this risk stratification would help you to have an impact. So Math, many people are have risk aversion for math. Math is a mental abuse to human. I don't think so. Math is actually very exciting. Anything you do is based on math and numbers. So to make your life, not to abuse you mentally, there is a calculator which you can download in your phone, and you can have it, in which you can use and utilize it in your daily practice and risk stratify these patients to either low risk or a very high risk or intermediate risk. So you can have that on the ASC website, download it on your iPhone or Android, and make it work for you. So the first thing is, risk stratify them, which we talked, and then you use the score 2B, score 2 diabetes to risk assess them, and that's very, very important. So once you risk stratify them for your diabetic for their cardiovascular disease, and then what is next? Fine. I have type 2 diabetes, low risk, versus I have type 2 diabetes, very high risk. And then, so what? Would it gonna change how I approach them? Would it gonna change how am I gonna address them? Would it gonna change how I'm gonna get that patient really up to speed to reach the targets? And then your question is, what are my target? And what are the patient's target? They're completely different, and you need to understand those two things. So that's, I think it's a very, very famous slide in which is talks to you about cardiovascular risk management. And if you look at the base foundation of this slide is lifestyle modification and diabetes education. It's pretty boring, right? If you talk about lifestyle, people take that very lightly. It's boring. There's nothing flashy, nothing, I'm not going to use the other word. Okay? But it's not right, though. It's not true. The reason why it is perceived as a boring because we don't make it interesting. We say, oh, exercise, don't eat, don't take sugar, sleep well. Hold on. Give them the data. Get them engaged. This is how you do it. This is the numbers. You talked about the nutrition. This is how you're going to be doing it, and this is going to make an impactful event for you. Give them numbers, things which are tangible. And of course, diabetes education. This is your base foundation. I'm not going to talk about glycemic management. I'm not an expert in that. I'm not an expert in any of these. I'm not going to talk about blood pressure management. I'm going to concentrate on the fact the agents with cardiovascular disease, and basically that's all I'm going to talk about from now onwards. The reason which I thought I'm going to emphasize on that, because I see in my practice a variation of practice from people coming back to a tertiary center. And I say, why are we doing this? Are we doing the right thing? And I think it behoves on us to talk back to our colleagues, and sometimes I send them letters. I say, look, we need to do this. What do you think? Do not patronize them. You say, well, I think this is an option. I need to engage you in the management of the mutual patients. So what are our intentions? We have to think about, there are a couple of intentions that we have. When we manage diabetes, are we looking at cardiovascular protection? We want to prevent this. Or are our intention is to have blood sugar control? Are they the same? Is cardiovascular protection is the same as blood sugar control? And this is where we get into disagreement or agreement with our colleagues from endocrinology or diabetology or primary care. So are we looking into cardiovascular protection? That's what we want to do. Or are we doing a blood sugar control? They marry each other. They're not separate. So it's not enough to get their HbA1c at target. It's not enough to get them the right medication to get the blood sugar down to the target. Are we despite lowering the HbA1c, are we really giving them the best cardiovascular protection? Because 50 to 80% of them would die from cardiovascular disease. So we go back again to this, and we look into, after you risk stratify them from low to very high risk, which class of medications you're going to use. And I'm not going to dwell into this because I think you're all cognizant of this and you know what to do. But Mike, you know, when I started practicing, believe it or not, 20 years ago now, can't believe it. Metformin was the medicine to go to. Everybody should be in metformin, right? So what happened to metformin? So we in healthcare professionals, sometimes we're also human. We also get information from social media, from friends, from community, and there's always a conspiracy theory. Is metformin out because it's very cheap, because it has a very long record? Is it why metformin is being downgraded? It used to be any diabetic start metformin. And actually, it's not been downgraded. It's been downgraded from class 1 to class 2A in cardiovascular disease because, again, it all depends on the risk of the patients you're managing them. If it's a low risk, type 2 diabetes, absolutely is fine. So why is not the preferred drug for a very or very high risk patient? And it's basically to this meta-analysis of randomized trial which showed there's no significant benefit in the high or a very high risk patients. So that it should not be the first one you start with. But it may still be considered even if you as an add-on medications. Now, why did I'm going to pick on Actos, Poiglitazone, TZDs, and because I still see, and that's why I picked up this drug to talk about it, I still see a lot of patients who've been given Actos, which is a good drug as an added drug, but Poiglitazone, I'm sorry. And is it good? Is it bad? And what is its relationship with cardiovascular disease? There's one study, it's called a proactive study, in which randomized almost 20 years ago to patients with standard care plus Poiglitazone, and it was beneficial in terms of the MACE outcome, including stroke and renal impairment. Now, if you look, and I urge everyone in here, especially the newcomers, when you look at any data, always, always, always look at the details. So if you look at the slide, it shows you Poiglitazone is beneficial, better than placebo. Clear? But what is the number needed to treat, and for how long? So you need to know how to calculate number needed to treat, because that's a very powerful number for you to understand the impact of your intervention. So for this one, you need to treat 40 patients for 3 years to prevent one event, and that's not a mortality event. So it's not bad, it's safe. However, it causes this. So a lot of patients would come in to the outpatient clinic. I'm worried I have swelling in my foot, and I'm worried about I have heart failure. You examine them, they're absolutely fine, they have the swelling in the foot, and it's actually a fluid retention that the TZDs can cause. So it causes peripheral edema, and it also could be at risk factor for heart failure. So patients who are at risk of heart failure, which is your diabetics, your diabetic patients are at risk of heart failure. So I don't prescribe Poiglitazone. I don't dare to prescribe Poiglitazone, but I think I'm giving the message back to the community. Look, we got to be very careful about some of these medications. Now, this class of medications are very difficult for me to understand. I know the brand names, I don't know the actual names, but let me tell you something. And I learned this actually from a very good colleague and friend, Naji, bless him, and we were discussing about the patient, about which one. Naji, I'm confused. There's a lot of them. So when you talk about the high risk of cardiovascular disease, the linagliptin, which is commonly known as Trajenta, and is readily available, these are safe in cardiovascular disease. The sexagliptin, which is Onglyza, if I'm right, are to avoid it in patients with heart failure. And the sitagliptin, which is the Januvia, is neutral. So the one you can use, the sitagliptin, linagliptin, the other ones, with the patient with a high risk, try to avoid, and I have my colleagues from endocrinology to discuss that as well. That makes sense? Which one? Galvez is neutral. Galvez is neutral. So I wish we had a board exam in here. Would be all of these. Which one of them would increase the risk of heart failure? Is Sexa, which is the Onglyza. Okay. So this is a. Oh God, I can't see anything in here. So patients who are independent. So for cardiovascular patients, independent about their diabetics, now it's class 1 indication to start them with an SGLT inhibitor plus GLP-RA agonist drugs. And then you increase the medication as needed. So whether you're diabetic or not, then you check your HbA1c, then you can add metformin, and then you have pioglitazone 2B indication, and you have a gamut of other drugs which are available. I think the other topic I want to really catch on really quick, I only have a minute, is antithrombotic therapy. Do we need to give patients who are diabetic an aspirin or any other antithrombotic therapies? And you know, diabetes enhances atherogenesis. And the question is, and you see this all the time in your clinic, what's the role of aspirin for primary prevention in diabetes? And this has been a subject of a lot of debate back and forth, and it's pretty tricky because no one wants to take responsibility. It's basically an informed consent between you and your patient. So probably in the very low risk individuals, you don't need to, but individuals with moderate, high, or high risk with low bleeding risk, you may consider, and this is a 2B indication. So the short answer for the boards or for any other question is there's no role for primary prevention, but you need to risk stratify them. Probably the higher risk individuals with a low risk of bleeding, you may consider aspirin. Which was interesting, actually. We found this data. It was a COMPASS trial in which addition of aspirin on a very low dose rivaroxaban, 2.5 milligram twice a day, which is not available in here, which has been significantly had positive result in patients with peripheral vascular disease. Remember, diabetes have the highest risk of peripheral vascular disease. So if you have a PVD and diabetes, you may consider adding rivaroxaban plus an aspirin combination. However, with a higher risk of bleeding, but non-major fatal bleeding. So the bleeding, I think, was about 3.1% on the dual versus 1.9% on the other one. So number needed to harm was 50. So number needed to treat, number needed to harm. These are very, very important concepts that we should adopt in our practice. So how does diabetes impact chronic disease? We've been discussing that for the past 20 minutes. So we talked about this. And I think I want to this is a very old study, which is Barry data. And this is what we all say, and we know that from medical school, and this is data from a trial. So your diabetic patients, only 19% of them, they have typical symptoms for chronic coronary syndrome. 81% of them are asymptomatic or have atypical symptoms. So you have to be cognizant of that. So if that is the case, what should I do with them? So they're diabetic, and I don't know if they have coronary disease. You should assume that they have coronary disease, period. So should we screen them? Should we do stress tests? Should we do calcium score? Should we do beta stress? And the answer is no. So treat them as if they have, you use the score 2B diabetes. If they're high risk, use the algorithm for the management. If they're low risk, use the other algorithm. If they're asymptomatic, you don't need to screen them. Even though I see this very common, we do that, and especially in private practices, But that's real world, but I'm talking about evidence-based. This is evidence-based. So GLP-1 and heart failure, I think I'm going to share with you the trial of Summit, which was released, just 10 seconds and I'm done. Because this is a very interesting subject, and Dr. Najah talked about NASH and everything else. Summit was just released 4 days ago, in which also they've used the tirzepatide for heart failure, and this was a positive trial. What I want to allude to you is that 50% of these patients with heart failure were diabetics. They have normal ejection fraction. So it improved the outcome of heart failure. It also decreased the inflammatory markers, the CRP, by 38%. So with this, I'll leave you with a summary. So the interaction between cardiovascular disease and type 2 diabetes, as you've seen, is extremely complex. Priority is early detection and prevention of the complications. Patient and community education is crucial for a scalable, better outcome. It's not enough that you do a better job. It has to be a scalable, better outcome. Science is developing very rapidly, and one must be updated regarding the latest developments as one of these meetings. Diabetes is for sure a multi-specialty disorder that requires an integrated approach to achieve the best possible results. And thank you again for having me and your attention.
Thank you so much for your excellent talk. I think we will do questions as the audience approach you later.
Bilal, if you want to do a question now, because I'm sorry I have to leave.
And I think we'll just move on to the next one. Thank you so much.
Thank you.
Thank you. Now we are welcoming Dr. Khalid bin Thani. He's going to talk about heart failure and diabetes. Dr. Khalid is a consultant physician, cardiovascular medicine, Department of Cardiology, Salmania Medical Complex. He is an assistant professor of medicine, Arabian Gulf University, Manama. And Dr. Khalid, the floor is yours.
Okay, so we should keep this one here. Okay, and the slides. Where is the slides? Okay, and there you go. Okay. Good evening, everybody. I hope I will be fast, quick. Okay, they gave me the task to talk about heart failure and diabetes, and I'm gonna roll the ball in the other way. I am a cardiologist, but I'm gonna go to the field of diabetology. So I hope you enjoy it. I'm gonna be to the point. I know it's the end of the day, so wake up with me. So this is my disclosure. I'm not I'm not a diabetologist. So we had enough since the morning regarding scaring everybody regarding diabetes. And I have only one slide to scare you. In heart failure, 97.5% patients have comorbidities, and 44% of patients hospitalized for chronic heart failure have diabetes. So yeah, تقريبا 50%. And these numbers are not far away from our numbers here in Bahrain, by the way. Okay? Now, I'm going to go directly to the management of cardiovascular disease in patients with type 2 diabetes. And I think Dr. Hussam, he alluded and he showed you some of the slides regarding the management of cardiovascular disease. He spoke about bits and pieces from cardiovascular disease, heart failure, and there are so many cardiac disease. And this session, we're going to talk about also, I think, hyperlipidemia, and also we're going to talk about hypertension with Dr. Sayyid Rida and Dr. Nasreen. So patients with diabetes have a higher incidence rate of heart failure. And DM accelerates the time to first cardiovascular event. So basically, if you have diabetes, you're going to have, a worse outcome if you don't take care of your diabetes. I do disagree. Maybe Dr. Hussam, he showed that screening and the play of screening. And I know in the primary care physicians, they do a yearly ECG. So I would highly recommend that you do at least a yearly ECG for your patient if they are diabetic coming to the NCD clinic. So when they showed up, at least per year, just do an ECG, because some of them, they're going to be asymptomatic, and they are harboring cardiovascular disease.
So, patient with diabetes at risk of heart failure, they should have a systemic survey for heart failure symptoms and or signs of heart failure as recommended at each clinical encounter on all patients with diabetes. So you have to ask them, and you have to double check and make sure. Symptoms and or signs of heart failure, you should include ECG in your assessment of these patients. This is the minimum that you can do for patients coming at least yearly. If heart failure is suspected, it's recommended to measure the proBNP, and this is according to the guidelines. I'm going to show you the guidelines here. I'm not going to show you like major trials, okay, to make it easy for you. And this is the recommendation for the EC guidelines, ECG, and then if you have signs and symptoms of heart failure, do the echo, chest radiograph, and you can do the routine blood test, including the iron studies and also proBNP, especially in patients with heart failure. Here, the glucose-lowering treatment of patients with heart failure and type 2 diabetes. Now, it's a big game, and we are playing it together. Cardiovascular, nephrologist, and also diabetologist. And by the way, there is a new player coming into play, the neurologist also. You're going to hear now the neurologists, they are coming into play with us as a cardiologist in some of the diseases. So, and all of you know the SGLT2 inhibitors, which is mainly a diabetic medicine, but it became a cardiovascular medicine and has a class 1 indication to be started for heart failure patient, independent of HbA1c. And independent of concomitant glucose lowering medication. So you can go ahead and start it and make sure about your GFR for these patients. The recommendation of heart failure treatment in patients with heart failure and reduced ejection fraction, this is the recommendation. This is class 1 to start the SGLT2 inhibitors, dapagliflozin or empagliflozin or sotagliflozin. It's not available yet. Sotagliflozin in the market, in our markets, I mean. You have the DABA heart failure, you have the Emperor Reduce and Solicit WHF, and all these trials support the usage of SGLT2 inhibitors for these patients. What about the other medicine? Yes, most of them, they are the 4 pillars. I think they spoke, I mean, you attended, I guess, at some other meetings for cardiologists. And the 4 pillars, the SGLT2 inhibitors, scopular valsartan or ACE inhibitors, beta blockers, and the MRAs. And they have a class 1 indication to be started for these patients. Heart failure and diabetes. What about recommendation for heart failure treatment with reduced ejection fraction? An intensive strategy of early initiation and also rapid titration based on frequent visit to the heart failure clinic. So you have to titrate the medicine, you have to titrate your medication. It's been shown with the strong HF trial and the primary endpoint suggests that you have to titrate and up-titrate the medication as per the patient tolerance. What about patients with ejection fraction more than 40, which is the mid-range and also the preserved ejection fraction? SGLT2, empagliflozin and dapagliflozin, got the class 1 recommendation for these patients to be started. So go ahead, don't be afraid from starting it for patients with mid-range and also preserved ejection fraction heart failure. And this has been shown by Emperor, Preserve, and the Deliver study for the DABA. What about glucose-lowering treatment of patients with heart failure and type 2 diabetes? Dr. Hussam, he showed you a glimpse of it, and we're going to concentrate here about heart failure and as per the guidelines. The DPP-4 inhibitors and TZDs, I think it made it easy for me with Dr. Hussam lecture that this one has a worse outcome for your patient. So if you are a cardiologist, you receive a patient coming to you in the clinic, taking one of these classes, stop it, send him back to the endocrinologist, make sure, change the medicine, adjust it, and then let him come back. And you start your own medicine, for heart failure, and you manage the patient accordingly. What about the rest of the classes? The GLP-1 is a class 2A, sitagliptin and linagliptin class 2A, and metformin as 2A, and also the insulin glargine and the long-acting glargine. Now, the ones that in the red, preferably you should not start for heart failure patient. Or if the patient develops heart failure and he is on this medicine, stop them, change them, and send the patient to the endocrinologist. So, in summary, I would call it, GLP-1 is recommended. It has a neutral effect. DPP-4 inhibitors, it has also sitagliptin, linagliptin, has a neutral effect. It's a class 2A, and also the basal insulin glargine and neutral effect. What about the metformin? As I mentioned, 2A recommendation. In terms of the other medicine, which is the piclitazone and DPP-4, saxagliptin, they have increased risk of incidence of heart failure. So try to avoid it in these patients. So it is recommended to switch glucose-lowering treatment from agent without proven cardiovascular benefit or proven safety to agent with proven cardiovascular benefit. So try to avoid. And so in summary, it's a reciprocal relationship between us and the endocrinologist. Diabetes increases the risk for heart failure. Diabetic heart failure patients are at greater risk of adverse outcome, including recurring hospitalization and death. The interaction can potentially be modified to improve the outcome. And most of the trial now from FDA recommended that patients with diabetes, any new medicine, you should look for cardiovascular outcome regardless. Metformin was started at an era they were not looking at the cardiovascular outcome. Nowadays, you have to make sure, because you want your patient to get the benefit of your intervention, I would call it. Okay, this is in the summary. So if you're primary care or like in the field of general medicine, these are the classes, and this is the recommendation basically for the diabetic medication to be started for your patient. And thank you.
Thank you so much, Dr. Khalid. Would you prefer to take questions before you leave, or should we move on?
If they have any question, yeah, why not?
I'm.
If you have question for me, even. By the way, حتى the data regarding from nephrology side, we have a lot of data now, because the patient comes with comorbidity. Tomorrow, attend another lecture regarding the multi-morbidity patient that you're going to face. And I think we're going to have the ball between us, the endocrinologist, the cardiologist, and the nephrologist. And with polypharmacy is going to be difficult. Attend the lecture, inshallah. You will enjoy it. And now I think you will hear, in the near future, the neurologist will come also with us in the team, inshallah. I hope we're going to have like some sort of like a multidisciplinary approach and taking care of multi-morbidity patient.
And I have to mention, he authored the chapter on cardiology and pregnancy in our book for women with diabetes. So thank you for your contribution.
Thank you, Doctora. Thank you.
And now we invite to the podium Dr. Nasreen Al-Sayed, who will speak to us about advances in lipid management. Dr. Al-Sayed is a consultant endocrinologist and a lipidologist, chief medical officer at Dar Al-Sahha Medical Center. She graduated from Arabian Gulf University, and she is American board certified in, she completed her residency training in internal medicine at Sinai Grace Hospital, Wayne State University in Michigan. She's also American board certified in clinical lipidology and a fellow of the American College of Physicians and American College of Endocrinologists. So we look forward to your talk, Dr. Nasreen.
Thank you very much, Dr. Dalal, for the kind introduction. And I would like to thank the organizing committee for inviting me to give this talk. I know I'm like 1 hour late from my supposedly it was supposed to be at 4:15, but I'll try to be fast. I know you're all tired by now. So this is like a dense topic. It is a lipid topic, and it is dense, and it is complicated. The field of lipidology is so complicated, and it is sort of interrelated between endocrinology, cardiology, internist, and primary care. So here we're going to talk about advances in lipid management, the new developments in lipid management. These are my disclosures. Why hyperlipidemia or dyslipidemia is very important? Because, like the cardiologists were talking about, is the risk of cardiovascular disease. it's in diabetes. We see it as a metabolic dyslipidemia and is like one of the leading factors to cardiovascular disease. So when we talk about advances in lipid management, we are talking about advances in testing and advances in treatment options. So it's not longer anymore just statin. We are not just dealing with statin when we treat dyslipidemia. So this is the typical lipid profile that you order in your daily practice. And this is what I see from the labs that I get from other hospitals is the total cholesterol. We are lucky sometimes if we have even the LDL cholesterol mentioned, and then you have the HDL and the triglyceride. But is this sufficient to really categorize your patient or do some sort of risk categorization? We know the role of LDL with the cardiovascular disease. That because the residual risk is related to other factors, which are for example, inflammatory risks such as CRP, it could be thrombotic risk, it could be even diabetes risk. So we need to achieve really tight glycemic control. So again, you can see among these risks over there that Lp(a), triglycerides, and triglyceride remnants, ApoB, are part of these risk factors. So that's why when you look at lipid profile, these are the targets that you should be looking at, not anymore only the LDL cholesterol. So when we look at the advances in lipid-lowering therapy, you need to know a little bit revision on the biochemistry and the cholesterol synthesis pathway and the cholesterol pathway as a whole. Acid sequestrants, because these are you are familiar with, and this is what you use in your daily practice. We know that statins are classified into low intensity, moderate, and high intensity based on their power in lipid lowering. So if you want to go with 50%, more than 50% reduction, you would go with a high intensity statin such as Atorva, 40 to 80 milligram, Rusuva, 20 to 40 milligram, and Simva, 80 milligrams. So these would lower your LDL cholesterol by more than 50%. Now, ezetimibe has shown, and basically it works at the level of the intestine and it prevents the cholesterol absorption, but there are positive outcomes with the ezetimibe added to statin. And we have seen that from the IMPROVE trial. The outcome was positive even after 7 years. And then you have the racing trial that showed non-inferiority. So if you combine moderate intensity statin with ezetimibe versus high intensity statin, it shows non-inferior, which means this is very good for your patients who are statin intolerant. Bile acid sequestrant, we don't use them anymore because we don't have really robust and big evidence in terms of cardiovascular outcome, but we use them. They are excellent option in children, and pregnant women, and breastfeeding, and they lower the LDL a little bit by only 12 to 20%. So what are the new agents, some of which are currently available and we are using, and others are in the pipeline. They're coming very soon. So one of them is these are the PCSK9 monoclonal antibodies. So what are these PCSK9 monoclonal antibodies? They are antibodies that are directed to the PCSK9 protein and thereby inhibit this protein synthesis, because this protein is responsible for the degradation of the LDL receptor. And if you don't have the LDL receptor, you don't have the clearance of the LDL particle. And most of you probably know there are the two common FDA-approved monoclonal antibodies that we are using, alirocumab and evolocumab, and they are actually available here in Bahrain, and you can use them as a monotherapy or as an add-on to statin, or even in statin-intolerant patients and in patients with familial hypercholesterolemia.
Significant reduction, both of them give you in the LDL cholesterol from baseline reaching up to 50%. Not only in the LDL, remember I told you have to look at your non-HDL, ApoB, and LP(a). So as you can see, significant reduction in ApoB and non-HDL reaching up to 30 to 40%. And if you look at the LP, I don't know which one is the laser. That's not working. So if you look at down there at the LP(a), these agents actually would lower your LP(a) by about 25 to 30%. And contrary to statin actually would increase your LP(a). So these agents would lower the LP(a) as well. And also, in terms of cardiovascular outcome, excellent. They met their primary endpoint in the trials for both evolocumab and alirocumab, and by decrease in composite cardiovascular endpoint by 15%. Another molecule that inhibits the PCSK9 gene, actually, and this is through the RNA interference. This is the inclisiran. So it's different from the others because the others are monoclonal antibodies. This actually interferes with the RNA and thereby inhibits the synthesis of the PCSK9 protein. Inclisiran is available also in Bahrain, and it is given as a shot subcutaneously every 6 months. And the data have shown that effective reduction in the LDL cholesterol reaching 52%, and there is a sustained over time, as you can see, over 500 days, a sustained reduction in the LDL cholesterol. These are excellent options for patients with statin intolerance, but of course they are very, very expensive. A shot of inclisiran is about more than 1,000 BD. You can see inclisiran also very nice changes in the non-HDL and ApoB. So you have very beautiful reduction in the ApoB and non-HDL. Coming in the pipeline, we have oral PCSK9 will be available, and in the clinical trials, the LDL reduction was more or less similar to the monoclonal antibodies. Another agent is the bempedoic acid. Bempedoic acid is not available yet in Bahrain or even in the Gulf. It's becoming very popular in Europe. I prescribe it to my patients. They get it from Europe mainly. It's available in UK and France. And bempedoic acid, it works a step before the statin. So the statins inhibit the HMG-CoA reductase. They actually inhibit the ATP citrate lyase, so at the beginning of the cholesterol synthesis. Now, the good thing about bempedoic acid that it won't cause increase in the glucose level compared to statin. We know that the statin, they carry the risk of a little bit increasing the risk of diabetes by 10 to 15%, but in contrary, bempedoic acid doesn't do that. We don't know exactly how. And it has lower side effects of muscle side effects, such as the myalgias that we see with the statin. And it reduces CRP significantly. But its power on the LDL is not as effective as statins. It lowers your LDL by 23%, but reasonable lowering in the non-HDL and ApoB. Was there any outcome trial on the bempedoic acid? Yes, the CLEAR outcome trial showed that it reduced a 4-point MACE by 23%. So there is a positive cardiovascular outcome with bempedoic acid. Now, in terms of another agent, is called lomitapide. Lomitapide actually works at different level in the liver and in the intestine, and it inhibits a microsomal triglyceride transfer protein that transfers usually the triglycerides to ApoB. So thereby, it lowers your ApoB and all the cholesterol-containing ApoB molecules. Significant reduction in LDL, non-HDL, and it is used primarily in familial hypercholesterolemia. Another agent called ANGPTL3 inhibitors, they actually by inhibiting this molecule, you are facilitating the effect of the LPA lipoprotein lipase and thereby degradation of the VLDL molecule. This is given as IV infusion once a month. It can be given for adults and children, and it is available in Bahrain but by order, and we are giving it for extreme cases of high triglyceride and high cholesterol level. It lowers the triglyceride by 60%, lowers the non-HDL by 34%. CATP inhibitors, another agents, they are coming soon. They are not available yet, but CATP actually inhibits the transfer, the cholesterol transfer from the actually the HDL to the LDL, and thereby increasing the HDL level and lowering the LDL level. All the CATP inhibitor trials have failed, except the new one, which is obicetrapib, is the promising agent, and there are many trials going on for the obicetrapib. It's an oral medication given on daily basis. There is the Broadway trial, Brooklyn trial, Prevail trial, which is cardiovascular outcome trial, and there are trials in addition to ezetimibe. You can see how this agent lowers, it comes in 5 milligram, 10 milligram, and it lowers your LDL by 40 to 50%, actually better than statin. They lower even your ApoB and non-HDL way better than statin, like 44% and 30%, and lowering the triglyceride and significant lowering in the Lp(a) molecule. The Prevail trial for the obicetrapib, which is the cardiovascular outcome trial, is going to be out probably by end of next year, and this will show us if this agent has a positive cardiovascular outcome similar to the PCSK9 inhibitors and statins. Now we come to the Lp(a) directed therapies. There are agents. So I told you that statin would actually increase your Lp(a). The PCSK9 inhibitors may lower your Lp(a). The CATP inhibitors would lower your Lp(a). But these agents are far more effective in lowering the Lp(a), such as pelacarsen. Pelacarsen is coming soon. By next year, hopefully, we will get the FDA approval. Again, it works on the RNA gene over there, so it inhibits the synthesis at the level of the Lp(a) gene, so it inhibits the synthesis of the Lp(a). So it lowers the Lp(a) by about 70%. That is a significant drop. And I am actually currently detecting in my clinic clusters of families in Bahrain with high Lp(a), and they are at extreme risk of cardiovascular disease. Some of these families are having premature cardiovascular deaths in the family, and they don't know that they have high Lp(a) protein. So this is going to be a very promising agent for them. We have oral forms of these inhibitors as well. Now we come finally to gene therapy, and this is really fascinating in the field of lipidology, because now there are targeted gene therapy. You could target the gene LDL receptor, you could target the PCSK9, ApoA, all the genetic abnormalities in lipid metabolism. This is one of the genes, it's called VERV101. So in the clinical trials, there were very few participants in this trial, and the reduction was significant in the PCSK9. So they went actually and they knocked down the PCSK9 gene, and look at the it was sustained over 6 months. So the patient was free of medication, just one shot, and the patient was free of medication for 6 months without any need for medication. And the lipid, the LDL cholesterol remained really low. And recent data actually showed that the extension of the study showed another 4 months of sustained lowering of the LDL cholesterol. So finally, we can see that the evolution of lipid-lowering therapy. This was, I know most of these agents are not available for you in clinical practice, but it is good to know that the field of lipidology is evolving. Very soon, after a couple of years, you will no longer have the option only for using statins. You will be using these new agents. So we started with statins and combination with ezetimibe. We were just talking about LDL cholesterol. Then we moved to the monoclonal antibodies. We talked about the non-HDL. Our target changed from LDL to non-HDL. Now we're talking about RNA silencing, such as the inclisiran. We went to the vaccine. We went to gene editing. So we are really moving forward in the field of lipidology. And with that, before I conclude, I'm actually a member of the International Atherosclerosis Society, the Africa and Middle East region, and we are delighted to invite you for our 20th Congress. It's a big congress in the field of metabolic disorders, lipidology, and cardiovascular disease, which will be held, inshallah, in Oman in December. And you're most welcome to go and visit the website and register for this fascinating congress. Thank you very much for your attention.
Thank you, Dr. Nasreen, for always great presentation. And our last speaker for this session, last but not least, Dr. Sayed Raza. He will talk to us about hypertension targets and control. Dr. Raza is a consultant cardiologist and head of the Department of Medicine at Awali Hospital. He is the Regional Educational Coordinator and Examiner for MRCP exam at the Royal College of Physicians of Edinburgh. He's certified educational and clinical supervisor in the NHS, and he is American board certified in medical quality and is involved in patient safety initiatives at our center. So Dr. Sayed, the floor is yours.
Thank you very much, Dr. Dalal, for the introduction and for the kind invitation. And I am thankful for the organizers for having me here. So I would like to begin by asking a question, and this is, you will see, it's not a very difficult question, and not even a medical school level question, as to what is the normal blood pressure. Now, I don't want any answers, but I'm just trying to highlight that how difficult it is sometimes, even for us healthcare professionals, to answer this simple question. And it is primarily because we scratch our head and ask that which guidelines are we going to follow as to what the normal cutoff or the threshold for the normal blood pressure will be. Now, some of you will remember that in 2017, American College of Cardiology and American Heart Association, they came up with this guideline of hypertension, and they had different thresholds for normal blood pressure, hypertension, and elevated blood pressure. And with that, overnight, millions of patients who were normotensive became hypertensive. Now, very recently, European counterpart has also come up with a similar guideline where they have included elevated blood pressure with these target blood pressure, both for systolic and diastolic, and for the hypertension, it remains the same. Now, the next question is, what should be the target blood pressure? And again, you may ask, which guidelines are you talking about? And under which category of patients with what comorbidities and which population? So I hope in the next 20 minutes or so, we can reach a consensus as to what the target blood pressure is going to be in diabetes mellitus. And we will see if lower is better and how low we can reduce the blood pressure in diabetes population. I will be discussing few trials that will probably give some evidence to support the outcome on reaching the target blood pressure. And I would also include what would be the choice of antihypertensive medications, particularly in diabetic population. So we all know that hypertension and diabetes They go hand in hand, and we call it like a brother and sister. They are very common comorbidities to increase the cardiovascular risk. But the question is why blood pressure should have a lower threshold in diabetes mellitus. And now we all know that diabetes is a chronic disease, and long-standing diabetes, particularly if it is not well controlled, it would lead to microvascular and macrovascular complications. And hypertension does share a similar pathogenesis, like endothelial dysfunction, vascular inflammation, vascular fibrosis, arterial remodeling. And with this common sharing of pathogenesis, it does increase the risk of microvascular and macrovascular complications. Similarly, sharing the same pathogenesis, they also increase the risk of kidney diseases. Now, I'll start with the first trial to discuss today. It's ACCORD blood pressure trial. This was published in 2010, and essentially it was looking at effects of intensively reducing the blood pressure in type 2 diabetes mellitus patients. It studied more than 4,000 patients, and in one arm, the patients had an intensive control, meaning thereby the systolic blood pressure was reduced by more than or less than, I would say, at 120 millimeters of mercury. And the other arm was the conventional blood pressure control arm, where the blood pressure was reduced by below 140 millimeters systolic. Patients were followed up for 5 years, and as you can see in the result, the primary outcome, which was a 3-point MACE, as usual, non-fatal MI, non-fatal stroke, and cardiovascular mortality did not change much in either arm. The first secondary outcome, which was the non-fatal MI, again did not show any statistical benefit in favor of the intensive blood pressure arm, but the stroke did reduce in favor of the patients whose systolic blood pressure was aggressively controlled and systolic blood pressure was reduced below 120 millimeters of mercury. So this is the summary of the ACCORD results, which obviously showed that there was no statistical difference in the primary outcome between the two arms. And no surprise, the patients who were treated intensively did have a lower blood pressure, but at the same time, these patients also suffered a number of adverse effects, which are shown here, which were like falls, hypotension, worsening renal function, hyperkalemia, and so on. But it did cut the risk of stroke by 40%. So that is something impressive. The blood pressure reduction, particularly if you reduce systolic blood pressure aggressively in hypertensive population, then you may cut down the stroke risk significantly. Now, this is a paper that was published in Circulation in 2011, and this was a meta-analysis of randomized trials. And this took into account two different thresholds of lower blood pressure than normal, less than 135 millimeters of mercury and less than 130 millimeters of mercury in diabetic population. And we go straight to the results, and as you can see that when the blood pressure is reduced to less than 135 millimeters of mercury, there is some improvement in terms of the outcome, clinical outcome, like all-cause mortality and cardiovascular mortality. But if you reduce the blood pressure a bit more, less than 130 millimeters of mercury, then you do not see that benefit. Similarly, for myocardial infarction and heart failure, if you reduce the blood pressure a little bit, less than 135, you see some benefit. If you reduce it too much, then that benefit is not there. But overall, there was no statistical significant benefit in favor of either population group. But stroke, if you see that the systolic blood pressure here was reduced less than 130 millimeters of mercury, and there was indeed a benefit in favor of those patients who had aggressive reduction in their systolic blood pressure, and the p-value was highly statistically significant. Now, SPRINT trial was published in 2015, and here more than 9,000 patients were studied, more than 50 years. They were hypertensive, systolic blood pressure more than 130 millimeters of mercury. They had presence of either established cardiovascular disease or at least one cardiovascular risk and CKD. But you will note that this study did not include diabetics. So this was in a non-diabetic population. And the goal of the trial was just to see if there was safety and as well as efficacy if the systolic blood pressure was reduced below 120 millimeters of mercury compared to the usual or routine management of less than 140 millimeters of mercury. And straight to the results, surprisingly, this trial did show that there was improvement in the outcome, primary outcomes such as acute coronary syndrome that included myocardial infarction, congestive cardiac failure, cardiovascular death, were all reduced much better in the arm that reduced the systolic blood pressure less than 120 millimeters of mercury. And just to tell you that this was the trial following which the American College of Cardiology and American Heart Association, they came up with the guidelines where the threshold for the blood pressure was reduced, and they came up with a new threshold for normotensive and hypertensive and elevated blood pressure. Now this is advanced trial that was published in 2019, and essentially this was trying to see a combination of medicines, which is perindopril, which you all know is ACE inhibitor, and a diuretic, indapamide, a combination treatment to see in patients of diabetes whether this would reduce the incidence of macrovascular and microvascular outcomes. So they were type 2 diabetic patients, and they were above 55 years old, and also they had one of these additional risk for vascular event. In addition, if you would look, that they also included normotensive individuals, and in this trial, at least 30% of the individuals did not have high blood pressure. So this is a unique trial where non-hypertensive patients were also included, but they were diabetic. And they used in a small dose indapamide and perindopril for 3 months, and this dose was up-titrated following 3 months. And again, not a surprise that there was average blood pressure, systolic and diastolic, were reduced in the arm that used perindopril and indapamide and compared to the placebo. But compared to the placebo, it did show a remarkable cardiovascular outcome benefits, such as reduction in microvascular and macrovascular complications. Cardiovascular events were less, cerebrovascular events were less, renal events were less, all favoring the use of perindopril and indapamide. Now, the take-home message from this is that this study basically showed that if you give this kind of medication to diabetic patients who are not hypertensive, so we may include this in our clinical practice if the patients have got near normal blood pressure or upper normal blood pressure, and where we may use these medications in order to prevent cardiovascular complications. Now, this is not a meta-analysis, it's a systematic review of several meta-analysis and 45 randomized control trials. And this was a Korean study, a Korean group conducted the study, or a systematic review, I would say. And they summarized the data amongst more than 2 million patients, Korean patients. This study was done, or meta-analysis or the systematic review was done in Korea. More than 2 million data set they reviewed, and then they came up with a summary, and the summary was that a target blood pressure of less than 140 by 90 millimeters of mercury is recommended for patients with hypertension and diabetes mellitus. And if these patients had established atherosclerotic cardiovascular disease or 10 years risk of atherosclerotic cardiovascular disease, which was more than 15%, then they should have a blood pressure of less than 130 by 80 millimeters of mercury. And following this, this was published in 2022, and following this, the American Diabetes Association came up with the guideline, a similar guideline, where they adopted, as you can see here, it has been put in a very simple manner that if the patients are diabetic with high blood pressure, then the threshold for systolic is less than 140, and for diastolic blood pressure less than 90 millimeters of mercury. But if these patients have got high cardiovascular risk, which means if they have got established atherosclerotic cardiovascular disease, or their 10-year risk for atherosclerotic cardiovascular disease is more than 15%, then they should aim for a systolic blood pressure of less than 130 and a diastolic blood pressure of less than 80 millimeters of mercury. And also, if these patients got left ventricular hypertrophy, heart failure, stage 3, 4, 5, chronic kidney disease, aortic disease, and so on, then they also should aim for reducing the blood pressure by below 130 by 80 millimeters of mercury. They also came up with a nice algorithm of use of medications. So if the initial blood pressure in this diabetic population is more than 130 by 90, or sorry, more than 130 by 80, then you start with one agent. And if these patients have got presence of albuminuria or underlying coronary artery disease, then you should choose ACE inhibitor as the first-line treatment. If ACE inhibitor is for any reason contraindicated or not tolerated by the patient, then you may use ARB. Now, how about if the patient has got initial blood pressure which is more than 150 by 90 millimeters of mercury? In this situation, there are several guidelines, and not only the ADA that has come up with this guideline that you should start with 2 agents, and preferably it should be combined 2 agents together. Now, if these patients have got albuminuria or established underlying coronary artery disease, then certainly you should start with ACE inhibitor. For any reason, if the ACE inhibitor is not tolerated or it is contraindicated, then you may use ARB. And if the blood pressure is not controlled, then use calcium channel blocker, use diuretic. Now, we all know that medicine has advanced, and certainly we must not be stuck with the conventional way of treating blood pressure. And just to give you some examples, if you have a patient of diabetes who is hypertensive, but also has got underlying chronic kidney disease and albuminuria, then you should choose a novel agent like SGLT2 inhibitors. Similarly, if the patient is hypertensive and has got underlying heart failure, then you should choose a medication we know for a number of years now used in heart failure is ARNI, which is a combination of sacubitril and valsartan. And there are situations where you can use MRAs in certain groups of patients, particularly in chronic kidney disease. Now, this is something very recent. As you can see, the date here is just published on the 16th of November, which is just 4 days ago. And the result of this trial, which is a BP road trial, this was announced in the American Heart Association conference that is still taking place in Chicago. Today is the last day of the conference. And this was announced on day 1. And this was actually a Chinese study. And this study was done in type 2 diabetes population, and more than 12,000 patients at 145 sites in China. They were studied, and they looked at if we reduced the blood pressure intensively, which means that if the systolic blood pressure was reduced by more than or less than, I would say, 120 millimeters of mercury, compared to patients who had the normal or usual control, conventional way of controlling systolic blood pressure less than 140, would that make a difference? Now, if you will recall, in the beginning of my talk, I discussed about the SPRINT trial. So how this is different from the SPRINT trial? So SPRINT trial did not include any diabetic population, but the objective of the study was very similar. They were looking at intensive reduction of systolic blood pressure less than 120 millimeters of mercury. And here this was a diabetic population, and they were going to see if you reduce the systolic blood pressure intensively, reduce it by more than or less than 120 millimeter of mercury, whether you get a positive outcome or not. And this trial was a positive trial, and it showed that there was a positive outcome in terms of cardiovascular morbidity and mortality. Now, very quickly, I would like to answer this question. And is there a systolic blood pressure level below which there is a significant potential for harm? So some of the trials, as I showed earlier, that if we did bring the blood pressure quite aggressively, lowered it to about 120, 110, then the patient may come at harm. So this answer comes from the INVEST trial, and it is a diabetes and coronary artery disease sub-study, and this very clearly demonstrated that in patients of diabetes, but just mind you, these are the established cardiovascular disease or coronary artery disease. If you have got a diabetic patient and has got underlying coronary artery disease, then you must be careful if you drop your systolic blood pressure quite aggressively. And particularly if the systolic blood pressure is dropped below 110 millimeters of mercury, then these patients may have adverse effect. And this study did show that there was increase in adjusted risk of all-cause mortality. Now, how about the diastolic blood pressure target? So HOT study was the only trial that studied this, and it was the largest trial that addressed the question whether reducing the diastolic blood pressure in hypertensive individuals would have any positive cardiovascular outcome. Now, if you look at, there were not many diabetic patients here. It was about 8% of the total population of 18,000 that was studied. And they grouped the study population into 3 groups where the diastolic blood pressure was less than 90 millimeters of mercury, less than 85 millimeters, and less than 80 millimeters of mercury. They used felodipine versus placebo. And the end result was that it did not show a significant improvement in morbidity or mortality. But there was a subgroup analysis that was done later, and that did indeed show that there was some improvement or benefit in favor of patients who had reduction in their diastolic blood pressure as well, below 80 millimeters of mercury. Now, there were another 2 randomized controlled trials I'm not discussing here in sake of time. And these 2 trials also showed that reducing the diastolic blood pressure below 80 millimeters of mercury versus between 80 and 90 millimeters of mercury did decrease the risk of major cardiovascular events. So now we are talking about the target blood pressure. Now, American College Cardiology and American Heart Association has come up with these target blood pressures in different comorbidities, and as you can see, the diabetes mellitus, it clearly highlights that it should be less than 130 and 80. Now you may ask, how is it different from the American Diabetes Association guideline? Now, the American Diabetes Association guideline is a little different, that it still says if you have a diabetic patient who has hypertension, then the cutoff is 140 by 90, should be less than 140 by 90, yeah? But if they have got high cardiovascular risk feature, if they have got established cardiovascular disease, then only reduce below 130 by 80. So that's the difference. So just the last 2 slides before I finish. Now, we have now gone through a number of trials. I've talked about giving you data and so on and so forth. But at the end of the day, what I believe is important is we look at patients as a whole. And one patient is different from the other. They have got different comorbidities. One factor is not considered very well here is the age. We all know that the elderly population do not tolerate blood pressure reduction quite well, particularly if they are dehydrated, if they are on drugs like Lasix or diuretics. So these are the things that you'll need to keep in mind. You'll need to look at what other drugs these patients are on, and also how fragile or frail they are, if they had risk of postural hypertension, if they're dizzy, and so on and so forth, and also the underlying coronary artery disease, which I discussed in one of the trials. So these are the factors that you have got to keep in mind, and then take the decision whether you're going to reduce the blood pressure aggressively in these patients or not. So just don't go by guidelines. Sometimes we've got to use these clinical judgments as clinicians. And finally, this is my final slide in last 30 seconds, that irrespective of whatever I have talked today, we have given the numbers and everything looks good, that there will be improvement in cardiovascular mortality and blah, blah, blah. But the take-home message, this is the only take-home message from my slide, during the last slide, is irrespective of whatever we do, how much money the pharmaceutical companies they spend on these, the antihypertensive medication and so on. But the basic thing is that we must measure our blood pressure correctly. And I, in my clinic, do not rely on anybody's blood pressure until I've checked it myself. So it is extremely, extremely important. Very basic skill, not very difficult to learn, but if you do not do it correctly yourself, if you do not let others do it correctly, and if you do not watch if the blood pressure is taken correctly, then everything is meaningless. So last home message is, please, please, please ensure these basic skills that the blood pressure measurement techniques are correct. So with that, I thank you very much. And if there's any question, I would be ready to take. Thank you.
Thank you, Dr. Sayed. And Bahrain Diabetes Society has been conducting MMM, or May Measurement Month campaign, for the past 2 years. We've screened thousands of people. We train the volunteers how to measure blood pressure correctly, leg straight, arm down, etc. So we'll be letting you know the data of the analysis of those soon. I wonder if we have any pressing questions for our esteemed speaker. I think the ones who deserve a round of applause are our audience, who stayed till the last lecture of day 1. So thank you very much for all of those who stayed. It's an award for Dr. Sayed. We take a photo, and this will conclude successfully day 1. And we look forward to seeing you tomorrow at 8:30 in the morning, sharp, ready, and good to go. Thank you.
Thank you. Thank you so much.